Fossa, pectoral fossa. It is the deep fossa covering the anterior aspect of the pectoralis major muscle. It is thin and anchored firmly to the muscle by numerous fascicles. Extent superiorly, it attaches to the clavicle. Inferiorly, it is continuous with the fossa of the anterior abdominal wall. Superior-laterally, it passes from the deltopectoral groove to become continuous with the fascial covering of the deltoid muscle. Inferiorly, it covers the round in the interlateral border of the pectoralis major and becomes continuous with the axillary fossa. The axillary fossa is a dense fibrous sheath that extends across the base of axilla. Clavipectoral fossa. The clavipectoral fossa is a strong fossa sheath deep to the clavicle head of the pectoralis major muscle, filling the space between the clavicle and the pectoralis minor muscle. Clavipectoral fossa. Clavipectoral fossa is a strong fossa sheath deep to the clavicle head of the pectoralis major muscle, filling the space between the clavicle and the pectoralis major muscle. So, inversing layer of the deep cervical fossa, clavicle, supraclavicular muscle, pectoralis fossa, pectoralis minor, pectoralis major, clavipectoral fossa, superior sensory ligament of axilla, coracoclavicular ligament, coracoprocess, acrobrachialis, and short head of the brachialis, short head of the biceps brachii, clavipectoral fossa, and costoclavicular ligament. Costoclavicular ligament, first rib, clavicle, and subclavius. Extent. Vertically, it extends from the clavicle above the axillary fossa below. The upper part splits into two laminae and encloses the subclavian membrane. The posterior lamina becomes continuous with the investing layer of the deep cervical fossa and gets fused with axillary sheath. The anterior lamina gets attached to the clavicle. Its lower part splits to enclose the pectoralis minor muscle. Below this muscle, it extends downward as the subsensory ligament of axilla, which is attached to the dome of the axillary fossa. The suspensory ligament keeps the dome of the axillary fossa pulled up, thus maintaining the concave of the axilla. Medially, clavipectoral fossa is attached to the first rib and costoclavicular ligament and bends with the external intercostal membrane of the upper two intercostal spaces. Laterally, it is attached to the coracoid process and bends in the coracoclavicular ligament. The thick upper part of the fossa extends from the first rib near the costoclavicular joint to the coracoid process is called the costochoroid ligament. The clavipectoral fossa encloses two muscles, subclavius and pectoralis minor, structures piercing the clavipectoral fossa. These are as follows: lateral pectoral nerve, thoracoacromial artery, acromiothoracic artery, lymphatic from the breast to the apical group of the axillary lymph node. Structures of clavipectoral fossa. Cephalic vein, the first two structures pass outward, whereas the last two structures pass inward. Mnemonic clap, subclavian vein, lymphatics, and acromial artery and pectoral nerve. And then the breast or mammary gland. The breast or mammary gland is the most important structure present in the pectoral region. It is a midfield acromial sweat gland present in the superficial fossa of the pectoral region. The breast is found in both male and female. However, it remains rudimentary in male throughout life but develops in female at puberty to form the hemispheric bulge. On rare occasions, the breast male becomes enlarged. In this condition known as gynecomastia. Gynecomastia. In females, it forms a accessory sex organ to the female reproductive system and produces milk to the newborn baby. Primary purpose of the breast female is to nourish infants. The anatomy of the breast is of great surgical importance and therefore needs to be studied in detail. The adult female breast is described in the following Text. Location. The breast is located on the superficial fossa of the pectoral region atop of the pectoralis major, pec, chest muscle. A small incision of the breast from the suprapectoral part axillary of the spans pierces the deep fossa and extends to the axilla. The aperture in the deep fossa through which axillary tails pass into the axillary is called the foramen of Langer. The axillary tail is the site of a high percentage of breast tumor. Shape and extent. Location. The breast is located in the superficial fossa of the pectoral region, sitting top of the pectoralis major, pec muscle. A small extension of the breast tissue form its supralateral part. Axillary tail of spans pierces the deep fossa and extends into the axilla. The aperture in the deep fossa through the axillary tail passes into the axilla is called the foramen of Langer. The aperture of the deep fossa through which axillary tail passes into the axilla is called the foramen of Langer. The axillary tail is the site of high percentage of breast tumor. Axillary tail. Shape and extent. Shape. Hemispherical bulge. Extend vertically. It extends from the second rib to the sixth rib. It extends from the second rib to the sixth rib. Horizontally, it extends from the lateral border of the sternum to the maxillary line. Lateral border of the sternum to the maxillary line. So the axillary tail of spans, foramen of Langer, breast, nipple, and areola. Despite individual variations of size of breast, the extent of its breast base remains firmly constant. For example, from the sternal edge to the metaxillary line, from the second to sixth ribs. Relations. The deep aspect of breast is related. The deep aspect of breast is related to the following structures from superficial to deep. Pectoral fossa. The deep fossa covering the anterior aspect of the pectoralis major and the three muscles pectoralis major, serratus anterior and external oblique. Serratus anterior and external oblique. Note 12. So the deep aspect of the breast is related to the following structures of the superficial to deep. Pectoral fossa, the deep fossa covering the anterior aspect of the pectoralis major and three muscles. Relations. Pectoralis major, serratus anterior and external oblique. So pectoralis major and then serratus anterior and then external oblique. Note 12. The breast is separated from the pectoral fossa by a space, retromammillary space. The breast separated from the pectoral fossa by retromammillary space, which is filled with loose areolar tissue. Due to the presence of loose areolar tissue deep in the breast can be moved freely up and down and from side to side over the pectoral fossa. Retromammary space and then pectoral fossa, retromammary space, and then pectoral fossa, and then pectoralis major, and then breast, areola, nipple, and then clavicle, subclavius, and pectoralis minor and chest wall. Structure. The breast consists of the following three components: skin, stroma, parenchyma, glandular tissue, and mammary gland. Proper. Skin. It is the covering of the breast and presents the following structures. Nipple. It is a conical projection below the center of the breast, usually at the level of the fourth intercostal space. It contains smooth muscle fibers which can make the nipple stiff and erect or flatten it, being richly innervated by sensory nerve endings. The nipple is the most sensitive part of the breast to tactile stimulation and become erected during sexual arousal. Structure. The breast contains the following three components: skin, stroma, and parenchyma, glandular tissue, mammary gland. Proper. Skin. It is the covering of the breast and presents the following features. Nipple. It is a conical projection below the center of the breast. Nipple. Usually at the level of the fourth intercostal space. It contains smooth muscle fibers which can make which can snip and erect and flatten it.
when richly innervated by sensory endings. Areola. It is the circular area of pigmented skin surrounding the base of the nipple. It is the circular area of the pigment skin surrounding the base of the nipple. It contains a large number of modified subascaous glands, particularly at its outer margin. The glands produce oily secretions which lubricate the nipple of the areola and thus prevent from the drying and cracking. The color of the areola and the nipple varies with the complexion of the woman. During pregnancy, the areola becomes darker and enlarged. Pregnancy, the areola becomes darker and enlarged. The sebaceous gland in the areola are enlarged during pregnancy and prepare as small nodular elevations called Montgomery's tubercles. And during pregnancy and appear as small nodal elevations called Montgomery's tubercle. Stroma. The stroma of the breast consists of connective tissue and fat. It forms the supporting frame of the breast. The connective tissue. The sebaceous gland in areola are enlarged during pregnancy and appears as small nodal elevations called Montgomery's tubercles. Stroma. The stroma of the breast consists of connective tissue and fat. It forms the supporting framework of the breast. Stroma. The connective tissue condenses to form a fibrous strand receptor called suspensory ligament of Cooper. The connective tissue condenses on the fibrous receptor called suspensory ligament of Cooper. The suspensory ligament of Cooper are arranged in a radial fashion. They connect the dermis of the overlying skin to the duct of the breast and pectoral fossa. The ligament of the Cooper maintain the protuberance of the breast. Their atrophy due to aging makes the breast pendulous in old age. Their atrophy due to aging makes the breast pendulous in old age. The fat forms the most of the bulk of the breast. It is distributed all over the breast except beneath the areola and the nipple. Parenchyma. So this was the stroma. Parenchyma. The parenchyma gland arrives tissue of the breast secretes milk to feed the newborn baby. It consists of about 15 to 20 lobes arranged in a radial fashion, 15 to 20 lobes. The spokes of wheel and converge towards the nipple. Each lobe is divided into lobes that consist of cluster of acne. Each lobe is drained by a lactiferous duct. The ducts from different lobes converge towards the nipple and open its summit. Near its termination, each duct expands into a lactiferous sinus that serves as a reservoir of milk during lactation. Fat acne lobules, lactiferous sinus, and then areola, nipple, lactiferous duct. Structures of the lobe of the mammary gland. Male breast resembles a rudimentary female breast. It is devoid of lobes and lobules. It is a small nipple and areola lie over the fourth intercostal space. Arterial supply. The breast is highly vascular. It is supplied by the following arteries: internal thoracic artery, mammary artery through the perforation branches which pierce the second, third and the fourth intercostal space. So internal thoracic artery which perform branches which pierce the second, third and the fourth intercostal space. Lateral thoracic artery, branch of the axillary artery and posterior intercostal arteries. Through their lateral branches, pectoral branch of the thoracoacromial artery and superior thoracic artery. So internal thoracic artery, lateral thoracic artery, internal thoracic artery, lateral internal thoracic artery, as can be seen in here, then lateral thoracic artery, and then posterior intercostal arteries. Lateral branch of the intercostal arteries. Lateral thoracic artery, internal thoracic artery, lateral thoracic artery, and then posterior intercostal arteries. Posterior intercostal arteries. And then pectoral branch of the thoracic artery, thoracoacromial artery, thoracoacromiothoracal artery, and then superior branch of the artery. Blood supply of the breast is mainly derived from the lateral thoracic artery. Venous drainage. Venous drainage of the breast takes place by the following veins: axillary vein, interthoracic vein, and posterior intercostal veins. The veins follow the arteries. First, they converge towards the base of the nipple, where they form an anastomotic venous circle, venous plexus of the halar. From there, they run into the superficial and deep sacs. The veins follow the arteries. First, they converge towards the base of the nipple, where they form an anastomotic venous circle and venous plexus of halar. From there, they run into the superficial and deep sacs. The superficial veins drain into the internal thoracic vein. The deep veins drain into the internal thoracic axillary and posterior intercostal veins. Apart from lymph vessels, the cancer breast can also spread through segment veins. Here, it is important to know that veins drain the breast communicates with vertebral venous plexus. Clinical correlation: metastasis of breast cancer to the brain. It occurs through the following group: cancer cells from the breast, posterior intercostal veins, and then vertebral venous plexus, intracranial dural venous sinus, and then brain. Nerve supply. The nerve supply of the breast is primarily somatosensory. It is derived from the second and the seventh intercostal nerves through their anterior and lateral cutaneous branch. It is derived from the second and the sixth intercostal nerves through their anterior and lateral cutaneous branch. These nerves provide sensory innervation of the skin and carry anastomotic fibers to the smooth muscle and blood vessels of the breasts. The sensory nerve endings of the nipple and the areola make an important role in stimulating the release of milk from the mammary gland to response to suckling by the infant. Note well, the secretion of milk from the breast is not under neural control but is enabled by the prolactin hormone secreted by the pituitary gland. Lymphatic drainage. The knowledge of the lymphatic drainage of the breast is great significance to the surgeon because the carcinoma of the breast spreads mostly through the lymphatics. For better understanding lymph nodes and lymphatics during draining the breasts are described in detail in the following text. Lymphatic drains of the breasts. The lymph from the breasts is drained into the following group of lymph nodes. Axillary lymph node lying in the axillary and divided into 5 groups: anterior, pectoral, posterior, central, lateral, and apical details. So axillary lymph nodes, and then internal mammillary nodes lying along the neutral thoracic vessels, lying along the internal thoracic vessels, internal mammary gland. Supraclavicular nodes lying above the clavicle, internal mammary nodes lying along the internal thoracic vessels. Posterior intercostal nodes lying in the posterior part of the intercostal space in front of the head of the rib. Cephalic nodes lying in the deltopectoral groove. Note well, the addition of the aforementioned nodes. The lymph from the breast also drain into subdiaphragmatic and subperitoneal lymph plexus. So axillary lymph nodes, and then internal mammillary nodes, and then supraclavicular nodes, and then posterior intercostal nodes, and then cephalic deltopectoral nodes. In addition to the aforementioned nodes, the lymph from the breast also drain into the subdiaphragmatic and subperitoneal lymph nodes. Lymphatic drains from the breasts. The lymphatics draining the breasts are divided into two groups, superficial and deep. Superficial lymphatics drain the skin of the breast except the nipple and the areola. Deep lymphatics drain the parenchyma from the breasts, the skin of the nipple and the areola. The plexus of lymph vessels deep to the areola is called subareolar plexus of Sapei. The areolar plexus, most of the lymph from the breast drain into the anterior group of the axillary lymph nodes. The superficial lymphatics of the breasts of one side communicate with those of the opposite side. Consequently, the unilateral malignancy may become bilateral. The lymphatic drainage from the breasts occur as follows. The lymph from the lateral quadrant of the breasts is drained into the anterior axillary or pectoral groups of lymph nodes. These lymph nodes are situated deep to the lower border of the pectoralis minor. The lymph from the medial quadrants is drained into internal mammillary parasternal lymph nodes situated along the internal mammary artery. Some lymphatics may go to the internal mammary lymph nodes of the opposite side. A few lymph vessels from the lower lateral quadrant of the breasts follow the posterior intercostal arteries and drain into posterior intercostal nodes located along the course of these arteries. The lymph from the medial quadrant is drained into the internal mammary lymph nodes situated along the internal mammary artery. Some lymphatics may go to the internal mammary lymph nodes of the opposite side. A few lymph vessels from the lower lateral quadrant of the breasts follow the posterior intercostal arteries and drain into the posterior intercostal nodes located along the course of these arteries. A few lymph vessels from the lower medial quadrant of the breasts across the costal margin pierces the linea alba and communicates with subdiaphragmatic and subperitoneal lymph plexus. The lymph vessels from the deep surface of the breasts pierce pectoralis major and clavipectoral fascia to drain into the apical group of the axillary lymph node. Note well, about 75% of the lymph from the breast is drained into the axillary nodes, 20% into the internal mammary lymph nodes, and 5% into the posterior intercostal lymph nodes. Among the axillary lymph nodes, most of the lymph drain into the anterior axillary nodes and the remaining into the posterior apical groups. The lymph from the anterior, posterior, and lateral groups first goes to the central group and then throw them into the supraclavicular lymph nodes. So there is the apical group of the axillary lymph node, and then deltopectoral lymph node, and then central lymph node, lateral lymph node, anterior and posterior lymph nodes, group of axillary lymph nodes, and then posterior intercostal lymph node, internal mammary lymph nodes, subperitoneal lymph plexus, ovary, fallopian tube, Krukenberg's tumor, breast cancer, carcinoma of the breast. It is the most common cancer in females. It arises from the epithelial cells during the lactiferous ducts of acne of tubules. In about 60% of cases, it occurs in the upper lateral quadrant of the commonly affected females between 40 to 60 years of age. Clinically, it presents a very serious problem with the following signs and symptoms. Presence of painless hard limb. Breast becomes fixed with immovable due to intrusion of suspensory ligament by cancer cells. Retraction of skin due to infiltration of the suspensory ligament by cancer cells. retro- retraction of the nipple due to infiltration of the fibrous of the lactiferous duct. Pseudo-orange appearance played opposite of the skin, i.e. skin gives off appearance like that of a skin of an orange. Because pits, the hair follicle appears to be retracted beneath the level of the skin due to the obstruction of the superficial lymphatics. Metastasis. The knowledge of the lymphatic drainage of the breast is of great importance due to high percentage of occurrence of cancer in the breast and its subsequent dissemination of cancer cells. Metastasis along the lymph vessels of the region lymph nodes. Some lymph vessels from the infero-medial quadrant of the breasts communicate with the subperitoneal lymph lashes and carry cancer cells to it. From here, cancer cells migrate transcelometrically and get deposited on the ovary, producing a secondary tumor in the ovary called the Krukenberg's tumor. Early detection of the breast cancer. Breast cancer is a serious and often a fatal disease in women. The mammography and regular self-examination of the breast help in early detection of the breast cancer and its effective treatment. Mammography. It is an X-ray examination of the breasts used to detect cancer. The mammogram is X-ray picture of breasts. It is looked at by doctors to look for early signs of breast cancer. For example, characteristic mass of microcalcifications. Self-examination of breasts. The 6 steps of breast self-examination are as follows. Stand in front of the long mirror and inspect both breasts for any discharge from the nipples, puckering or dimpling of the skin. Now look at any changes in shape or the contour of the breasts. Clasp hand beneath your head and press hands forward. Press hands firmly on the hips and bow down slightly forward. During shower, raise your arm and use the fingers of the other hand to palpate the breast in a circular fashion. From palpatory the nipple from usually lump or mass under the skin. To palpate the nipple, usually pump or mass on the skin. Gently squeeze the nipple and look for any discharge. Do similar examination on both sides. Step 4 and 5 should be repeated in the lying down position. In this position, the breasts are flattened, which makes it easier to palpate them. Treatment. Surgical treatment of the breast cancer is in the form of lumpectomy or mastectomy. Lumpectomy is the removal of only tumor. Mastectomy is the removal of one or both breasts. In classical operation, the radial mastectomy, the whole breast is removed along the axillary lymph nodes, pectoralis major and minor muscle. All lymph nodes, pectoralis major and minor muscle. The whole breast is removed along with axillary lymph nodes, pectoralis major and minor muscles. Development of breast. The breast develops from the ectodermal thickening of milk line ridge. The line appears in a young embryo as early as the 4th week and extends from the axilla to the groin. In lower animals, several mammary glands develop along this line, but in humans beings, the ridge appears except for a small part of the pectoral region. Hence, it thickens, becomes depressed, and gives 15 to 20 solid cords, which grow into underlying mesenchyme and proliferating to form lobes in the gland. At birth, the depressed endodermal thickens is raised to the nipple. The stroma of the breast develops from the surrounding mesoderm. Macroscopic structures of the breasts. The microscopic anatomy of the breasts differs in resting and lactating phase of breasts. In resting phase, the lobules and the ducts are not well defined and have an macroscopic different resting phase. are not defined and have aberrant connective tissue and fat. On the other hand, on the lactating breasts have well-developed granular tissue but less connective tissue and fat. Age changes the breast. With age, there is decrease in fat and granular tissue of the breast. The connective tissue that supports the breast becomes less elastic. Many of these changes occur due to the decrease of estrogen during the level at menopause. And as a result, these changes in old women breasts become smaller, loose and sag. Clinical correlation, development of anomalies of the breasts. The following development anomalies of the breasts are concerned during the clinical practice. Polythelia supranumary nipple. It appears along the milk ridge and is often mistaken for moles. Retracted nipple or inverted nipple. It occurs if the nipple fails to develop from the ectodermal pit. In this condition, suckling of an infant cannot take place and the nipple is prone to infection. Appears along the milk ridge and often mistaken for moles. It appears along the milk ridges. Polymastia, so retract nipple or inverted nipple, and then polymastia, the development of more than one breast along the milk line. Gynecostia, the development of the breast in male, mainly in puberty. Usually it is bilateral and so occur due to hormonal imbalance. Most important structure of pectoral region of female breasts. Large muscle of the pectoral region, pectoralis major. Key muscle of the pectoral region, pectoralis minor. Most of the lymph from the breast, 75%, is drained into the axillary lymph nodes, mainly into anterior nodes. Subareolar plexus of Sapei. Plexus of lymph vessels deep into the areola, which drain into the anterior axillary lymph nodes. Rotors lymph nodes, interpectoral lymph nodes. Most common site of breast cancer, upper and outer quadrant of the breasts. Breasts. Main artery supply of the breast, lateral thoracic artery. A 55-year-old female complained to her family physician of heart painless lump in the upper and the outer portion of her right breast. The examination of the breast revealed the period orange appearance of the skin, loss of mobility of the breast, and retraction of the nipple. The examination of the axilla revealed that enlargement of the axillary lymph nodes. The X-ray of the vertebral column revealed that irregular shadow in the vertebral bodies of T6 to T7 vertebra. She was diagnosed in a case of the breast cancer. Questions. What do you understand about lymph of the breasts? What are its common causes? Any abnormal mass in the thickening of the breast tissue is called lump on the breasts. Lymph in the breast may occur due to a fibroadenoma, being tumor of the breast, which is usually a firm solitary mass that is mobile beneath the skin, or breast cancer, a malignant tumor of the breast which is adherent to the underlying tissue and immobile. Mention the anatomical basis of plateau, the appearance of the skin, retraction of the nipple, and loss of mobility of the breasts. The plateau, the appearance of the skin, it is due to the retraction of pits of hair follicles beneath the oedomatous skin following the retraction of the gametes of Cooper. The condition is due to the blockage of lymphatics draining the skin, leading to the stagnation of the lymph and edema of the skin. Retraction of the nipple occurs due to the infiltration of lactiferous ducts by the cancer cells and their subquadrant fibrosis. Name the three muscles lying deep to the base of the breasts. Pectoralis major, serratus anterior, and aponeurosis of the external oblique muscle and abdomen. What is the venous route of the spread of the breast cancer? Cancer cells of the breast, pectoralis, intercostal veins, vertebral venous plexus, vertebral bodies. What is the most common site of breast cancer? Upper and outer quadrant of the breast.
Radius. There are two bones in the forearm, radius and ulna. The radius is the lateral bone of the forearm and is homologous to the medial bone of the leg and tibia. The radius is relatively shorter than ulna, but it is larger and weight-bearing bone of the forearm. The radius and the ulna are joined together by fibrous interoserous membrane parts. The radius is a long bone and consists of three parts: upper end, shaft, and lower end. Upper end. The upper end presents the head, the neck, and the radial tuberosity. The head is disc-shaped and articulates above with the capitulum of the humerus. The neck is constricted part below the head. The radial tuberosity is just below the medial part of the neck. It has a smooth anterior part and rough posterior part, shaft. The long shaft extends between the upper and the lower ends and presents a lateral convexity. It widens rapidly towards the distal and is concave anteriorly in its distal part. Its sharpest anteroserous border is located on the medial side, lower end. The lower end is the widest part and presents 5 surfaces. The lateral surface projects distally as the styloid process. The distal surface presents palpable dorsal tubercle, Lister's tubercle, which is limited medially by an oblique groove. Anatomical position and side determination. The side of the radius can be determined by keeping the bone vertically in such a way that the narrow disc-shaped end is directed upward. The sharpest border, anteroserous border of the shaft, is kept medially. The styloid process is the lower end is directed laterally and prominent tubercle, Lister's tubercle, at the lower end of the faces dorsally. The convexity of the shaft faces laterally and the concave anterior surface of the shaft faces anteriorly. Features and attachments. Upper end. It is shaped like a disc and leaving its covered with an articular hyaline cartilage. It articulates superiorly with the capitulum from the humeroradial articulation.
Yeah.
How inclusions differ from cell organelles. And cytoskeleton. The cytoskeleton is a series of intracellular proteins that help in cell with shape, support, and movements. The cytoskeleton consisting of a network of tiny protein filaments and tubules that extends towards the cytoplasm. It serves as an important structural framework for the cells. The cytoskeleton has three main structural components: microtubules, microfilaments, and then intermediate filaments. Function of each component of a cytoskeleton. Microtubules, they provide support and shape the cell. Microtubules participate in intracellular transport and cell organelles, assist in cellular movement. Cilia, flagella, centrioles from a spindle which moves, and cytochrome myosotis. Microfilaments participate in muscular contraction. Microfilaments. So microtubules help in forming the cells, help in containing the cell shape, supporting the cell shape, and also in transportation of other organelles, also assist in cellular movement. Cilia, flagella, and centrioles, and participate in intracellular transport and other organelles. Intracellular transport and other organelles. And participate in intracellular transport and other organelles. And microfilament in particularly in muscular contraction. Intermediate filaments from leukocytes. Neutrofilaments help in intermediate filaments, link cells to others. Intermediate filaments link cells to others. Neurofilaments help to maintain cylindrical shape of axons. Loss of water and heat, smooth muscle. So microtubules help in supporting the cell shape and also transportation of cellular material and organelles. Microfibrils, microtubules, microfilaments help in muscle contraction, participate in moving and shifting of cytoplasm, help in endocytosis, exocytosis, help in endocytosis, exocytosis, phagocytosis, movement of flagella, etc. And then intermediate cells help in linking the cells. Intermediate filaments, epithelial tissue, cytokeratin, connective tissue, venentrin, cytokeratin, venentrin, destin, neurofilaments, GFA, soluble acid protein. Cystoles are composed of microtubules. Sequence of events, smooth muscle contraction, depolarization of cell membrane, opens voltage gated channels. First, depolarization happens due to opening of voltage gated calcium channels. Calcium flows into the cells into the electrochemical gradient, increasing in intracellular hormones and neurotransmitters may open in ligand gated channels and other membranes. Calcium enters the cell release hormones and neurotransmitters also directly release calcium from SR 1,4,5 triphosphate channels, 1,4,5 triphosphate to IP3 channels. So depolarization happens due to opening of voltage gated channels. Intracellular calcium releases. Intracellular calcium increases. Depolarization of cell membranes opens voltage gated calcium channels and calcium flows into the cell down to electrochemical gradient. And calcium flows into the cell down to electrochemical gradient. Cell binds with calmodulin. The calcium calmodulin complex binds to active myosin chain kinase. Decrease and relaxation. Decrease intracellular produces relaxation. Calcium binds with calmodulin chain, and then decrease intracellular calcium produces relaxation. Biophysics. Define pH and its importance. pH is the negative logarithm of hydrogen ion concentration of a solution to the base 10, where hydrogen concentration is expressed as mole per liter. Biomedical and clinical importance of pH. Maintenance of appropriate pH is necessary for homeostasis. pH controls the biomolecular reactions. It controls the enzyme activity. It controls the cellular viability. Maintenance of CF pH between 7.35 to 4.35 is essential for health. Blood pH 7.35 indicates acidosis, which occurs in diabetic ketoacidosis and lactic acidosis, etc. pH 7.45 indicates alkalosis that may occur in the vomiting of acidic substance. Calculate the solution. Hydrogen concentration of 1.3 into 10 to the power minus 4 mole per liter. Given hydrogen equal to 1.3 10 to the power minus 4 mole per liter. pH equal to minus log H equal to minus log 1.3 10 to the power minus 4 equal to 3.44. So pH 04 equal to 14 minus 3.88 equal to 10.12. Define buffer with classification. Buffer is a mixture of a solution of weak acid and conjugate bases of weak acid conjugate bases or of weak base or their conjugate acids, which have the capacity of preventing the change in pH when a moderate amount of strong acid or base is added to it. Classification of buffer system of the body. Body fluids buffer system. Plasma buffers. Bicarbonate buffer, plasma protein buffer, and phosphate buffer. RBC buffers. Bicarbonate buffer system, hemoglobin buffer system, oxyhemoglobin buffer system, and phosphate buffer system. Interstitial fluid buffers. Bicarbonate buffer, protein buffer, phosphate buffer. Intracellular buffer systems, protein buffer systems, phosphate buffer systems, bicarbonate buffer systems. Buffers acting through respiratory system. Hemoglobin buffer system, bicarbonate buffer system. Buffering action through kidney systems. Buffer phosphate buffer system, ammonia buffer system, bicarbonate buffer system. State the basic mechanism of buffer action. Mechanism buffer action. When moderate amount of a strong acid or base is added to a buffer solution, the buffer prevents change of pH the following ways. Mechanism of buffer action. When moderate amount of strong acid and base is added to a solution, the buffer prevents change of pH in the following ways. Buffer acts by converting a strong acid to weak acid and weak acid to weak base, strong acid to weak acid, and strong base to weak base, and thereby minimizes the effect of strong acid and a strong base or a strong base of a pH solution. Strong acid NaHCO3 NaH2CO3 and then NaOH and then H2CO3 and then weak acid. Buffer acts by donating proton into the solution by the buffer acid when there is proton deficient, by receiving proton from the solution by the buffer base when there is proton excess, H2CO3 and then HCO3 plus H equal to H2CO3. Proton deficit and proton excess. Proton deficit and then proton excess. Why bicarbonate buffer is the most powerful blood buffer? Bicarbonate buffer is the most powerful buffer in ECF. The bicarbonate buffer system is the most powerful ECF buffer in the body. This is due to mainly the fact that the no elements of the bicarbonate system, CO2 and HCO3, are regulated respectively by the lungs or the kidneys. As a result of this regulation, the pH of ECS can precisely be controlled by relative rate of removal and addition of HCO3 by the kidneys and the rate of removal of CO2 by lungs. The other fact is that it is present in plasma at a higher concentration than other buffer systems. It is the most potent power ECF in the body. This is due to mainly the fact that no element of the bicarbonate system of systems are regulated respectively by lungs and kidneys. It is buffer system most powerful ECF in the body. It is due to mainly the fact that no elements of the bicarbonate system, H2 and HCO3, are regulated respectively by the lungs or the kidneys. As a result of this regulation, the pH can be precisely controlled by relative and removal of additional H2CO3. Short note: pK is negative logarithm association of K. pK equals to minus log K, dissociation constant. pK is body buffers: bicarbonate buffer, phosphate buffer, ammonia buffer, protein buffer, hemoglobin buffer, and oxyhemoglobin buffer. State the Henderson-Hasselbalch equation and its importance. So pH equal to pK plus log conjugate base and weak acid. Importance of HH equation. Determination of weak acid. Determination of weak acid. pH of weak acid. Determination of pH of buffer action. Determination of pH of buffer action. Preparation for buffer solution of a definite pH. Preparation of buffer solution of a definite pH. Determination of blood pH and elevation acid base status of patients. Assessment of internal consistency of acid base parameter. Assessment of internal consistency of acid base parameter. How Henderson-Hasselbalch equation is used. Interpretation of acid base balance. Acid base balance is H equal to pK plus log HCO3 and H2CO4, or pH is equal to 6.1 and plus log HCO3 0.03 into PCO3, or pH equivalent to HCO3 minus and PCO3. From this equation, it is apparent that an increase in HCO3 concentration causes the pH to rise. From this equation, it is apparent that an increase in HCO3 concentration causes the pH to rise, shifting the acid-base balance towards alkalosis. H2 concentration causes the pH to rise. In increase, PCO3 causes the pH to decrease, shifting in the acid-base balance towards acidosis. An increase in PCO2. When disturbance of this acid-base balance results in a primary change of extracellular fluid CO2 concentration, they are referred as metabolic acid-base disorders. Therefore, acidosis caused by a primary decrease in HCO3 concentration is termed metabolic acidosis, whereas alkalosis caused by the primary increase of HCO3 concentration is called metabolic acidosis and metabolic acidosis. Therefore, acidosis caused by primary decrease in HCO3 concentration is termed metabolic acidosis, and whereas alkalosis caused by a primary increase of HCO3 it is considered metabolic alkalosis. Acidosis caused by an increased PCO2 is called respiratory acidosis. Metabolic acidosis and the respiratory acidosis. Whereas alkalosis caused by a decrease of PCO2 is termed as respiratory alkalosis. Find out the pH of a solution when concentration of NaHCO3 and H2CO3 are 0.025 and 0.125 m respectively. Buffer acts as a defense mechanism in living human body. Give the following answers regarding buffer. Buffer. A buffer pair, there are two components, weak acid and a conjugate base. The weak acid acts by donating proton to the solution in case of protein deficit, whereas the conjugate base, salt, acts by removing proton. So conjugate base acts by removing proton, and then whereas the weak acid acts by donating proton. In case of base access, buffer acts as donate proton to neutralize base, and then in case of acid decrease, the buffer base takes up proton and neutralizes acid. So buffer acid are functionally anti-base components of buffer, and buffer bases are functionally anti-acid components of buffer. Therefore, weak acid, a part of the buffer, prevents the previous deviation to alkali direction, and whereas the conjugate base, salt, prevents the pH deviation towards a acidic direction. Since the deviation of pH is either direction from normal value is incompatible to life, so a buffer pair of expected to work potentially at its maximum capacity at the weak acid concentration and conjugate base concentration are equal. Because of this stage, a buffer system attains equal capability of to prevent the deviation of pH in either direction. In case of base to acid ratio is 1. Base to acid ratio is 1. So the equation is modified to given below. pH equals to pK plus log 1 equal to pH to pK, since log 1 is equal to 0. Therefore, buffer maximum capacity at the pH which is numerically equal to close to pK value of the conjugate base. Because of this condition, buffer exists with acid concentration equal to that of conjugate base concentration. Define a standard solution. Classify with example. Give the calculation for preparing 100 ml of 5% dextrose solution. Find the osmolarity. Solution. A solution is homogeneous mixture of two or more substances, solid or liquid or gas, distributed uniformly among each other to form a single phase. Define a standard solution. Classify with example. Give the calculation for preparing 1000 ml of 5% dextrose solution. Find the osmolarity. A solution is a homogeneous mixture of two or more substances, solid, liquid or gases, distributed uniformly among each other to form a single phase. Classification. Solution: qualitative and quantitative, colloidal solution and crystalloid solution, a standard solution and non-standard solution. Colloidal solution: emulsoid solution, and suspensoid solution. And the standard solution includes normal, molar, premolar, osmolar and present, unsaturated, saturated and supersaturated. So qualitative and quantitative. Qualitative: colloidal, crystalloid. Colloidal also has emulsion and suspension. Quantitative has a standard solution and non-standard solution. A standard solution, non-standard solution. A standard solution also has normal, molar, osmolar and osmolar and present. Percent has weight, volume, weight and volume. Prepare 100 ml of 0.5% solution of glucose and calculate the osmolarity. 0.5% glucose solution contains 0.9 gram of glucose for every 100 gram solution. It means that our sample will contain exactly 0.5 gram of glucose. To convert this to mole of glucose, the compound molar mass 0.5 gram equal to 1 mole glucose and 180 gram. Prepare 100 ml 0.5 solution of glucose to calculate osmolarity. To convert this to mole of glucose, see the compound's molar mass. Now you need to find the sample's volume. Since the concentration of glucose is so low, you can say that the density of the solution is approx equal that of water. What is done is approx equal to 1 gram liter. We have 100 gram solution equal to 1 ml, 1 gram solution 10 ml. Remember, osmolarity is calculated per liter of solution. So convert the volume to 0 ml to L. Osmolarity 0.002527775 osmoles. 10 to the power 3 liter. So 0.094 osmol per liter. Which turn equal to, we have 100 gram solution, 1 ml, 1 gram solution equal to 100 ml. Remember, osmolarity is calculated per liter of solution. So convert the volume from ml to L. Osmolarity equal to 0.002775 osmoles by 100 to 10 to the minus 3 liter equal to 0.028 osmol per liter. Prepare 100 ml of 5% dextrose solution and concentrate the osmolarity of the components. 0.5% dextrose solution contains 5 gram of detox from every 100 gram of solution. Means that sample will contain exactly 5 grams of dextrose. Convert this to moles of dextrose. So the compound's molar mass 5 into 1 mole glucose into 180 grams 0.02778 osmoles. Now need to find the sample of the volume. Since the concentration of dextrose is low, you can say that the density of the solution is approx equal to that of water, which in turn is approx equal to 1 gram per liter. So we'll have 1 gram, 1 liter and 1 gram solution to 100 ml. Remember, osmolarity is calculated per liter of solution. So convert the volume to 1 ml to L. Short note, plasma osmolarity. Osmolarity is a number of osmoles per liter of solution. For example, 1 mole of NaCl of 1 liter of solution dissociates to proceed to osmol particles, and osmolarity of the solution is 2 osmol per liter. Amount of plasma osmolarity. Plasma osmolarity 300 milliosmol, 0.3, and a range 280 to 300 milliosmol. Amount of plasma osmolarity produced by NaCl and 8% produced by others. Produced by NaCl proteins, 0.5% by colloidal proteins and other crystalloids. The plasma colloidal osmolarity 298.5 milliosmol per liter. Plasma colloidal osmolarity 1.5 milliosmol per liter. Isotonic solution. An isotone have its same osmotic pressure as the plasma is called isotonic solution. Example: 0.9% NaCl solution, 5% glucose solution, and 3.8% sodium citrate solution. Buffering capacity. Buffering capacity of a solution is defined as the number of moles or acid base which must be added to a molar solution in order to change the pH of the solution by 1 unit. The amount of strong acid or strong base added in 1 liter system with pH change of 1 unit. The more the amount added, the more the buffering capacity. Factors affecting buffering capacity. Buffering capacity depends on total quantity of buffering components. The more the components, the more the buffering capacity. Based on acid ratio of buffer system, buffer capacity will be more with this ratio close to 1. 45-year-old male patient with a history of diarrhea for 2 days. What acid-base disorder may occur in this case? Metabolic acidosis. Metabolic acidosis. Write the biochemical pictures of metabolic acidosis and compare and compensate acid-base disorders. Part. How hemoglobin buffer act. Hemoglobin buffer system. It is the major buffer of RBC and consists of acid hemoglobin. HHB or HHBO2 and their conjugate base or basic hemoglobin. So hemoglobin buffer system exists on a oxygenated form, and an oxygenated or a deoxygenated form. It has a pK value of 7.7 to 7.8. This adverse 7.1 and the normal body of pH. The total buffer concentration is about 53.0 mole per liter in blood. Hemoglobin constructs acid group COOH that can donate proton where base or alkali is added, and base group that can accept proton when acid is added. Additionally, hemoglobin also contains imidazole group histidine. Imidazole group has pK value of 7.3 and it has donate proton when alkali is added as well as accept proton when acid is added. Mechanism of the acid. When a strong acid is added, proton release the acid are buffered by the acid hemoglobin and converted to acid hemoglobin. So strong acid is replaced by weak acid at the cost of basic hemoglobin component that minimizes the fall of pH. Strong acid hemoglobin or hemoglobin O2, HHB or HHBO2. When base of alkali, for example NaOH, is added, the base OH is buffered by the acid hemoglobin, forming H2O and basic hemoglobin. So a strong base is replaced by weak base at the cost of acid hemoglobin that minimizes the rise of pH. NaOH, OH, HHB or HHBO2, H or HBO2, H equal to H2O. Prepare 100 ml of 0.5 solution of glucose and calculate the osmolarity. 0.5% glucose solution contains 0.5 gram of glucose for every 100 gram solution. This means that our sample will contain exactly 0.5 gram of glucose. To convert this to mole of glucose, see the compound's molar mass. Define colloid and crystalloid with example. Substance having molecular size, atomic size 1 to 100 nanometer, which cannot pass through a semi-permeable membrane. Example, protein. Types of colloid: hydrophilic, lyophilic colloid. Practically all colloids of living systems are hydrophilic. These are solvent-loving and have affinity to water. They are easily solvented and hydrated where a shell of water molecule is formed around them. Protein and polysaccharide bile salt. Hydrophobic colloid. These are solvents hating and having no affinity to water. They are kept in solution by hydrophilic colloid absorbed around them. For example, colloid, gold, unconjugated bilirubin, etc. Crystalloids. Crystalloids are substances with size of 1 nanometer which can pass through a semi-permeable membrane. For example, crystalloids, minerals, glucose, amino acids, etc. State the function of crystalloids in human body. General function of crystalloids. General functions: maintains body fluid osmolarity and integrity of body fluid compartments. Concerned with resting membrane potential and action potential. Concerned with neuromuscular irritability, excitability, and tissue fusion. Specific functions: calcium helps in coagulation in bone mineralization. Concerned with buffering activity. Act as cofactor for enzymes. Take the difference between colloid and crystalloid. Colloid, larger 1 to 100, larger than solvent particles, cannot pass, amorphous and has no definite shape. Low, exhibit Tyndall phenomenon. Exhibit Tyndall Brownian movement, Brownian, visible under microscope, visible, non-dialyzable. Salt gel conversion occurs, separated by ultrafiltration possible. Nature of solution forms heterogeneous solution. Colloid, smaller than solvent particles, crystalloids, can pass. Crystalline, physical form. Osmotic pressure high. Tyndall phenomenon does not exhibit. Movement molecular. Visible under ultramicroscope, not visible. Dialyzable. Sol gel conversion does not occur. Separation by ultrafiltration not possible. Nature of solution forms homogeneous solution. Classify the biotransport mechanism across the cell membrane. Transport mechanism. Active transport and passive transport. Active transport, primary active transport, secondary active transport. Passive transport, osmosis, diffusion. Simple division, passive division. Secondary active transport includes glucose co-transport, amino acids, and then counter transport and then H and counter transport. Transport process for macromolecules, exocytosis and endocytosis, pinocytosis and phagocytosis, short note dialysis. It is one of the methods used in separate colloid and crystalloid form in their mixture. The principle of dialysis is based on the fact that crystalloid substances in solution can pass through semi-permeable membrane while colloidal particles cannot. Semi-permeable membrane used in dialysis may be parchment membrane, cellophane membrane, cellulose, nitrate, cellulose, acetate, etc. These are called dialyzable membrane, usually in the form of elongated tube or a bag. Dialyzable membrane acts as a sieve, retaining the large particles. Mixture of colloid and colloid is placed. Crystalloid and colloid is placed inside the tube of a bag or dialyzer and then suspended in a vessel containing dialysis fluid. Dialysis fluid is prepared without the crystalloid substance, which are to be separated. The crystallized particles from the mixture will diffuse out the dialysis fluid through the dialyzer down the concentration gradient, but colloid will retain within the dialyzer. Dialysis fluid is changed either periodically or continuously as crystalloid particles diffuse from the interior of the dialyzer into the surrounding dialysis fluid. Types: hemodialysis, peritoneal dialysis. Importance of dialysis: used as artificial kidney for treatment of renal failure. It is used for treatment of hyperkalemia. Short note on dialysis. Define isotope with example. Mention the use of isotopes in medical science. Isotope: protons with same isoatomic number but different atomic weight, number of protons plus neutrons. Example: rarely some naturally occurring isotopes determined can also be unstable. For example, carbon, iodine, and cobalt. Clinical use: diagnosis use of isotope for diagnosis of disease. Iodine uptake test for diagnosis of thyroid disorder. Radioimmune assay for hormone or for diagnosis of hormonal disorders. Organ scanning, for example, bone scan, brain scan, and thyroid scan. Absorption test for iron and vitamin B12, etc. Isotope for GFR, glomerular filtration rate clearance, RBC lifespan measurement, therapeutic use, radiotherapy, and treatment of malignancy, use of tracer technique. Isotope and used as tracer in metabolic studies to outline the metabolic pathways. Measurement of volume and space, ECF volume, blood volume, plasma volume, etc. Measurement of regional blood flow, cerebral blood flow, coronal blood flow, renal blood flow, etc. Sterilization for medical instruments. What are the reducing substance of blood? State the principle and the procedure of Benedict test. Answer: Benedict test. Principle: cupric salt is reduced by glucose in hot alkali solution to corpus salt, giving a variable color. Benedict's reagent: CuSO4 plus Na2CO3 and sodium citrate. Procedure: take 5 ml of Benedict's qualitative reagent to this test tube. Heat the tube over a flame to expel any impurities. Add 8 drops of urine and heat. Leave for about 2 minutes. RBC measurement. Therapeutic is radiotherapy treatment malignancy. Use of tracer techniques. Isotope are used as tracer in metabolic studies to outline the metabolic pathways. Measurement of volume and spaces. ECA volume, blood volume, plasma volume, etc. Measurement of regional blood flow. Cerebral blood flow, coronal blood flow, and renal blood flow, etc. Sterilize of medical instruments. Biomolecules. What are the reducing substances of blood? State the principle and procedure of Benedict's test. Benedict's test. Cupric salt is reduced by the glucose is in a hot alkali solution to cuprous salt, giving an variable color. Benedict's reagent. CuSO4, Na2CO3 and sodium citrate. Procedure. Take 5 ml of Benedict's qualitative reagent on test tube. Heat the tube over flame to expel any impurities. Add 8 drops of urine and heat again for about 2 minutes. Define the classify carbohydrates with example. Definitions of carbohydrate. Polyhydroxy organic compounds. Polyhydroxy organic compounds having aldehyde or ketone. Functional group aldehyde or ketone derivatives of polyhydric alcohol. Compounds which produce aldehyde and ketone derivatives on hydrolysis. In carbohydrate, number of carbon is always 3 or more, never less than 3. Classify carbohydrate example. Classification of carbohydrate: monosaccharide or simple sugar. A simple form of carbohydrate which cannot be hydrolyzed further into simple form of carbohydrate. These are 3 to 9 carbon compounds and serve as blending blocks of all carbohydrate. Among them, pentose and hexose are the most important. Glucose, fructose, galactose, mannose, ribose, and glutinose, etc. Disaccharide. Carbohydrate produced by the condensation of two monosaccharide units by glycosidic bond. Sugar that produces two molecules of same or different monosaccharides or hydrolysis. For example, maltose consists of two glucose molecules. Lactose consists of glucose and galactose. Milk sugar and sucrose consist of oligosaccharide. Carbohydrate procedure by condensation of 3 to 10 monosaccharides used by glycosidic bond. For example, maltose, raffinose, blood group, and substance, etc. Polysaccharide, also called glycans, polymer of monosaccharide composed of more than 10 monosaccharide units connected by glycosidic bond. Starch, glycogen, cellulose, monosaccharide, and glycoprotein, etc. Name the reducing sugars among carbon reducing agents. Reducing sugars. Sugars having free aldehyde ketone or groups called reducing sugar. They act as reducing agent in alkaline media. Examples: all monosaccharides and disaccharides are reducing sugars. Non-carbohydrate reducing agents: ascorbic acid, glutathione, cysteine, and hydroquinone and catechol. Monosaccharide and simple sugar, the simplest form of carbohydrate which cannot be hydrolyzed further into further simple form of carbohydrate. These are 3 to 9 carbon compounds and serve as the building blocks of all carbohydrate. Among them, pentose and hexose are the most important. Glucose, fructose, galactose, and mannose, ribose, glucose, and glucose, etc. Disaccharides, carbohydrate produced by condensation of two monosaccharide units by glycosidic bond. Sugars that produce two molecular or same or different monosaccharides or hydrolysis. For example, maltose, lactose, sucrose, table sugar. Oligosaccharide produced by condensation of 3 to 10 monosaccharides units by glycosidic bond. For example, maltotriose, raffinose, blood group, substance, etc. Polysaccharides, also called glycans, polymer of monosaccharides or composed of more than 10 monosaccharides units created by glycosidic bond. Sugar, glycol, cellulose, and mucopolysaccharide, glycoprotein, etc. Name the reducing sugar and non-carbohydrate reducing sugars. Reducing sugars. Sugars having free aldehyde and ketose group called reducing sugar. They can be reducing agents in alkali media. Example: all monosaccharides and disaccharides are reducing sugars. Non-carbohydrate reducing agents: ascorbic acid, glutathione, crystal, hydroquinone, and catechol. Define isomer. Discuss the isomer of monosaccharide. Isomer are the substances having same molecular formula but different structural formula. Isomers of sugars. L and D isomers, optical isomers, Paranose isomer and fructose ring structures. Pyranose 6 number of rings having 1 oxygen atom and 5 carbon atoms. Furanose 5 number of ring having 1 oxygen atom and 4 carbon atoms. Alpha and beta anomers. Abimers aldose, ketose, isomerism. Short note mutation. The spontaneous exchange in the optical rotation of optically active solutes that reaches a stable equilibrium value is called mutual rotation. For example, a solution of pure D-glucose in water spontaneously produces the equilibrium mixture of about 62% beta glucopyranose and 68% alpha glucopyranose. This process requires that the ring structure open to the linear form during the interconversion. During this procedure, the net optical rotation of the solution gradually changes. At least an equilibrium is reached and the net optical rotation of the solution is fixed at plus 52.7 degree. Mutual rotation, the spontaneous change in the optical rotation of optically active solids that reaches the stable equilibrium value of mutual rotation. For example, a solution of pure D-glucose in water spontaneously produces an equilibrium mixture of about 62% beta glucose and 82% alpha glucopyranose. Define protein. Proteins are high molecular weight nitrogenous macromolecules compounds composed of one or more polypeptide chain of alpha amino acids linked together by peptide bonds. Structural protein, catalytic protein, transport protein, hormone protein, gene regulator protein, protective protein, respirator protein, and complement protein. Support framework, collagen, elastin, catalyze enzymes, transport of substance, albumin, transferrin, regulation of functions, insulin, glucagon, etc. Regulate genetic functions, histone, porphyrin, prevent function, immunoglobulin, receptor function, LDL receptors. Muscle contraction, actin, myosin. What are bond on the protein structures? Type of bond in the protein structure: covalent bond, peptide bond, and disulfur bond. Non-covalent bond, hydrogen bond. Elastic bond, ionic interactions, van der Waals interactions, hydrophobic interactions. Isotropic pH. Isoelectric pH is defined as the pH at which an ion carries equal number of positive and negative changes, hence net charge becomes zero. Protein, peptide bonds, and amino acids exhibit isoelectric pH. At this pH, the ion called zwitterions. Albumin 4.6, gamma globulin 6.4, hemoglobin 6.7, and leucine 6.0. What are the bond protein structures? Covalent bond, peptide bond, disulfide bond, non-covalent bond, hydrogen bond, electric bond, van der Waals interactions, and hydrophobic interactions. Short note: isoelectric pH. Isoelectric point PL is defined as the pH at which an ion carries equal number of positive and negative charges and hence net charge becomes zero. Proteins, peptides, and amino acids exhibit isoelectric pH. At this pH, the ion is called zwitterions. Importance: at isoelectric pH, proteins are least soluble and so can easily be precipitated. And isoelectric pH, proteins and amino acids migrate least in the electric field. In solutions having pH above isoelectric pH, proteins act as acids and form anions. In solutions having pH below isoelectric pH, proteins act as base and form cations. It has a significant value in clinical laboratory and determining the mobility of known compounds in electric field. It selects appropriate buffers for separation of one from another. Define classify proteins with examples. Protein: macromolecular polymer. of amino acids linked together by peptide bonds. Classification of peptides: simple peptide, conjugated protein, and derived protein, collagen, elastin, keratin, nucleoprotein, and protease, peptone. Nutritional classification of protein: complete protein, egg, albumin, meat; incomplete protein, like gelatin; particularly incomplete protein, wheat protein. Functional classification of protein: functional classification of protein: structural, catalytic, transport, humoral, gene regulatory, protective, receptor, and contractile. Amino ends and N-terminal, peptide bond, peptide unit, carboxylic and C-terminal. Denaturation of protein and name the denaturation agent. Denaturation may be defined as the disruption of secondary, tertiary, and quaternary structure of the native protein, resulting in alteration of the physical, chemical, and biological characteristics of protein by a variety of agents. Native protein denaturation, denatured protein. Denaturation agents: physical agents, X-ray, UV ray, ultrasound, extreme temperature, etc. Chemical agents: strong acid, strong alkali, high urea concentration, heavy metal salts, ethanol, detergents, etc. Result of denaturation: primary structure with peptide linkage remains intact, but secondary, tertiary, and quaternary structures are lost. Denatured protein loses its biological activity. Denatured proteins cannot be crystallized. Denatured proteins are less soluble and so can be easily precipitated. Enzymatic or hormonal activities is destroyed by denaturation. Usually it is irreversible process, but rarely it may be reversible. Denatured proteins become insoluble in their solvent in which it was originally soluble. Define and classify liquid with examples. Lipids are heterogeneous group of organic substances which are water soluble but soluble in fat solvent. Classification of lipids: simple lipid, complex lipid, derived lipid. Mention the chemical properties of lipid. Properties: hydrolysis, hydrogenation, oxidation, rancidity, saponification, lipid peroxidation. Short note: rancidity. Rancidity is the term used to represent the deterioration of fats and oil resulting in an unpleasant taste. Fat containing unsaturated fatty acids are more susceptible to rancidity. Cause of rancidity: rancidity occurs when fat and oils are exposed to air, moisture, light, bacteria, etc. Hydrophytic rancidity occurs due to partial hydrolysis of triglyceride by bacterial enzymes. Oxidative rancidity is due to oxidation of unsaturated fatty acids. This results in formation of unpleasant products such as dicarboxylic acids, aldehydes, and ketone, etc. PUFA, polyunsaturated fatty acids. They contain 2 or more double bond sources: cotton seed oil, soybean oil, corn and fish oil, etc. Classification of polyunsaturated fatty acids according to the number of double bonds: dionic acid, and then trionic acid, tetraionic acids, polysaturated, pentoic acids, and hexaonic acids. Diomedic importance: polyunsaturated fatty acids decrease plasma cholesterol level by dietary means and thus reduce the risk of coronary heart disease. 10-carbon polyunsaturated fatty acids gives rise to euglycanoids. 10-carbon gives rise to euglycanoids. Ionic number: it is defined as the number of grams of iodine absorbed by 100 grams of fat or oil. Butter 25 to 80 ionic number. Palm oil 45 to 55. Olive oil 80 to 85. Coconut oil 7 to 10. Sunflower oil 125 to 135. Significance: iodine number is measured by the degree of unsaturated of fat and it is directly proportional to the content of unsaturated fatty acids. Lower is the iodine number, less is the degree of unsaturation. Name the prostaglandins. Show the steps of synthesis of prostaglandins with the diagram and mention their clinical importance. Prostaglandins. Prostaglandins are one type of euglycanoids derived from unsaturated fatty acids through glycooxygenase pathway. Subtypes: it is divided into the basis of Number of double bonds like Pg1, Pg2, Pg3 substitute group. Its compositions like Pgd2, Pge2 and PgF2 alpha. Production of prostaglandins. Membrane phospholipid are carotenoids and prostaglandin. Functions of prostaglandin. They act as local hormone. They are mediators for inflammatory and hemostasis, cause vasodilation and potentiate edema. Involved in pathogenesis in pain, fever, and in inflammation. Therapeutic use, including prevention of concentration, induction of a labor term, termination of pregnancy, prevention of gastric ulcer, control of inflammation, and control blood pressure. Define and classify phospholipids. Give the importance. The complex lipids containing phospholipids group in additional to fatty acids, nitrogenous base, and alcohol are called phospholipids. Phospholipids, fatty acid, alcohol, and phosphoric acid with or without nitrogen base. But in most of the cases, classification phospholipids, glycerophospholipid and sphingophospholipid and sphingophospholipid, glycerophospholipid, phosphatidic acid and phosphatidylglycerol, phosphatidylglycerol, phosphatiglyceramine, and phosphoradiol, phosphoserine, lysophospholipids, and plasmalogens. Sphingolipids. Biochemical importance. Phospholipids are the main lipid constituent of biological membrane. Regulate membrane permeability. Dipalmitoid procophorin is an important lung sufficient which decreases in surface phospholipid in an important alveolar lungs. Phospholipid is precursor of second messenger IPDAG. In the bile of gallbladder, they keep the cholesterol soluble and thus prevent formation of gallstones, help in blood coagulation. Phospholipids in myelosis provides insulation. Membrane phospholipids is hydrolyzed into arachidonic acid, which is precursor of glucosamines, components of bile acid. Define and classify lipoproteins with example. Lipoproteins are complex lipids made out of lipid and protein. Means of transport lipid protein. 4 measures of plasma lipoproteins have been identified. Chylomicrons, very low density lipoprotein, preview lipoprotein, a low density lipoprotein, and high density lipoprotein. Functions of lipoprotein. Since lipids are insoluble in water, they cannot alone travel in the aqueous blood plasma. Lipoproteins are water soluble, so lipids can easily travel in the blood as lipoproteins. So lipoprotein acts as transport vehicles for lipid in plasma. Chylomicrons transport exogenous TAG in intestine, in liver and peripheral tissue. VLDL transport endogenously synthesis TAG from liver and peripheral tissue, acts as precursor of LDL. LDL transports cholesterol from liver to peripheral tissue. HDL transport cholesterol from peripheral tissue to liver for its degeneration and excretion. Define enzyme with example. Enzymes are biocatalysis procedure by living cells to catalyze biochemical reactions. IUB or classification of enzymes. Oxidoreductase, transferase, hydrolase, lyase, isomers, and ligase. Write down the factors affecting enzyme action. Temperature, pH, substrate concentration, enzyme concentration, product concentration. Explain how substrate concentration affects enzyme activity. The rate of an enzyme catalyzed reaction increases with increasing substrate concentration until a maximum velocity is reached, and there is no further rise of velocity in spite of further increase of substrate concentration. What is Nicholas constant? For an enzyme, it is the substitute of concentration at which enzyme shows half maximum velocity. For an enzyme, it is the substance concentration at which enzyme shows half maximum velocity. At this point, 50% of enzyme binds its substrate indicates the enzyme's substrate affinity, and its M inversely proportional to the enzyme affinity of the substance. The more the enzyme affinity, the more substance Km value will be low. Then means substrate is low, concentration will be half maximum velocity. The less the enzyme affinity substrate, Km value will be high, and substrate must be high concentration to show the half maximum velocity. So Km provides measure of the substrate concentration required for significant catalysis to occur. Km value M is constant for a given enzyme at a defined condition. What is enzyme inhibition? Inactivation of enzyme and reduction of the velocity of enzyme catalyzed reaction is called enzyme inhibition, and the substance doing this is called enzyme inhibitor. The name of three enzyme inhibitors with corresponding enzymes: inhibitors and enzyme inhibitor, monoamine oxalate inhibitor, and allopurinol inhibitor, and inhibitor. Enzyme inhibitors. Give the difference between competitive and non-competitive inhibitors. Competitive inhibitor, non-competitive inhibitor binds with active site in enzyme, structurally substrate analog. Binds with active site of enzyme, substrate analog, cause reversible inhibition. Inhibition revealed by increasing substrate concentration. Reduce the affinity of enzyme to substrate. Mostly concerned with drug action. What is covalent modification? Hereby reversible phosphorylation and dephosphorylation. Activity of enzyme, especially at the rate of limiting enzymes, are regulated. So enzymes are active in phosphorylated forms and inactive in diphosphorylated forms, whereas the others are active in dephosphorylated form and inactive phosphorylated form. So glycosynthesis is active dephosphorylated form and inactive phosphorylated form. Sensitive form. In short note, temperature coefficient. The Q10 or the temperature coefficient is a factor by which rate of biological process increase 10 degrees in temperature. Value of Q10 for the temperature which enzymes are stable. The rate of most biological process typically double for 10 degrees Celsius rises temperature Q10 equal to 0. For a majority of enzymes, Q10 is 2 between 0 degrees to 40 degrees Celsius. Increase in temperature results in higher concentration energy of molecules and more molecular enzymes. Collision and interaction in the reaction of process faster. Define coenzyme with example and mention the clinical importance. Coenzymes are enzymes which are functionally must be same but structurally different. Important coenzymes: specific diagnosis, assessment of diagnosis, prognosis. Common isozymes are CK, LDH, ALP, NSO, and COX2. Immunoleuconic acid synthase. What are the different types of enzymes? Inhibitor or inhibitors, reversible inhibitor, competitive inhibitor, and inhibitors, and non-competitive inhibitor. Here inhibitor shows a structural similarity to substrate. Here inhibitor shows a structurally unrelated. Irreversible inhibitor. Here inhibitors has no structural similarity with substrate which binds with enzyme polyphosphate enzyme. They cannot be removed from enzyme only with the loss of enzyme activity. Heavy metal desulfurization fluoride and cyanide. Cofactor. These are usually trace elements. Cofactors are inorganic metallic ions which help in enzyme activity. Most of the cofactors remain in loosely bonded with enzyme. The enzyme are called metallic activated enzymes. Less frequently, cofactors found in remain tightly bound enzymes. When enzymes are called metalloenzymes and cofactors are called prosthetic group. Enzymes and cofactors. Enzymes: carbonic anhydrase, hexokinase, and cytochrome oxidase and catalase. Cofactors are zinc, magnesium, copper, and iron. It is the energy storage of polysaccharide in animals. It is sometimes called the animal starch, glycogen. Source: liver, muscle, brain, yeast, fungi, etc. It is a highly branched structure with chains 14 to 12 alpha D glycopyranose decides with branching means alpha 1 to glycolic bonds properties. It is non-reducing glycogen, readily soluble in water and gives red color in iodine. Importance of glycogen. Glycogen is the reserve source of energy in animal. It is stored on liver and skeletal muscle. Liver glycogen. During hyperglycemia, it is converted into glycogen by glycogenolysis and maintains glucose level. Serves other tissues via formation of blood glucose. Muscle glycogen serves as a fuel reserve for the synthesis of ATP during muscle contraction. Serves the need of muscles only. Muscle glycogen does not play a role in maintaining blood glucose level. Reserved for the synthesis of ATP during muscle contraction. It is also the reserve source of energy of some plants having no chlorophyll. No chlorophyll. Yeast, fungi. Write down the difference between starch and glycogen. Source: plant source, animal source. Mixture of amylose and amylopectin, single polysaccharide. Starch: less branched and glycogen. Amylose is unbranched and amylopectin is branched. Highly branched. Amylose is unbranched, amylopectin is branched. Molecular weight about 5 lakh. Molecular weight about 10 to 40 lakh. Gives reddish violet color in with dilute iodine solution. Gives deep red color in dilute iodine solution. Common dietary: rice, potato, wheat, etc. Liver, muscle, brain, etc. Glycogen and then starch. Reddish violet, red. Highly branched, not very highly branched. About 5 lakh, 10 to 40 lakhs. Write down the biological importance of cellulose. Cellulose is the polysaccharide of glucose units that constitute the chief part of the cell walls of plants. Structure of cellulose: it contains beta D glucose units linked by beta 1,4 glycosidic bonds. Cellulose is a polysaccharide of glucose unites the constitute of chief parts of the wall and plants. Cellulose. Glycogen is the energy storage polysaccharide in animals and in some also called animal starch. Importance: it is a major constituent of dietary fiber. It helps in defecation and thus prevents constipation. Cellulose is not digested in human body. It remains water in the intestine due to the colloidal nature, and it retains water in the intestine due to the colloidal nature and increases the bulk of intestine contents, thus stimulates peristalsis and causes defecation. Absorption of glucose so has a benefit role in diabetes mellitus. Absorption of glucose, diabetes mellitus. Absorption of cholesterol, decrease absorption of cholesterol, so it has a beneficial role in hypercholesterolemia, obesity and diabetic person. Mammals, including man, lack any enzyme that hydrolyzes the B14 bonds and cannot digest cellulose, so it gives not no energy. Microorganisms in the gut and of the ruminants and other herbivores can hydrolyze the beta linkage and ferment the product of smart chain fatty acids as a major energy source. Difference among starch, cellulose and glycogen. Starch, cellulose, glycogen. Starch, plant source, mixture of amylose and amylopectin. Starch. Amylose is unbranched and amylopectin is branched. Alpha D glucose, alpha 1,4 and alpha 1,6. Rice, potato, wheat. Cellulose, plant source, single polysaccharide and unbranched. Cellulose, beta D glucose, beta 1,4, alpha 1,4, 1,6, beta 1,4. Energy source: no. Vegetables, fruit, etc. Glycogen, animal source, single polysaccharide. So starch is the only amylose and amylopectin, mixture of amylose and amylopectin. Amylose and amylopectin and highly branched. Alpha D glucose, alpha 1,4 and alpha 1,6. Energy source: yes. common dietary source: liver, muscle, brain, etc. A solution is a homogeneous mixture of two or more substances. A solution is a homogeneous mixture of two or more substances distributed uniformly among each other, forming a single phase at a definite temperature and pressure. A solution is a homogeneous mixture of two or more substances distributed uniformly among each other, forming a single phase at a definite temperature and pressure. Qualitative solution: crystalloid solution, colloidal solution. Quantitative solution: normal solution. On the basis of concentration: normal solution. It is a solution in which 1 gram equivalent of solvent is dissolved in 1 liter of solution. 1 gram equivalent of HCl is 36.5 gram. Therefore, normal solution of HCl contains 36.5 grams HCl in 1 liter of solution. Molar solution: it is the solution in which 1 mole of solute is dissolved in 1 liter of solution. It is a solution in which 1 mole of solute is dissolved in 1 liter of solution. For example, 1 mole of NaOH is 40 grams. Therefore, 1 molar solution of NaCl contains 40 gram NaCl in 1 liter of solution. Molar solution, osmolar solution, osmolar solution present percentage solution. Scapula. The scapula is a large flat triangular bone located at the upper part of the posterior aspect of the thorax against the second and the seventh rib. It forms the posterior part of the shoulder girdle and provides attachment to about 16 muscles, which helps you to move your shoulders parts. The scapula is highly mobile bones and consists of 4 parts: a part and 3 processes: spinous process, acromial process, and coraconoid process. Spinous process, acromial process, and coraconoid process. Some authorities divide the scapula into 3 parts, namely head, neck, and body. The head is the thickest and largest angle. The neck is slightly constricted part, which surrounds the head, and while the body of the scapula is large triangular major part of the body. The body is triangular, thin, and translucent. It presents the following features: 2 surfaces, costal and dorsal, 3 borders, superior, tertial, and superior, lateral, and medial, 3 angles, inferior, superior, and lateral, 3 angles, inferior, superior, and lateral, 2 surfaces, costal and dorsal. Dorsal surface presents a self-like projection on the upper part called the spinous process. The lateral angle is truncated to form an articular surface, the glenoid cavity. Lateral angle is the thickened and called the head of the scapula, which is connected to the plate-like body of the spinous neck. Process. There are 3 processes: spinous process, acromion process, and coracoid process. Spinous process, acromion process, and coraconoid process. The spinous process is a self-like bony projection on the dorsal aspect of the body. The acromion process projects forward and almost at a right angle from the lateral end of the spine. The acromial process projects almost a right angle from the lateral end of the spine. The coracoid process is like a bird's neck. It arises from the upper border of the head and bends sharply to project super anteriorly. Anatomical position and site determination. The site of the scapula can be determined by holding the scapula in such a way that the glenoid cavity laterally forward and slightly upward at a 45-degree from coronal plane. The coronoid process is directed forward. The self-spinous process is directed posteriorly. The inferior angle apex of the triangular bone is directed downwards. Features and attachments. Surfaces. Costal surface. It concave and directed medially and forward. It presents 3 longitudinal ridges. The provides attachment to intramuscular tendons of the scapular fossa. Provides attachment to the intramuscular tendon of the subscapularis muscle. The subscapular muscle arises from the medial two-thirds of the subscapular fossa, costal surface, except for the neck, where subscapular brusa intervenes between the neck and the subscapular tendon. The serratus anterior muscle is inserted on the surface along the medial border of the inferior angle. Dorsal surface. The dorsal surface is convex and represents a self-like projection called a spinous process. The spinous process divides the dorsal surface into a supraspinous and infraspinous fossa. The upper supraspinous fossa is smaller and the lower infraspinous fossa is larger. The sphingolenoid notch lies between the base of the spine and the scapula, and the dorsal surface of the glenoid process of the neck of the scapula through the notch. The superior fossa communicates with the inferior infraspinous fossa and supraspinous nerve and vessels pass from the supraspinous fossa to the inferior fossa. The supraspinous muscle arises from the medial two-thirds of the supraspinous fossa. Supraspinous notch, dorsal surface, the supraspinous muscle. The infraspinous muscle arises from the medial two-thirds of the infraspinous fossa. Tres minor muscles arise from the upper two-thirds of the dorsal surface to the lateral border. This origin is interrupted by the circumflex subscapulary artery. Tres major muscles arises from the lower one-third of the dorsal surface of the lateral border and inferior angle of the scapula. The latissimus dorsi muscle also arises from the dorsal surface of the inferior angle by a small slit. Borders. The superior border. The superior border is the shortest extent between the superior and the lateral angles. The supraspinous notch is present on the border near the root of the coracoid process. The suprascapular notch is converted into suprascapular foramen by the superior transverse ligament. The suprascapular artery passes above the ligament. The suprascapular notch, superior border, suprascapular notch, and then the suprascapular foramen. The suprascapular artery passes into the ligament and scapular nerve passes below the ligament through suprascapular foramen. Air Force fly above the Navy, that is A artery, and for nerve below the ligament. Air Force fly below the N is for nerve. The inferior belly of the omohyoid arises from the superior border near the suprascapular notch. Lateral border. The lateral border is the thickest border and extends from the inferior angle to the glenoid cavity. The infraglenoid tubercle is present at the upper end, just below the glenoid cavity. The long head of the triceps muscles arise from the infraglenoid tubercle. Infraglenoid tubercle, long head of the triceps. Note 12. The lateral border of the scapula is thick because it acts as a fulcrum during the rotation of the scapula. Median border extends from the superior angle to the inferior angle. The thin and angled at the root of the spine of the scapula. The serratus anterior muscle is inserted on the costal surface of the medial border of the inferior angle. Serratus anterior. The levator scapular muscle is inserted on the dorsal aspect of the medial border of the superior angle of the root of the spine. The rhomboideus minor muscle is inserted in the dorsal aspect of the medial border opposite to the root of the spine. Rhomboideus minor muscle. The rhomboideus major muscle is inserted into the dorsal aspect of the medial border from the root of the spine of the inferior angle. It lies over the seventh rib of the seventh intercostal space. Superior angle. It is the junction of the superior and the medial border and lies over the second rib. Inferior angle, superior angle, and lateral angle. It is truncated and bears a pear-shaped articular cavity called glenoid cavity that articulates with the head of the humerus to form a glenohumeral joint. a fibrocartilaginous rim. The glenoid labrum is attached to the margins of the glenoid cavity, deeper its concavity. The capsule of the shoulder joint is attached to the margin of the glenoid cavity, proximal to the attachment of the glenoid labrum. The long head of the biceps brachii arises from the supraglenoid tubercle. This origin is intracapsular. Glenoid process, spinous process. It is a triangular shaft-like bony projection attached to the dorsal surface of the scapula at the junction of its upper one-third of the lower two-thirds. It divides the dorsal surface of the scapula into two parts: upper supraspinous fossa and lower infraspinous fossa. The spinous has two surfaces, superior and inferior surfaces. The superior surface of the spine forms the lower boundary of the supraspinous fossa, gives origin to the supraspinatus. The inferior surface of the spine forms the upper limit of the transverse fossa and gives origin to the infraspinous. The anterior border of the spine is attached to the dorsal subscript of the scapula. The lateral border of the spine binds with the sphingogleinoid notch. Through which the subscapular nerve and the vessels pass from the supraspinous fossa to the infraspinous fossa. The posterior border of the spine is also called crest of the spine. Trapezius is inserted to the upper lip of the crest of the spine, while the posterior fibers of the deltoid takes origin from the lower lip, acromial process. It projects forward almost at a right angle, from the lateral end of the spine, overhangs an glenoid cavity. Its superior surface is subcutaneous. It has a hip, two borders, and two surfaces. The medial and the lateral border of the acromial continue with the upper and the lower lip of the crest, the spine of scapula respectively. Its superior surface is rough and subcutaneous. Its inferior surface is smooth and related to the subacromial brusa. The medial border of the acromial provides insertion to the trapezius muscle near the tip. The medial border presents a articular facet that articulates with the lateral end of the clavicle from the acroclavicular joint. The lateral border of the acromion gives origin to the intermediate fibers of the deltoid muscle. The coracoacromial ligament is attached to the tip of the acromion. The acromial angle is the junction of the lateral border of the acromial and the lower border of the crest of the spine of the scapula. Coronoid process. It arises from the upper part of the head of the scapula and bent sharply so as to project forward and slightly laterally. The coraconoid process provides attachment to the three muscles: short head of the biceps brachii, coracobrachialis, and pectoralis major. The three ligaments coracocromial, coracoclavicular, and coracohumeral. The short head of the biceps brachii and the coracobrachial arises from the tip of the common tendon. The pectoralis minor muscle is inserted on the medial border of the upper surface. The coracocaminal ligament is attached to the lateral border. The conoid part of the coracoclavicular ligament is attached to its knuckle. The trapezius part of the coracoclavicular ligament is attached to the ridge on the superior aspect between the pectoralis major muscle and coracocaminal ligament. The coracohumeral ligament is attached to the root of the adjacent glenoid cavity. In living individuals, the tip of the coracoid process can be palpated 2.5 cm below the junction of the lateral 1/4 and medial 2/3 of the clavicle. In reptiles, the coracoid process is separate bone, but in humans, the attached scapula and thus presents a atavistic epiphysis. Ossification. The ossification of the scapula is the membranous cartilaginous body is formed by membranous ossification, while the other parts are formed by cartilaginous ossification. The scapula is ossified in 8 centers, a primary and 7 secondary. The primary centers appears in the body. The secondary centers appears as follows. 2 centers appear in the coracoid process, and 1 middle process, another root of the process, subcutaneous center. 2 centers appear in the acromial process. 1 center appears in each medial border, inferior border, and other on the lower rim of the glenoid cavity. The primary center of the body appears near the glenoid cavity during 8th week of IUL. The first secondary center of the middle of the coracoid process appears in the first year of the postnatal life and fuses at the age of 15 years. Second coracoid center appears at the root coracoid process during 10th year and fuses at 17 years of life. All other secondary centers appears at the puberty and fuses with the 10th year. Note 12. The first coracoid center represents the pre-coracoid elements and the second coracoid center represents the coracoid proper and the reptilia glottal. Asparagus deformity of scapula. Congenital high scapula. The scapula develops in the neck region during IUL and migrates downward to its adult position, i.e. upper part of the neck and the chest. Failure descends leads scapular asparagus deformity of the scapula. Bones of the upper limb. The study of the bones of the upper limb is important to understand the general morphology of the upper limb, and the students must read the features and attachments of the bones before undertaking the study of the upper limb. The study of the bones also helps to understand the position of various articulations, reach a wide range of movements executed by the upper limb, and the genesis of various fractures, which are common in the upper limb bones. Each upper limb contains 32 bones, namely scapula, the shoulder blade, clavicle, the collarbone, humerus, the bone of the arm, radius and ulna, the bones of the forearm, bones of the pectoral girdle, scapula and clavicle. Carpal bone, the bone of the wrist, the metacarpal, the bone of the hand, and phalanges, the bone of the digits. So carpal, metacarpal, and phalanges. The hand includes carpus, metacarpus, and ridges. Hence, it consists of 27 bones, which are arranged in a group of carpal, metacarpal, and phalanges. The total number of bones in a human body is 206, out of which upper limbs only contain 64. Clavicle. The clavicle or the collarbone is the long bone, approximately 15 centimeters 6 inches long, with an S-shaped curve. It serves as a shirt between the shoulder blade and the sternum. It is located horizontally on the anterior aspect of the body at the junction of the root of the neck and trunk. It articulates medially with the sternum and first rib cartilage and laterally with the acromion process of the scapula. It is subcutaneous and hence it can be palpated through the entire extent. It is the only bony attachment between the trunk and the upper limb. Functions. The functions of the clavicle are as follows. It acts as a shirt for holding the upper limb far from the trunk so that it can move freely. This allows free swing of the upper limb of various prehensile acts such as holding and catching. The transmission of forces from the upper limb to the axial skeleton. It provides an area for attachment of muscles. Peculiarities. The peculiar features of the clavicle are as follows. It is the only long bone that lies horizontally. It has no medullary cavity. It is subcutaneous through the extent. It is the first bone to start ossifying because the fifth and the sixth week, between the fifth and the sixth week in the uterine life, and the last bone to complete ossification at 25 years. It is the only long bone that ossifies by two primary centers. It is the only long bone that ossifies in the membrane except for its medial end, which ossifies in the cartilage. Membranocartilaginous ossification. Long bone ossify in the cartilage. It may be pierced through and through by the cutaneous nerves, intermediate subclavicular nerve parts. The clavicle consists of three parts, two ends and a shaft. The lateral acromial end is flattened above downward. The lateral end is flattened above downward. and articulates with the medial margin of the acromial process. Medial margin of the acromial process. The median sternal end is as enlarged and quadrilateral. It articulates with the clavicle notch of the manubrium sterni. It articulates with the notch of the manubrium sterni shaft. The shaft is curved. Its median two-thirds is round and convex forward. The shaft is curved. Its median two-thirds is round and convex forward. Its lateral one-third is flattened and concave forward. The inferior surface of the shaft possesses a small longitudinal groove in its middle third. Anatomical position and site determination. The site of the clavicle can be determined by holding the bone horizontally in such a way that it is flattened and is on the lateral side of its enlarged quadrilateral end is on the medial side. The convexity of its medial two-thirds and the convexity of its lateral one-third. The convexity of its medial two-thirds and the concavity of the lateral one-third face forward with the longitudinal groove. Cavity. Lateral one-third face forward with the longitudinal groove in the middle third of the shaft facing inferiorly. Features and attachments. Lateral end of the acromial. It is flattened above downwards. Lateral end. Its oval facet on this end articulates with the facet on the medial margin of the acromion to form the acromioclavicular joint. The lateral of the provides attachment to the fibrous capsule of the acromial joint. The lateral end provides attachment to the fibrous capsule of the acromioclavicular joint. Medial end. The enlarged medial end has shuttle-shaped articular surface that articulates with the clavicular notch of the manubrium sterni to form the sternoclavicular joint. It provides attachment to the fibrous capsule, articular disc, and interclavicular ligament. So, sternoclavicular joint. It provides attachment to the fibrous capsule, articular disc, and interclavicular ligament. Fibrous capsule, articular disc, and intraclavicular ligament. And fibrous capsule, articular disc. Shaft. The shaft of the clavicle is divided into two parts: lateral one-third and medial two-third. The medial two-third is the shaft convex forward and lateral one-third is concave forward. Lateral one-third is flattened and formed above downwards. It has two surfaces, that is superior and inferior, and two borders, that is anterior and posterior. Superior surface. It is subcutaneous between the attachment with the deltoid trapezius muscle. Inferior. It presents a conoid tubercle and a trapezoid ridge, which provides attachment to the conoid and trapezoid. Conoid and trapezoid parts of the coracoclavicular ligament. Conoid and trapezoid parts of the coracoclavicular ligament respectively. Conoid and trapezoid. Conoid tubercle is located on the inferior surface of near the posterior border of the junction of the lateral 1/4 of the medial 3/4 of the tubercle. The conoid tubercle is located on the inferior surface near the posterior border at the junction of the lateral 1/4 and medial 3/4. Lateral 1/4 medial 3/4 of the clavicle. At the junction of the lateral 1/4 and medial 3/4 of the clavicle. The trapezoid extends from forward and lateral from the conoid tubercle. Borders. Anterior border. It is a concave forward and gives origin to the deltoid muscle. A small tubercle located at the deltoid tubercle may be present in the border. Posterior border. It is convex. Convex backwards and provides insertion to the trapezius muscle. Medial two-thirds. It is cylindrical in shape and presents four surfaces: anterior, posterior, superior, inferior. Anterior, posterior, superior, inferior. Anterior surface is convex forward and gives origin to the clavicular head of the pectoralis major. The posterior surface is concave backwards. Concave backwards and gives origin to the sternohyoid muscle. Anterior surface gives pectoralis muscle and the posterior surface gives origin to the sternohyoid muscle near the medial end. Sternohyoid muscle. The lateral part of this surface forms the anterior border of the lateral part of the surface from the anterior boundary of the cervicoaxillary canal and is related to the following structure: anterior surface, posterior surface. It is concave backwards and gives origin to the sternohyoid muscle on the medial end. The lateral part of the surface forms the anterior border of the clavicoaxillary canal and related to the structures. Division of the trunk of the brachial plexus and third part of the subclavian artery. Superior surface and inferior surface. Superior surface. The superior surface of the head, So, pectoralis major and sternohyoid muscle. Pectoralis major and sternohyoid muscle. So, the superior surface, the clavicular head of the sternocleidomastoid muscle. The anterior has pectoralis major, the posterior has sternohyoid muscle. The clavicle head of the sternocleidomastoid muscle. Superior sternocleidomastoid muscle is origin to the medial half of the surface. Our inferior surface presents the following features: the costoclavicular ligament. It is attached to the oval impression at the medial end. Subclavius muscle. Costoclavicular ligament and subclavius muscle. It is inserted into the subclavian groove on this surface. Inserted in the subclavian groove. Clavipectoral fossa. It is attached to the margin of the subclavian groove. And nutrient foramen, the tubercle located on the lateral end of the subclavian groove. Pectoralis major muscles, ligaments. Pectoralis major coracoclavicular. Sternocleidomastoid, costoclavicular. Deltoid, interclavicular. Trapezius and subclavius. The muscles of the ligament attached to the clavicle are given in table 2.1. Features of the clavicle. The clavicle is one of the most common fractures of the bone. It is most common fractures of the junction of the lateral 1/3 and 2/3 due to the fall of the outstretched hand and shoulder. Due to the fall of the outstretched hand and shoulder. It commonly occurs in the males in the age of 15 to 25 years. When fracture occurs, the lateral fragment is displaced downward by the weight, the lateral, and the upper limb because trapezius muscle is unable to support the weight of the upper limb, trapezius. In addition, the lateral fragment is drawn medially and shoulder abducts, namely crest major, etc. The medial fragment is slightly elevated on the sternocleidomastoid. The lateral is displaced downward and by the weight of the upper limb because the trapezius is unable to support the weight of the upper limb. Crest major, etc. The medial fragment is slightly elevated by the sternocleidomastoid muscle. The characteristic clinical picture of the patient with the fractured clavicle of the man or woman supporting his sagging upper limb on opposite hand. The fracture at the junction is the structure clavicle that man or woman supporting his sagging upper limb the supporting hand. The fracture at the junction of the lateral one-third and medial two-third occurs because weakness was due to two curvatures of the clavicle meet at this site. Transmission of forces from the scapula to clavicle on this site through the coracoclavicular ligament. Recently, clinicians have found that the commonest site of fracture clavicle is the middle one-third, 80%, as the thinnest part of the deltoid muscle and ligamentous attachments. It occurs due to the fall on the lateral shoulder. The clavicle is absent in animals in which the upper limbs are used for walking and strength and weight transmission, and not for grasping or such as horses. Ossification. The ossification of the clavicle membranocartilaginous. The first bone to begin ossification 5th to 7th week, and one of the last bones to finish ossification 15 to 25 years of age. Whole of the ossification in the membranes except the medial end that ossifies in the cartilage. The clavicle begins to ossify before any other bone in the body. It ossifies by 4 ossification centers, 2 primary and 2 secondary centers, one on each end. The site of appearance, time of appearance, and time of fusion of the various centers are given in table 22.2. Note 12. Growing end of the clavicle. The sternal end of clavicle is growing end. The sternal end of the clavicle is growing end because epiphysis at this end appears at the age of 19 to 20 years. Growing end of the tubercle. The sternal end of the clavicle is the growing end. Unites with the shaft and the age of 21 to 25 years. The last of the epiphysis in the body to fuse with the shaft. The radiological appearance of the epiphysis in the females confirms that bone age are given the legal consent to marriage. The radiological appearance of this epiphysis in females confirms their bone age for giving the legal consent to marriage. 2 primary centers, 5th and the 6th week of intrauterine life, 4th and the 5th day of appearance, day after appearance, time of fusion, for 5th or 6th week of intrauterine life. Secondary center in the sternal end, 19 to 20 years, earlier in female, 2 years earlier. And secondary center at the acromial end, 20th year. Congenital anomalies, clavicular dysostosis. It is a clinical condition in which the medial and the lateral parts of the clavicle remain separated due to the non-union of the 2 primary centers of ossification. Clavicular dysostosis. It is the clinical condition in which the medial and the lateral parts of the clavicle remain separated and non-union. Cleidocranial dysostosis. It is a clinical condition characterized by the partial or complete absence of clavicle due to the defective intramembranous ossification. It is often associated with the defective ossification of the skull bones. In this condition, 2 shoulders can be approximated anteriorly in front of the chest. Condition characterized by the partial income of clavicle due to the defective intermembranous ossification. It is associated with the defective ossification of the skull bones. In this condition, 2 shoulders can be approximated anteriorly in front of the chest. This is a specimen of the right scapula. It has 2 surfaces, an anterior concave with 3 ridges rough surface and a posterior surface with a spinous process. Its glenoid cavity is directed laterally and its comparatively thin border is directed medially, and this comparatively thick border is directed laterally. So this is the lateral border and this is the medial border. Its inferior angle or the apex of the scapula is directed inferiorly. It has two surfaces, three borders, and three angles and three processes. The two surfaces are anterior surface and posterior surface. In the anterior surface, it has three ridges for giving attachment to the intermuscular tendon, which in turn gives attachment to the subscapularis muscle. Subscapularis muscle, which only occupies the which only attaches to the only to the medial two-third of the scapular fossa, and afterwards it is innervated by the scapular bursa from the neck. And on the anterior surface, on its medial border, all the way from the superior border to the inferior angle, a continuous muscle can be observed, known as the serratus anterior muscle. On the posterior surface, it has a self-like projection known as the spinous process, which divides the posterior surface into suprascapular fossa and infrascapular fossa. The suprascapular fossa has supraspinatus muscle, and the infraspinous fossa has infraspinatus muscle. On the posterior surface, the spinous process begins and is directed posteriorly. The posterior surface on the median border gives attachment to three different muscles. First, the levator scapulae muscle at the root of the scapula on the medial border, and then above there is the rhomboideus minor, and below the levator scapulae all the way to the inferior angle there is the muscle rhomboideus major. And on the posterior aspect, near the inferior angle, there is the latissimal origination of the latissimal dorsi muscle, and above that, on the lateral border, it has the teres major muscle attachment. And on the lateral border, on the upper two-third, it has the teres minor muscle attachment, which is intervening by the subscapular vein. And it has three borders: the superior border, which continues from the glenoid cavity to the medial border and has a notch known as the suprascapular notch near the root of the coracoid process. This notch is turned into a facet by the suprascapular ligament. A vein goes above the ligament and a nerve goes below the ligament. In the lateral border, on the posterior side, there is, from above downward, the rhomboideus minor, the levator scapulae, and the rhomboideus major. And on the anterior aspect, their entire medial border is covered by the serratus anterior muscle, the attachment to the serratus anterior muscle. And in the lateral border, which is comparatively thick, as the lateral border works as a fulcrum for the upper limbs, on the posterior surface there is the teres minor muscle and also teres major muscle, and on the very end of the inferior angle there is the latissimus dorsi muscle. It has three processes: the spinous process, acromial process, and coracoid process. The spinous process is directed posteriorly from the posterior surface of the scapula. It is a self-like projection. Its posterior aspect is attached to the scapula, and its anterior aspect attached to the scapula, and its posterior aspect is free and has two limbs. This is also known as the crus of the spinous process. The upper lip gives attachment to the trapezius muscle, and the lower lip gives attachment to the deltoid muscle. And the continuation of the spinous process gives rise to the Acromial process. Acromial process has a medial and a lateral border. The medial border continues to become the upper lip and the lateral border continues to become the lower lip and gives origin to the trapezius and the deltoid muscle respectively. It also has two ligaments, the subacromial ligament and the coracoacromial ligament. Subacromial and coracoacromial ligament. And the coracoid process is directed anteriorly from the root from the glenoid cavity. The posterior surface also has a notch known as the sphenoglenoid notch. Through the notch, the suprascapular continues with the infrascapular fossa, and the nerves and the veins go through. The acromial process is directed anteriorly and forward, anteriorly and laterally. It gives attachment to three muscles and three ligaments. The three muscles are biceps brachii pectoralis minor, biceps brachii pectoralis minor, pectoralis minor, biceps brachii and coracobrachialis, and gives origin to three ligaments: the coracoacromial ligament, the coracoclavicular ligament, and the coracohumeral ligament. It has 8 ossification centers, 1 primary and 7 secondary. The primary ossification center is situated in the center of the body, and ossification happens in the intrauterine life, 8th week of the intrauterine life. And there is 2 secondary ossification centers in the acromial process and 2 in the coracoid process, and 1 in the medial border, 1 in the inferior angle, and 1 other in the lateral border. The acromial process ossification, the ossification of the acromial process, acromial secondary process begins at the first year, and the rest of the ossification begins at the 10th year of life and ends after puberty at 20 to 25 years. The Spranger defect, scapula Spranger defect, as the scapula develops from above downward, and it in a normal physiological condition extends from the second rib to the 7th rib in the Sprangial deformity of the scapula. It fails to continue from above downward and only continues to the 3rd or the 4th costal cartilage until the 3rd and 4th costal cartilage. This is a specimen of the right clavicle. It is a modified long bone with an S-shaped shaft and 2 ends. Its lateral end is flattened and its medial end is quadrilateral in shape. The medial end makes the sternoclavicular joint, and the lateral end gives the acroclavicular joint. The shaft can be divided as the medial 2/3 and the lateral 1/3. The medial 2/3 will project concave forward, and the lateral 1/3 is convex, concave forward, and the medial 2/3 is convex forward. On the posterior border of the superior surface of the lateral border, it gives origin to the deltoid muscle, and on the anterior border gives the deltoid muscle, and the posterior border it gives attachment to the trapezius muscle, and the medial 2/3 of the shaft. Anteriorly, it gives origin to the pectoralis major muscle, and for the medial 2/3 posteriorly, it gives origin to the sternohyoid muscle. Superiorly to the medial two-thirds of the shaft. It gives rise to the sternocleidomastoid muscle, and inferiorly it has the sternocostal costoclavicular ligament, and the inferiorly it has the costoclavicular ligament. On the inferior border of the lateral end of the clavicle, it has the coracoclavicular ligament. The coracoclavicular ligament, which has two parts: a conoid tubercle and a trapezoid ridge. The conoid tubercle is situated at middle one-third, and the trapezius ridge continues to the end of the lateral end of the scapula. Inferiorly, it has a rough surface which gives rise to the subcostal groove, where the cleidopectoral fossa can be found, and also the nutrient foramen and the subcostal muscle, where the subclavius muscle originates, and the costoclavicular ligament is attached. The subcostal muscle, subclavicular, where the subclavicular muscle originates, and also the clavipectoral fossa is attached. The medial border makes the fibrous capsule, intermediate disc, and ligament, interclavicular ligament. The posterior surface also is an important landmark for the third part of the subclavian artery and brachial plexus, and division of the brachial plexus. It's a unique bone because it's a modified long bone. It is the only long bone that is not vertical but that is horizontal. It has the medullary cavity. It has two primary ossification centers, the first bone to ossification and the last bone to finish ossification. It is not entirely it's not entirely cartilaginous in origin, but membrana cartilaginous in origin. Also, it is subcutaneous, thus most of it can be palpated below the skin, and the nerves of the skin penetrate this bone through and through. The abnormalities include fracture of the bone, where the two curvatures meet, lateral 1/3 and the medial 2/3, 80%, and also the clavicular dysostosis and cleidocranial dysostosis, where the two primary centers never meet together. Also, there is an absence of a skull bone. Scapula. The scapula, a large Latin scapular shoulder blade, a large flat triangular bone located in the upper part of the posterolateral aspect of the thorax against the 2nd to 7th rib. It forms posterior part of the shoulder ridge. It forms posterior part of the shoulder ridge and provides attachment to 17 muscles, which helps you to move your shoulders. Parts. The scapula is highly mobile bone and consists of 4 parts: body and 3 processes: spinous, acromion, and coracoid. Some authorities divide the scapula into 3 parts, namely the head, the neck, and the body. The head is the thickest, larger angle. The neck is slightly constricted part which surrounds the head, while the body of the scapula is large, triangular, major part of the bone. Body. The body is triangular, thin, and translucent. It presents the following features: 2 surfaces, costal and dorsal. 3 borders, superior, lateral, and medial. And 3 angles, inferior, superior, and lateral. The dorsal surface represents a self-like projection on the upper part of the spinous process. The dorsal surface presents a self-like projection of a process. The lateral angle is truncated from the articular surface of the glenoid cavity. The lateral angle is truncated. The lateral angle is thickened and called the lateral angle head of the scapula, which the lateral end, which is connected to the plate-like body of the inconspicuous neck. There are three processes which are as follows: spinous process, acromial process, coracoid process. Spinous process, acromion process, spinous process, acromion process, coracoid process. The spinous process is a self-like bony projection on the dorsal aspect of the body. Spinous process. The acromion process projects forward almost at the right angle. The acromion process projects forward almost at the right angle from the lateral end of the spine. The acromial process projects forward almost at the right angle at the lateral end of the spine. The coracoid process is like a bird's beak. It arises from the upper border of the head and bends sharply to the project superior anteriorly. Anatomical position is the determination. The site of the scapula should be determined by holding the scapula in such a way that the glenoid cavity faces laterally forward and slightly upward at an angle of 45 degrees from the coronal plane. The coracoid process is directed forward. The coracoid process is directed forward. Coracoid process. The self-like spinous process is directed posteriorly. The inferior angle apex of the triangular bone is directed downwards. Inferior angle. Features and attachments. Surfaces. Costal surface. It is concave and directed medially and forward. Costal surface. It is concave and directed medially and forward. It presents three longitudinal ridges which provide attachment to the intermuscular tendon of the subscapular muscle. The subscapular muscle, a multipennate muscle, arises from the medial two-thirds of the subscapular fossa, except the near the neck, where the subscapular bursa intervenes between the neck and the subscapular tendon. The serratus anterior muscle is inserted on the surface along the medial border and the inferior angle. Dorsal surface. The dorsal surface is convex and presents a self-like projection called the spinous process. The spinous process divides the dorsal surface into supraspinous and infraspinous fossae. Supraspinous fossae. The upper supraspinous fossae is smaller and the lower infraspinous fossae is larger. The sphenoglenoid notch lies between these sphenoglenoid notch. Spinoglenoid notch lies in between the base of the spine and the scapula. To be specific, is lateral border and the dorsal surface of the glenoid process of the neck of the scapula. Through this notch, the supraspinous fossa communicates with the infraspinous fossa, and the suprascapular nerve and the vessels pass from the supraspinous fossa into the infraspinous fossa. The supraspinatus muscle and the infraspinatus muscle. The supraspinatus muscle arises from the medial two-thirds of the supraspinous fossa. The infraspinatus fossa arises from the medial two-thirds of the infraspinous fossa. Medial two-thirds and the medial two-thirds. The teres minor muscle. The teres minor muscle arises from the upper two-thirds of the dorsal surface. Upper two-thirds of the dorsal surface of the lateral border. Upper two-thirds. The origin is interrupted by the circumflex scapular artery. Circumflex scapular artery. The teres major muscle arises from the lower one-third. The teres minor muscle arises from the lower one-third of the dorsal surface of the lateral border. Lower one-third. upper 2/3 and lower 1/3 of the dorsal surface of the lateral border and the interior angle of the scapula. Lateral border and the anterior angle of the scapula. Angle of the scapula. The latissimus dorsi also arises from the dorsal surface of the inferior angle by a small slip. Borders. Superior border. The superior border is the shortest and extends between the superior and lateral angles. The superior border is the shortest and extends between the superior and the lateral angles. Superior and the lateral angles. Superior border. Superior and the lateral angles. Angle. The suprascapular notch is present on this border. The suprascapular notch is present on this border near the root of the coracoid process. Coracoid process. The suprascapular notch is covered by the suprascapular foramen. Is converted to the suprascapular foramen by the superior transverse ligament. Superior transverse ligament. Superior transverse ligament. The suprascapular artery passes suprascapular artery above the ligament and the suprascapular nerve. Suprascapular. And the suprascapular nerve passes below the ligament through which suprascapular foramen. So through the suprascapular foramen. The inferior belly of the omohyoid arises. The inferior belly of the omohyoid arises from the superior border and suprascapular notch. Superior border of the omohyoid. Omohyoid. Lateral border. The lateral border is the thickest border and extends from the interior angle to the glenoid cavity. The lateral border is the thickest border and extends from the anterior angle to the glenoid cavity. The infraglenoid tubercle and the supraglenoid tubercle. The infraglenoid tubercle is present on the upper end just below the glenoid cavity, and the long head of the triceps muscle arises from the infraglenoid tubercle. The lateral border of the scapula is thick because it acts as a fulcrum from the rotation of the scapula. Medial border. It extends from the superior angle of the inferior. It extends from the superior angle to the inferior angle. Medial border, vertebral border. It extends from the superior border to the inferior border. Medial border. It extends from the superior angle to the inferior angle. It is thin and angled at the root of the spine of the scapula. The serratus anterior muscle is inserted on the costal surface of the medial border of the inferior angle. The serratus anterior, medial border of the inferior angle, costal surface. Levator scapulae muscle is inserted on the dorsal aspect of the medial border from the spinous superior angle of the root of the spine. So levator scapulae muscle. The rhomboideus minor muscle inserts on the dorsal aspect of the medial border opposite to the root of the spine. The rhomboideus minor muscle is inserted on the dorsal aspect of the medial border. The rhomboideus minor muscle is inserted on the dorsal aspect of the median border. Opposite to the root of the spine. And the rhomboideus major muscle is inserted on the dorsal aspect of the median border from the root of the spine through the inferior border. Inferior angle. It lies over the 7th rib or the 7th intercostal space. Superior angle. It is the junction of superior and medial border. Superior angle. It is the junction of superior and medial borders. It lies over the 2nd rib. Lateral angle. It is truncated and bears a pear-shaped articular cavity called glenoid cavity that arises with the head of the humerus, that articulates with the head of the humerus to form the glenohumeral joint. The fibrocartilaginous rim, the glenoid, the fibrocartilaginous rim, the glenoid labrum is attached to the margin of the glenoid cavity to deepen the concavity. The glenoid labrum is attached to the margin of the glenoid cavity labrum to deepen its cavity. The scapula of the shoulder joins the attachment to the margins of the glenoid cavity proximal to the attachment of the glenoid labrum. The long head of the biceps brachii arises from the supraglenoid tubercle. This origin is intrascapulous. Spinous process. It is spinous process. Spine of the scapula. It is a triangular self-like bony projection. Attached to the dorsal surface of the scapula. At the junction of its upper 1/3 and lower 2/3. The division of the dorsal surface of the scapula into two parts. It divides the dorsal surface of the scapula into two parts: upper supraspinous fossa and lower infraspinous fossa. The spinous process. There are two surfaces, superior and inferior, and three borders: anterior, posterior, and lateral. The surfaces. The superior surface of the spine forms the lower boundary of the supraspinous fossa. And gives origin to the supraspinatus. The inferior surface of the spine forms the upper limb of the infraspinatus fossa and gives origin to the infraspinatus. Borders. The anterior border of the spine is attached to the dorsal surface of the scapula. The lateral border of the spine bounds the sphenoglenoid notch through which the suprascapular nerve vessels pass from the suprascapular fossa to the infraspinal fossa. The posterior border of the spine is also called the crest of the spine. The trapezius is inserted in the upper lip of the spine, while the posterior fibers of the deltoid takes origin in the lower lip. Acromion process. It projects forward almost at the right angle from the lateral end of the spine and overhangs the glenoid cavity. It projects forward almost at the right angle and the lateral spine and overhangs the glenoid cavity. Its superior surface is subcutaneous. It has a tip, two borders, medial and lateral, and two surfaces, superior and inferior. Two tips, medial and lateral. The medial and the lateral borders of the acromion continues with the upper and the lower lip of the spine respectively. The superior surface is rough and subcutaneous. The inferior surface is smooth and related to the subacromial bursa. The medial border of the acromion provides insertion to the trapezius muscle and near the tip, and the medial border articulates with the lateral end of the claviculi to form the acromioclavicular joint. The lateral border of the scapula gives origin to the medial border of the lateral border. Deltoid muscle, coracoacromial ligament, is attached to the tip of the acromion. So, coracoclavicular coracoacromial and subacromial. So coracoclavicular ligament and subacromial bursa. Coracoclavicular ligament. It coracoid process. It arises from the upper part of the head of the scapula and bends sharply to project forward and slightly laterally. The coracoid process provides attachment to the three muscles: short head of the biceps brachii, the coracobrachialis, the biceps brachii, and the coracobrachialis, the biceps brachii and the coracobrachialis, the biceps brachii and the coracobrachialis, and the pectoralis minor, the biceps brachii, coracobrachialis. Ligaments: the coracocranial ligaments, the coracoclavicular ligaments, and the coracohumeral ligaments. The coracoacromial ligaments, the coracoclavicular ligament, and the coracohumeral ligament. The short head of the biceps brachii and the coracobrachialis arise from the tip of the common tendon. The biceps of the brachii and the coracobrachialis arises from the coracobrachialis, and the biceps brachii arises from the tip of the common tendon. The pectoralis minor muscle is inserted to the medial border of the upper surface. The coracocranial ligament is attached to the lateral border. The coracocranial ligament is attached to the lateral border. The conoid part of the coracoclavicular ligament is attached to the knuckle. The trapezoid part of the coracoclavicular ligament is attached to the ridge of the superior aspect between the pectoralis minor muscle and coracocranial ligament. The trapezius part of the coracoclavicular ligament is attached to the ridge of the superior aspect of the pectoralis minor muscle. The coracohumeral ligament is attached to the root of the adjacent to the glenoid cavity. In living individuals, the tip of the coracoid process can be palpated below the junction of the lateral 2/4 and medial 3/3 of the clavicle. In reptiles, the coracoid process is a separated bone, but in humans, the attachment of the scapula, and thus it represents atavistic epiphysis. Sprengel's deformity of the scapula. Congenital high scapula. The scapula develops from the neck region during the IUL in uterine life and then migrates downward to the adult position. Upper part of the back of the chest. Failure to descend leads to Sprengel's deformity of the scapula. The first coracoid center represents the precoracoid element, and the second subcoracoid center represents the coracoid proper of the raptilla girdle. Cardiovascular system. What is heart? The heart is a muscular organ in all vertebrae, responsible for pumping blood through the blood vessels by repeated rhythmic contractions. What are the functions of the heart? Generations of blood pressure. Contractions of the heart generate blood pressure, which is responsible for blood movement through the blood vessels. Routine blood. The heart separates the pulmonary and the systemic circulation and ensures better oxygenation and blood flowing to tissues. The valve of the heart ensures a one-way flow of blood through the heart and blood vessels. Regulation of blood supply changes the rate of force of contraction, match blood delivery to change metabolic needs. Valve and situations: mitral, tricuspid, and aortic and pulmonary valve. Enumerate the properties of cardiac muscle. Properties of cardiac muscle: automaticity, functional syncytium, excitability, contractility, all or none, prolonged refractory period, conductivity, rhythmicity, Frank-Steiner law, tonicity. Automaticity is intrinsic factor of the tissue, generates impulse spontaneously and rhythmic without any stimulation. Automatic of cardiac muscle function, null syncytium. Excitability, contractility, refractory period, tonicity. Explain why cardiac muscle never fatigue. State the law during cardiac muscle contraction. State the properties of cardiac muscle. Action potential of cardiac muscle. Phase 0, 1, 2, 3, 4. And then what is plateau? Compare the action potential of SA node with cardiac muscle. Conductive system of the heart. Explain how conductive system generates automatically. Generation of action potential. Rate of rhythmicity in higher in SA node. Why? Resting membrane potential. Name the pacemaker tissue. Tissues having pacemaker potential. Show a diagram the channel responsible for pacemaker potential, action potential. Write down the cholinergic and adrenergic stimulation of SA nodal membrane. What is AV node delay? What is ectopic pacemaker? What is reserve pacemaker? What is AV node? Shortly discuss the role of Purkinje fiber. Nerve supply of the heart, effect of sodium and potassium ions, function. Cardiac cycle. What is cardiac cycle time? And then what is ventricular system begins after arterial system. And heart sound, apex and murmur. And then name the sites for heart and death sound. Hemodynamics, cardiac output and venous return. Define cardiac output, and then what are the factors that influence the cardiac output? How can cardiac output be measured? What is cardiac reserve? And venous return of SV, EDV and ESV. Effects of affecting EDV. And then blood pressure and its regulation. And what is VMC? Blood pressure regulation. What is renin and buckle system? Hypertension, HTN, heart rate, pulse, electrocardiogram. And then heart block, heart failure, angina pectoralis, circulation, physic and blood flow, shock and cardiac failure, exercise and cardiac change, coronal circulation. This is a specimen of the left clavicle. It has two ends, a lateral end or the acromial end and a medial end or the sternal end. The medial end is quadrilateral shape and the lateral end is flattened above downwards. The lateral end is flat above downwards and has two surfaces and two borders. The lateral end gives rise to the lateral two-thirds of the scapula, and the medial end gives rise to the medial two-thirds of the scapula. The medial two-thirds of the scapula is convex, concave forward, and the lateral two-thirds of the scapula is concave forward. It has convex forward and concave forward. The medial two-thirds of the scapula has important ligaments like the costoclavicular ligament. The lateral has the cranoclavicular ligament that has the trapezoid ligament and the coronoid ligament. And the middle of the scapula has the subclavius muscle and the clavipectoral fossa. Clavipectoral fossa. Also nutrient foramen. Nutrient foramen. It has the specialties of the clavicle is that unlike the other long bones, this long bone is not vertical but horizontal. It has no medullary cavity. Its origin is from the membranocartilaginous origin. It is the first bone to start ossification and the last bone to finish ossification. Muscle attachments. On the lateral end of the superior surface of the posterior border, it has the attachment for trapezius muscle, and on the anterior border it gives origin to the deltoid muscle, and on the medial anterior part it gives rise to the pectoralis major muscle. And superiorly in the medial two-thirds it has the costoclavicular muscle attachment. This is a specimen of the left scapula. It has two surfaces, three borders, three angles, and three processes. Its anterior surface is convex and directed forward, and its posterior surface with spinous process is directed posteriorly. It has three angles: inferior angle, lateral angle, and superior angle, and three borders: superior border, lateral border, and medial border. Then the anterior surface, it has three groups which gives attachment to the intermuscular tendon, which in turn is attached to the subscapular muscle, which only extends for the medial two-thirds of the clavicle. Then it is interrupted by the subclavius bursa from the neck. On the anterior borders, on the anterior surface, on the median border has a muscle attachment called the serratus anterior muscle. On the posterior surface there is a self-like projection called the spinous process, which divides the posterior surface to supra spinous fossa and infraspinous fossa, which has the supraspinatus muscle and the infraspinatus muscle. On the posterior surface, on the lateral border of above two-third, it has the muscle origin. It is the origin of the muscle teres minor, which is interrupted by the circumflex branch of the circumflex artery, and then near the inferior border it has the attachment of latissimus dorsi muscle, and above the latissimus dorsi muscle there is the serratus major muscle attachment. On the medial border near the sternal line up to the upper two-third, on the posterior surface it has the rhomboid major muscle attachment, and at the root of the spinous process it has the levator scalpi muscle attachment, and above that attachment it has the rhombus minor muscle attachment. It has three surfaces: a superior surface. The superior surface extends from the lateral surface to the coracoid process into the glenoid cavity. It has a notch known as suprascapular notch, which has the suprascapular superior transverse ligament, which turns the notch into a foramen. The artery goes above the foramen and the nerve goes inside the foramen. And in the median border is comparatively thicker than the lateral border, as it also works as a fulcrum. On the median border, below the clavicular notch, there is the infraclavicular tubercle, where the head of the triceps is attached, and it extends all the way to the inferior angle. On the lateral border is comparatively thinner, and it has three processes: body, spinous process, and acromion process. The spinous process is a serp-like projection that originates from the posterior aspect of the clavicle. It has two lips, an upper lip and a lower lip, and a posterior and anterior surface. The anterior is attached to the posterior aspect of the body of the clavicle. The upper lip has the trapezius muscle attachment, and the lower lip has the deltoid muscle attachment. The posterior surface is also known as the crus of the spine. The spine continues to become the acromial process. The acromial process also has two borders: anterior border and a medial border, lateral border. The medial border becomes the upper lip, and the lateral border becomes the lower lip, thus giving attachment to the trapezius muscle and the deltoid muscle. It has also two surfaces, an upper surface and a lower surface, and the tip of the acromial process also has ligaments and muscle attachment. The coracoid process is a bird beak shaped process which originates from the body of the scapula and directs forward and laterally. The coracoid process has three muscle and three ligament attachments. The three muscles are biceps brachii and costobranchial muscle. They both origin from the same ligament, tip of the same ligament. And there is a ligament known as costoclavicular ligament, then costohyoid ligament, and costohumerus ligament. Ligament. The scapula has 8 origination centers, ossification centers, 1 primary and 8 secondary. The primary ossification center is situated on the center, which ossifies the center part of the body, and the 2 ossification centers are in the acromion process, 2 on the coronoid process, and 1 in the inferior border, 1 in the medial border, and 1 in the lateral border. The clinical correlation, the scapula can have the spargals, imperfect scapula, where the scapula does not descend from above downwards as a abnormality. This is the specimen of the right scapula. It is situated on the posterolateral, as it is situated on the upper posterolateral aspect of the thorax. Its spinous process, the posterior spinous process, is directed posteriorly, and its concave anterior surface is directed anteriorly. Scapula. The scapula, or the shoulder blade, is a large flat triangular bone located on the upper part of the posterolateral aspect of the thorax against the second to seventh costal rib. It forms the posterior part of the shoulder girdle and provides attachment to about 17 muscles, which help you to move your shoulders parts. The scapula is a highly mobile bone and consists of 4 parts: a body and 3 processes: a spinous process, acromion process, and coracoid process. Spinous process, acromion process, and coracoid process. Note 12. Some authorities divide the scapula into 3 parts, namely the head, the neck, and the body. The head is thickest lateral angle. The neck is slightly constricted part which surrounds the head, thickest lateral angle. The head is thickest lateral angle, while the body of the scapula is the large triangular major part of the bone. The head is the thickest lateral angle. Body. The body is triangular, thin, and translucent. It presents the following features: 2 surfaces, costal and dorsal. 2 surfaces, costal surface and dorsal surface. 3 borders, superior, lateral, and medial. 3 angles, inferior, superior, and lateral. The dorsal surface presents a self-like projection on its upper part called the spinous process. The dorsal surface presents a self-like projection on its upper part called the dorsal surface presents a self-like projection on its upper part called the spinous process. The lateral angle is truncated to form the articular surface, the glenoid cavity. The lateral angle is truncated to form the articular surface, the glenoid cavity. The lateral angle is thickened and called the head of the scapula. The lateral angle is thickened, called the head of the scapula, and it is connected to the plate-like body by the inconspicuous neck. Process. There are 3 processes. There are as follows: spinous process, acromion process, coracoid process. Spinous process, acromion process, and coracoid process. The spinous process is a self-like bony projection on the dorsal aspect of the body. The acromion process projects forward almost at the right angle from the lateral end of the spine. The coracoid process is like a bird's beak. It arises from the upper border of the head and bends sharply to project superior anteriorly. The acromion process projects forward almost at the right angle to form the lateral end of the spine. Anatomical position and side determination. The site of the scapula can be determined by holding the scapula in such a way that the glenoid cavity faces laterally forward, faces the laterally forward, laterally forward, and slightly upward at an angle of 45-degree angle at a coronal plane. The coracoid process is directed forward. The coracoid process is directed forward. The self-like spinous process is directed posteriorly. The inferior angle apex of the triangular bone is directed downwards. Surfaces, costal surface. The concave and directed medially and forward. It presents three longitudinal ridges. Which provide attachment to the intramuscular tendons of the subscapularis muscle, which provides attachment to the intramuscular tendons of the subscapularis muscle, which provides attachment to the intramuscular tendons of the subscapularis muscle. The subscapularis muscle, a multipennate muscle, arises from the medial two-third of the subscapular fossa surface except near the neck, where the subscapular bursa intervenes the neck, between the neck and the subscapular tendon, innervates between the neck and the subscapular tendon. The serratus anterior muscle is inserted on the surface along the medial border and the inferior angle. Dorsal surface. The dorsal surface is convex and presents a self-like projection called a spinous process. The spinous process divides the dorsal surface into supraspinous and infraspinous fossae. The upper supraspinous fossa is smaller and the lower one-third, and the lower infraspinous fossa is larger, 2/3. The sphingogleinoid notch lies between the base of the spine of the scapula. The sphingogleinoid notch, the scapula, to be specific, the lateral border, and the dorsal surface of the glenoid process. The dorsal surface of the glenoid process. The neck of a scapula. Through this notch, the supraspinous fossa communicates with the infraspinous fossa, and the suprascapular nerve and vessels pass from the supraspinous fossa to the infraspinous fossa. The nerves. The supraspinous muscle arises from the medial. The supraspinous muscle arises from the medial two-third. Supraspinatus. The supraspinatus muscle arises from the medial two-third of the supraspinous fossa. The infraspinatus muscle arises from the medial two-third of the infraspinous fossa. Infraspinatus. The teres minor muscle arises from the upper two-third of the dorsal surface of the lateral border. Upper two-third. This origin is interrupted by the circumflex scapular artery. The teres minor muscle arises from the lower one-third of the dorsal surface. The teres major muscle arises from the lower one-third of the dorsal surface. Lower one-third of the dorsal surface of the lateral border and the inferior angle of the scapula. The arises from the lower one-third of the dorsal surface of the lateral border and the inferior angle of the scapula. The latissimus dorsi muscle also arises from the Dorsal surface of the inferior angle by a smaller slip, the latissimus dorsi muscle. So here we have the coracoid process, the acromion process, the suprascapular notch, the spinous process, and the superior border. Oblique ridge for attachment of the small intramuscular tendons of subscapularis, median border, inferior border, lateral border, infraglenoid tubercle, glenoid cavity, supraglenoid tubercle, infraglenoid tubercle, supraglenoid tubercle. Acromial process, lateral border of the acromion, suprascapular notch for facet for acromoclavicular joint, acromoclavicular joint, sphingogleinoid notch, suprascapular nerve, infraglenoid tubercle, lateral border, median border, infraspinous fossa, lower lip of the spine, upper lip of the spine, supraspinous fossa, spinous process. Pectoralis and muscles pectoralis minor, biceps brachii and coracobrachialis, so pectoralis major, biceps brachii and coracobrachialis, coracoacromial ligament, coracoclavicular ligament, and coracohumeral ligament, coracoacromial ligament, coracoclavicular ligament, and coracohumeral ligament. The long head of triceps, subscapularis, long head of triceps and long serratus anterior, inferior belly of the omohyoid, suprascapular ligament. The trapezius and deltoid. Trapezius and then deltoid, then coracoid, then coracoacromial ligament, superior angle, suprascapular ligament, levator scalpi, rhomboidas minor, levator scalpi, rhomboidas minor, infraspinatus, and then rhomboidas major, latissimus dorsi, teres major, teres minor, circumflex artery, and then long head of the triceps, glenoid cavity, capsule of the shoulder joint, suprascapular ligament, supraspinatus muscle, infraspinatus muscle, spinoglenoid ligament, suprascapular nerve below the ligament, suprascapular vessel above the ligament. Borders, superior border. The superior border is the shortest and extends between the superior angle and the lateral angles. The suprascapular notch is present on this border. Near the root of the coracoid process. The suprascapular notch is converted into suprascapular foramen by the superior transverse ligament or the suprascapular ligament. The suprascapular artery passes above the ligament and the suprascapular nerve passes below the ligament through suprascapular foramen. suprascapular foramen. Mnemonic Air Force flies above the Navy. That is A. Artery is above and nerve is below the ligament. The inferior belly of the omohyoid arises from the superior border near the suprascapular notch. The inferior belly of the omohyoid arises from the superior border of the suprascapular notch, lateral border. The lateral border is the thickest border and extends from the inferior angle to the glenoid cavity. Border is the thickest border. It is the thickest border, extends from the inferior angle to the glenoid cavity. The infraglenoid tubercle is present at the upper end and below the glenoid cavity, the infraglenoid tubercle. The long head of the tricep muscle arises from the infraglenoid tubercle. The long head of the triceps muscle. The lateral border of the scapula is thick because it acts as a fulcrum during the rotation of the scapula. Median border. It extends from the superior angle to the inferior angle. It is thin and angled at the root of the spine, and it extends from the superior angle to the inferior angle. It is thin and angled at the root of the spine of the scapula. Serratus anterior. The serratus anterior muscle is inserted on the costal surface of the medial border and the inferior angle. The serratus anterior muscle is inserted on the costal surface of the median border on the inferior angle and the inferior angle. The levator scalpi muscle is inserted on the dorsal aspect. It's also inserted on the costal surface as dorsal aspect on the medial border of the superior angle in the root of the spine. Levator scalpi muscle. The rhomboideus minor muscle is inserted on the dorsal aspect of the median border opposite to the root of the spine. The rhomboideus major muscle is inserted on the dorsal aspect of the medial border from the root of the spine to the inferior angle. The inferior angle lies above the seventh rib or the seventh intercostal space. Inferior superior angle. It is the junction of superior and medial borders and lies above the second rib. Lateral border. It is truncated and bears a pear-shaped articular cavity called the glenoid cavity. Articulates with the head of the humerus to form the glenohumeral joint, a fibrocartilaginous rim. The glenoid labrum is attached to the margin of the glenoid cavity to deepen its concavity. The fibrocartilaginous rim, the glenoid labrum, is attached to the margin of the glenoid cavity to deepen the concavity. The capsule of the shoulder joint is attached to the margin of the glenoid cavity. The capsule of the shoulder joint is attached to the margin of the glenoid cavity, proximal to the attachment of the glenoid labrum. The long head of the biceps brachii arises from the supraglenoid tubercle. This origin is intracapsular. The long head of the triceps brachii arises from the supraglenoid tubercle. The long head of the triceps brachii, supraglenoid tubercle. This origin is infrascapular. The long head of the biceps arises from the supraglenoid tubercle. The biceps arises from the supraglenoid tubercle, which origin is intrascapular. Supraglenoid tubercle. Process. Spinous process. It is a triangular shaft-like bony projection attached to the dorsal surface of the scapula at the junction of the upper 1/3 and lower 2/3. It is a triangular shaft-like bony projection attached to the dorsal surface of the scapula at the junction of the superior 1/3 and the lower 2/3. It divides the dorsal surface into scapula into two parts, upper supraspinous fossa and lower infraspinous fossa. The spine has two surfaces, superior and inferior, and three borders, anterior, posterior, and lateral surfaces. The superior surface of the spine forms the lower boundary of the supraescapular fossa and gives origin to the supraspinatus. The inferior surface of the spine gives the upper limb of the infraspinous fossa and gives origin to infraspinatus. Borders. The anterior border of the spine is attached to the dorsal surface of the scapula, and the lateral border bounds the spine bounds the sphenoglenoid notch through which the suprascapular nerves and vessels pass from the supraspinous fossa to infraspinous fossa. The superior surface is subcutaneous. The acromial process's superior surface is subcutaneous. It has a tip and two borders, median and lateral. A tip and two borders, median and lateral, and two surfaces, superior and inferior. So two borders, median and lateral, two borders, median and lateral, two surfaces, superior and inferior. Two surfaces, superior, inferior, two borders, median, lateral, and then a tip, median and lateral. The superior surface is subcutaneous. The median and the lateral borders of the acromial continue with the upper and the lower lip of the crest of the spine of scapula, respectively. Its superior surface is rough and subcutaneous. Superior surface is rough and subcutaneous, and its inferior surface smooth and related to the subacromial bursa. Its inferior surface is smooth and related to the subacromial bursa. The median border of the acromial process, medial border provides answer to the trapezius muscle near the tip. The median border presents a articular facet. Presents an articular facet that articulates with the lateral end of the clavicle to form the acromoclavicular joint. The lateral border of the acromion gives origin to the intermediate fibers of the deltoid muscle. The coracoacromial ligament is attached to the tip of the acromion. The coracoacromial ligament. The acromial angle is at the junction of the acromial lateral border. The acromial angle is at the junction of the lateral border of the acromion and lower border of the crest of the spine and scapula. The acromial angle, lateral border of the acromion and lower border of the crest of the spine of the scapula. Acromial angle. At the junction of the acromial and the crest of the scapula. Coracoid process. It arises from the upper part of the head of the scapula. And bends sharply to project forward and slide laterally. The coracoid process provides attachment to three muscles: short head of the biceps, brachii, and coracobrachialis, and pectoralis major, pectoralis minor. Three ligaments: coracoacromial and coracoacromial, coracoclavicular, and coracohumeral. The short head of the biceps brachii and coracobrachialis arise from the tip by a common tendon. The pectoralis minor muscle is inserted on the median border of the upper surface. Median border. The acromial ligament is attached to the lateral border. The pectoralis minor muscle is inserted on the median border of the upper surface. The coracoacromial ligament is attached to its lateral border. The coracoacromial ligament is attached to its median lateral border. Inside lateral border. The conoid part of the coracoclavicular ligament is attached to its knuckle. Lateral part to its knuckle. The trapezoid part of the coracoclavicular ligament is attached to the ridge of the superior aspect between the pectoralis major muscle and coracoid ligament. The coracohumeral is attached to the root of the adjacent to the glenoid cavity. So the short head of the biceps brachii and coracobrachialis arise from the tip of the common tendon. The pectoralis minor muscle is inserted on the median border. The pectoralis minor is inserted to the median border of the upper surface. Median border of the upper surface. And then the coracoacromial ligament is attached to the lateral border. Coracoacromial lateral border. Coracoacromial ligament is attached to the lateral border. The coracoacromial ligament is attached to the knuckle. The conoid part of the coracoacromial ligament is in knuckle, major part, and the coracohumeral ligament is attached to the root of the adjacent glenoid cavity. So coracoclavicular, coracoacromial, and then coracohumeral ligament. The biceps brachii and coracobrachialis muscle from the same tip of the tendon. And then in the medial border, the pectoralis minor. In living individuals, the tip of the coracoid process can be palpated. The tip of the coracoid process can be palpated 2.5 centimeters below the junction of the lateral 1/4 and the medial 2/3 of the clavicle. Junction of the coracoid process can be palpated. Can be palpated 2.5 centimeters below the junction of the lateral 1/4 and the medial 2/3 of the clavicle. In reptiles, the coracoid process is a separate bone. The coracoid process is a separate bone, but in humans it is attached to the scapula, thus represents an atavistic epiphysis. Ossification. The ossification of the scapula is membranocartilaginous. Body is formed by membranous ossification, while the other part of the forms are cartilaginous ossification. The scapula is ossified by 8 centers, 1 primary and 7 secondary. The primary center appears in the body. The secondary center appears as follows. 2 secondary appears the coracoid process. 1 in the middle process, another in the root of the spinous process, And then 2 centers appear in the acromial process, and 1 center appears in the middle border, on the inferior angle, and the lower part rim of the glenoid cavity. So on the lower part of the rim of the glenoid cavity, median border, and the inferior angle. The primary center of the body appears near the glenoid center. Near the glenoid center. Near the glenoid cavity. During 8th week of intrauterine life. The first secondary center in the body of coracoid process. The first secondary center of the coracoid process appears in the first year of the postnatal life and fuses at the age of 25th year. Coracoid process. The second coracoid center appears in the root of the coracoid process during 10th year and fuses 17th year. All the other secondary center appears about puberty and fuse in the 25th year. The first coracoid center presents the precoracoid alignment, and the second coracoid center represents the coracoid proper, rectile girdle. Sprengels deformity of scapula. Congenital high scapula. The scapula develops in a neck region during the uterine life. Neck region during uterine life, then migrates downward to an adult person, i.e., upper part of the back of the chest. Failure to descend leads to Sprangel's deformity of the scapula. Scapular region. The scapular region includes parts, structures around the scapula. The following text deals with scapular humeral muscles, intermuscular space in the subscapular region, nerves and vessels, anastomosis around the scapula. The scapular humeral muscles. The scapulohumeral muscles are relatively short muscles which pass from the scapula to the humerus and act on the glenohumeral joint. They are also called intrinsic shoulder muscles. There are 6 in number. Intrinsic shoulder muscles: deltoid, supraspinatus, infraspinatus, subscapularis, tres major, or tres minor. Supraspinatus, infraspinatus, subscapularis, teres major, teres minor, deltoid. The deltoid or 3-in-1 muscle is thick, powerful and curved triangular muscle covering the shoulder and forming its rounded contour. The deltoid in shape like the inverted Greek letter delta. Hence it is named deltoid. The deltoid muscle is divided into 3 parts: anterior unipennate part, posterior unipennate part, and middle multipennate part. Origin. The deltoid has V-shaped origin from the subcutaneous bony arch. Correct.
Deltoid has a V-shaped origin from the subcutaneous body arch formed by the lateral one-third of the clavicle, acromial process, and the crest spine of the scapula.
Case is lateral one-third of the clavicle, deltoid, lateral one-third of the clavicle, also the acromial process and the crest of the spine. V-shaped. The acromial.
The details are the acromial impairment
Arises from the upper surface, another border, lateral third from the clavicle. The anterior aspect arises from the upper surface, from the clavicle. The middle multipennate part arises from the lateral margin and upper surface of the acromial. The lateral margin and the posterior multipennate part arises from the lower lip of the spinous scapula, lower lip of the crest of the spinous scapula. এরপরে origin, insertion, nerve supply, actions, muscles and connecting scapula with vertebral column. Trapezius, medial
one-third of the superior knuckle line. এটা কোথায়?
origin, তাহলে ট্রাপিজিয়াসের origin হচ্ছে medial one-third of the superior knuckle line. Insertion, acromial. Nerve supply, C3 C4 nerve supplies. Upper fiber elevations, scapula. Middle fiber retract scapula. Lower fiber depress scapula. Latissimus dorsi, nerve supply. Latissimus trapezius. Latissimus dorsi nerve supply, thoraco nerve. C6 C4 C6 C7 C8. Then levator scalpi, medial border of the scapula, dorsal C3 C4. Cervical 3, cervical 4. Rhomboideus minor, dorsal scapular nerve, C5, rhomboideus major, rhomboideus minor, C5 clavicle, acromion, which is spine of the scapula. Origin, lateral one-third of the clavicle, lateral margin of the acromion, crest of the scapula. Shaft of the humerus, insertion of the V-shaped humerus, the fibers converging inferiorly to form a third thick tendon. Note well, the fibers of multiple middle part arise from the four septa that are attached above the acromion. These fibers converge into three septa of insertion. They are attached to the deltoid tuberosity. Due to multiple arrangement, this middle acromion part of the deltoid is the strongest part. Nerve supply from axillary nerves C5 to C6. For actions.
The anterior or clavicular fibers of the flexor are flexors and medial rotation of the arm. The posterior spinous fibers are extensor and lateral rotation of the arm. Deltoides সবকিছু arm. The medial acromial fibers are the strong abductor of the arm from 15 degree to 90 degree. Middle fibers, acromial fibers cannot abduct the arm from the 0 degree to 15 degree when the arm is by the side of body because its ventral pool corresponds to the long axis of the arm.
Note well, the deltoid muscle is like three muscles in one. The anterior fiber flex the arm. The fiber flex the arm. The middle fiber abduct the arm. The posterior fibers extend the arm. Clinical
Flexion,
testing.
extension, medial rotation.
Clinical aesthetic. The deltoid can be easily seen and felt to contract when the arm is abducted against resistance. Abducted against resistance. তারপরে anastomosical basis injury to axillary and nerve during extramuscular injections in deltoid. The intramuscular injections should be given in the thick middle part in the lateral aspect of aspect 3 to 5 to 5 centimeters below the acromial process. Located in this area, lay 3 fingers across the deltoid muscle below the acromion process. This is essential to avoid injury on the axillary nerve, which winds around the surgical neck to the humerus and deep to the deltoid muscle. If intramuscular injection is given on the lower part of deltoid, the axillary may be damaged. The lower acromion. Insertion of the deltoid. The site for intramuscular injection in the deltoid muscle, given in the center of a triangle. Note well, earlier it was thought that the intramuscular junction is given in the upper and the outer quadrant of deltoid region. Structures under the deltoid. Bones, upper end and the humerus and the coracoid process. Joints and ligaments.
Joints are in shoulder, glenohumeral joint and coracoacromial ligament. Bursa around the shoulder joints, subscapular and subacromial and subdeltoid and infraspinatus. Muscles, insertion of the pectoralis minor, pectoralis major, teres major, latissimus dorsi, subscapularis, suprascapularis, and the supraspinatus, infraspinatus, teres minor. Origin of the long head of the biceps, short head of the biceps, and the coracobrachialis, long and lateral head of the triceps.
Vessels, anterior and posterior circumflex, humeral artery and vein. Vessels, anterior artery of the vein. Nerves, axillary nerve spaces, quadrangular and triangular subscapular intermuscular space. Supraspinatus. Origin.
Supraspinatus arises from the middle 2/3 of the supraspinous fossa of the scapula. Supraspinous fossa কোনটা? Fossa of the scapula.
তো মিডল টু-থার্ড বলতেছে কেন? মিডল টু-থার্ড
তার হচ্ছে insertion, the fibers passes forward and converse under the acromion into the tendon which across the above the shoulder joint and is inserted into the superior facet of the greater tubercle of the humerus.
The fibers pass forward and converge under the acromion. The fibers The fibers pass forward and converge under the acromion into a tendon, which cross the above shoulder joint and insert into the superior facet on the greater tubercle of the humerus. Greater tubercle. Nerve supply supraspinatus is supplied by a
Supraspinous is supplied
Supplied by
by the
the
suprascapular nerve,
suprascapular
cervical
nerve.
5 to cervical 6.
Actions.
Supraspinatus initiates the abduction of the shoulder. It is responsible for the first 15 degree of the abduction of the shoulder and thus assists the deltoid in carried abduction. Thereafter, that is from the 15 degree to 90 degree. Supraspinatus can be palpated due to the trapezius and above the spine of the scapula when the arm is abducted against the resistance. Clinical testing the supraspinatus can be palpated deep to the trapezius and above the spine of the scapula when the arm is abducted against the resistance.
Clinical correlation. Rupture of
the supraspinatus tendon. It is common of soft tissue injury in the shoulder region. The patient with the ruptured supraspinatus tendon, when they asked to raise his hand above the head of the affected side, it will first tilt his body affected and so that arm swings away from the body, leading to an initial abduction of the 15 degree, or he will slightly above the 15 degree raise the affected arm by the head of the healthy side, a common practice device learned by the patients with the ruptured spinatus tendon.
our infraspinatus.
It is thick triangular muscle which occupies most of the infraspinatus fossa. The arises from the medial two-thirds of the fossa by tendinous fibers from the ridges on its surface. Insertion, the fibers converge to form a tendon which processes across the posterior aspect of the shoulder joint to be inserted on the medial facet of the greater tubercle of the humerus.
The don't greater tubercle. Nerve supply C5 C6. Action. Infraspinatus is the lateral rotation of the humerus. Infraspinatus is the lateral rotation. Infraspinatus is the lateral rotation of the humerus. Infraspinatus.
Clinical testing. Infraspinatus can be palpated inferior spine of the scapula when the arm is laterally rotated against the resistance.
But tres minor.
Teres minor. The narrow elongated muscle arises from the posterior aspect of the lateral border of the scapula.
The narrow elongated muscle arises from the posterior aspect of the lateral border of the scapula.
Yes, sir. And fibers upwards and laterally across the shoulder joint to be inserted on the lower facet of the greater tubercle of the short greater tubercle.
Nerve supply tres minor.
greater tubercle দিচ্ছে স্যার,
সবগুলোতে greater tubercle
এটা greater tubercle আর এগুলো হচ্ছে
tres তারপরে nerve supply C4 C6. Action. Teres minor acts as a lateral rotation and weak abductor for the humerus. Teres major. Origin. This thick flat muscle arises from the oval area on the dorsal surface of the inferior angle. Teres major and adjoining lateral border of the scapula. Insertion. The fiber runs up to the initially and ends in the flat tendon, and which is inserted into the medial lip of the intertubercular sulcus of the humerus. Medial lip of the intertubercular sulcus of the humerus. Nerve supply. Tres major is supplied by the lower scapulae C5 C6. এগুলো হচ্ছে C5 C6 C5 C6. Action. Acts as a medial rotator of the arm. Medial rotator of the arm. Subscapularis.
It is bulky, irregular muscles which fills the subscapularis fossa.
Origin. Subscapula arises from the medial two-thirds of the costal medial surface of the scapula tenuous intermuscular apparatus to reach of the bone. Insertion.
The fibers converge laterally to the rod and tendon, which passes in front of the capsule of the glenohumeral joint of the joint inserted on the lesser tubercle of the humerus. The tendon is separated from the neck of the scapula by a large subscapular bursa, which generally communicates with the synovial cavity to the shoulder joint.
By a subscapular bursa. Nerve supply is the lower scapular C5 and C6. Actions.
এটা পুরোটা দেখছো subscapularis is the medial rotation of the humerus together with the
subscapularis, the medial rotation of the scapula together with the supraspinatus, infraspinatus, and teres minor. It stabilizes the head of the humerus in glenoid fossa during shoulder movements. The origin, insertion, and nerve supply and action of the scapulohumeral muscle are described in table 5.3. Rotator cuff muscles. The four rotator cuff muscles are subscapularis muscle, infraspinatus, supraspinatus, teres minor.
supraspinatus, infraspinatus, teres minor,
एक
subscapularis.
2 3 4 rotatory cuff.
According to the bottom, from top to bottom.
The four suprascapular muscles refers to, they are called rotatory cuff muscles, for they are formed muscular tendinous rotator cuff around the glenohumeral joint. SITS muscles. The SITS muscles are so referred in the reference to the first letter of their muscles. SITS muscle, SITS, sits. Rotatory cuff.
Rotatory cuff is the name given to the tendons of the supraspinatus, infraspinatus, teres minor, and subscapularis, which are fused with each other and the underlying capsule of the gleno. তুমি তো উঠবেই 7:45
তোমার 7:15 দেওয়ার সাথে
আচ্ছা দেখো
7:15 ডেকে দিয়েছে
7:15 ডাকলে 7:45 rotatory cuff is the name given to the tendons of supressor inferior teres minor subscapularis, which are fused with each other and underlying capsule of the glenohumeral
supraspinatus, infraspinatus, transmedullary subscapula, which are fused with each other and underlying scapula of the glenohumeral joint. Tendon of the supraspinatus fused superiorly. Tendons of the infraspinatus. ঠিক আছে পারবা না দেখে তুমি মেরে দেবে inferior আর teres minor এবারে fuses posteriorly তাহলে কথা এটা কথা তারি. The cuff plays an important role in stabilizing the shoulder joint during its movements. The primary function of rotatory cuff muscles is to grasp the relatively large head of the humerus and hold it against the smaller, shallow glenoid cavity. Movements of the scapula. The scapula is able to glide freely on the posterior chest wall because of the loose connective tissue between the serratus anterior and the chest wall. Smooth connective tissue. The movements of the scapula are produced by the muscles that attach to the trunk and indirectly by the muscles passing from the trunk to the humerus when the glenohumeral joint is fixed. All the movements of the scapula occurring on the chest wall. Scapulothoracic linkage. involves concomitant movement at the sternoclavicular and acromioclavicular joints. The various movements of the scapula are as follows: protraction, retraction, elevation, depression, and rotation. Protraction in the movement, scapula moves forward on the chest wall. It is produced by serratus anterior, supraspinatus, infraspinatus, supraspinatus, infraspinatus, teres minor, subscapularis, assisted by the pectoralis minor muscle. Protraction is required for punching, pushing, and reacting forwards. Retraction in this movement, the scapula are drawn backwards, downwards, and medial plane in bracing backward of the shoulders. It is produced by middle fingers of trapezius, middle fibers of trapezius and rhomboideus. Elevation, the scapula is elevated as in struggling by the stimulus contraction of the levator scalpi and upper fibers of the trapezius. Depression, the scapula is depressed by the simultaneous contraction of the pectoralis minor. The scapula is depressed by the simultaneous contraction of the pectoralis minor, lower fibers of trapezius and latissimus dorsi. Elevation is by levator scalpi and trapezius. Rotation, the rotation of the scapula takes place around the horizontal axis. The rotation of the scapula takes place around the horizontal axis, passing through the middle of the spine and scapula, sternoclavicular joint. Median rotation. Rotation in the scapula takes place around the horizontal axis, passing through the middle of the spine of the scapula and sternoclavicular joint. Medial rotation is brought about by the simultaneous contraction of the levator scalpi, rhomboider, and latissimus dorsi. The gravity plays a role in this movement. And lateral rotation is brought about by the trapezius. Its upper fibers raise in the acromial process and its lower fibers depress in the medial end of the spine of the scapula and serratus anterior. Its lower 5 digitations pull the inferior angle of the scapula forward and laterally. The lateral rotation is the scapula tilts its glenoid cavity upwards, which is essential for abduction of the upper limb above 90 degrees. The movement of the scapula and the muscle which produce them is summarized in tables 15.4 and figure 5.14. Subscapular spaces, intermuscular spaces in scapular region. The lateral rotation is brought about by the trapezius. Its upper fibers rise the acromial process and its lower fibers depress the medial end of the spine of the scapula. The serratus anterior, its lower 5 digitations pull the anterior angle of the scapula forward and laterally. The lateral rotation of the scapula tilts the glenoid cavity upwards, which is essential for the abduction of the upper limb above 90 degrees. Scapular spaces, these are quadrangular or triangular intermuscular spaces in the scapular region, which are clearly seen from behind after reflecting the posterior part of the deltoid. The knowledge of this space is essential for during surgery in the shoulder region. Superior tres minor subscapularis, capsule of the shoulder joints between the above two muscles, tres major, long head of triceps, and surgical neck of the humerus. Structures passing through the space: axillary nerve, posterior circumflex, humeral artery and vein. Upper triangular space, superior, lateral, and inferior. Structures passing through the space: circumflex, scapular artery. Lower triangular space. So quadrant space quadrangular space, upper triangular space, and lower triangular space. Upper triangular quadrangular space, tres minor. Quadrangular space, upper triangular space, and lower triangular space. Injury of the axial nerve is at risk of damage the inferior dislocation of the shoulder joint. It fractures in the surgical neck humerus because it close to the relations of the structures. Contents of the axilla. Contents of the axilla are as follows: axilla artery and its branches, axillary vein and tributaries, cords of the brachial plexus, axillary lymph nodes, fibrofatty tissue, axillary tail of breath, long thoracic and intercostal nerves. Note well, the neurovascular structures in the axilla are normally protected by arm on the side of the body and the cushioning of matrix. The axillary fat, but they are vulnerable to injury when the arm is abducted. Further details: axillary artery. The axillary artery is the main artery of the upper limb. It begins at the outer border of the first rib as the continuous and the subclavian artery and ends by becoming the brachial artery at the lower branch of the tres major. In axilla, it runs from the apex of the base, lying nearer to the anterior wall than the posterior wall. It's during axilla cross superficial surface parts: first part, second part, third part. The axilla are divided into the following three parts. The first part, superior or muscle proximal to the muscle. Second part, posterior or deep to the muscle. And third part, dorsal to the muscle. Pectoralis minor, three parts by the pectoralis divided by the pectoralis minor. Pectoralis minor, second part, first part, third part. Relations: axillary vein lies medial to the axillary artery and three or four parts, and branch of the axillary artery. On the branch from the first part, second branch from the second part, one branch from the first part. Superior thoracic artery. Superior thoracic artery. And the another second branch from the second part, and third branch from the third part. Two branches from the second part and three branches from the third part. Most of the branches supply the wall of the axilla. First part, superior branch. A small branch arises near the subclavius, passes between the pectoralis major and minor muscles, and supplies three muscles medial of the axilla. From the second part, thoracoacromial artery, lateral thoracic artery, lateral thoracoacromial artery. And then from the third part, subscapular artery, the third part, subscapular artery, and the anterior circumflex artery. So the subscapular artery arises from the third part of the axillary artery. A branch of the axillary artery runs along the lower border of the subscapular artery, ends in the inferior angle of the subscapular, gives large branch circumflex artery, which passes through the upper triangle inner muscular space, winds around the lateral border of the scapula, enter spinous fossa, in addition to gives numerous small branches. Subscapular arteries: anterior circumflex humeral artery, small artery, and then posterior circumflex humeral artery. Arterial anastomosis of the scapula. The arterial anastomosis around the scapula is principally formed between the branches of the first part of the subclavian and the third part of the axillary, first part of the scapula, third part of the axillary arteries. The arterial anastomosis around the scapula principally formed between the branches of the first part of the subclavian and the third part of the axillary arteries. The scapular anastomosis takes place at two sites: around the body of the scapula and over the acromion process of the scapula. The scapular anastomosis takes place in two sites: around the body of the scapula and over the acromion process of the scapula. So the first part has superior thoracic artery. The first part has superior thoracic artery. The second part has acromial artery and lateral thoracic artery. The third part has subscapular artery, anterior subscapular artery, and then anterior circumflex artery and the posterior circumflex humeral artery. Around the body of the scapula, it occurs. Around the body of the scapula, it occurs between the supraescapular, around the body of the supraescapular artery, a branch of the thoracocervical trunk, a first part of the supplementary, a branch of the thoracocervical trunk. Circumflex scapular artery, a branch of the subscapular artery, is third part of the axillary artery. Deep branch of the transvagal cervical artery, a branch of the thoracocervical artery. Over the acromial process, it occurs between the acromial branch of the thoracocervical artery and thyrocervical artery and thoracocervical artery, a branch of the supraescapular artery. Thoracocervical artery, branch of the supraescapular artery and the posterior circumflex artery, humeral circumflex artery. Clinical correlation, collateral articulation through the scapular anastomosis. If the subclavian of the artery arises are blocked anywhere from the first part of the supplementary, the third part of the axillary artery, the scapular anastomosis serves as a potential pathway between the first part of the subclavian artery and the third part of the axillary artery to ensure the adequate circulation of the upper limb. Axillary artery pulsations and compressions. Axillary artery pulsations and compressions. Axillary artery pulsations can be felt in the lower part of the lateral wall of the axilla. Lateral part of the axillary arteries can be affected, compressed against the lower part of the lateral wall of the axilla to control the bleeding from dorsal part of the upper limb. The pectoralis minor. It is a small triangular muscle that lies deep in the pectoralis major muscle. It arises from the third, fourth, and the fifth rib near the costal cartilage. Third, fourth, and the fifth rib. It is inserted by a short, thick tendon in the medial border upper surface of the coracoid process of the scapula. Nerve supply. Nerve supply is medial and lateral pectoral nerves. Nerve supply is by the medial and lateral pectoral nerves. Assist. The serratus anterior is in drawing the scapula forward. Depress. The point of shoulder acts as an accessory muscle of respiration during forced inspiration. The pectoralis minor is considered as the key muscle of axilla because it crosses in front of the axillary artery and thus used to divide the artery as three parts. The key muscle crosses in front of the axillary artery. Thus is divided to divide the artery into three parts. The origin of the pectoralis minor is variable. It may be prefixed or postfixed. Arises from the second and the fifth ribs, or arises from the fourth and the sixth ribs. Rarely some fibers of the pectoralis major separate and pass from the first rib to the coracoid process, what is called pectoralis minimatus muscle. Subclavius, the small rounded muscle that lies horizontally in the interior of the clavicle. Subclavius is inserted into the shoulder groove surface. Nerve supply by the upper trunk of the brachial plexus. Actions. The subclavius stabilizes the clavicle by pulling the inferiorly medial during the movement of the shoulder joint. Clinical correlation. The subclavian vessels and the divisions of the brachial plexus behind the middle 1/3 of the shaft of the clavicle provides protection of the three structures. The torn by fragments clavicle led to and following the fall of the back of the horse. Subclass vessels. For example, this was the case of death of Sir Robert Peel, the Prime Minister of UK, during 1835 and 1841 to 1846, following a fall from the back of a horse. Subclavian vessel. Subclavian vessels are torn by fragments and forced to clavicle may be led to even death. Serratus anterior. Serratus anterior is a broad sheath muscle that clothes the side of the upper thorax. Thus, strictly speaking, it is not a muscle, serratus anterior, of the pectoral region, but for convenience is described as within muscles. Origin and insertion scapulae. Fascia. Explain why cardiac muscles never fatigue. Cardiac muscles never get fatigued because of its prolonged refractory period, as this long refractory period ensures long and enough time for recovery of cardiac muscles from getting fatigue tired by getting nutrition or O2 supply. State the laws follow or during cardiac muscle contraction and their importance. Please write about all or none law and Frank Starlin's law. State the property of cardiac muscle that prevents the fatigability of heart. Property of cardiac muscles that prevents the fatigability of heart. Refractory period from above. Explain which of the property of cardiac muscle is responsible for heart function as a effective pump. Property of cardiac muscle responsible for heart function as effective pump. Please write about the functional syncytium from above. Functional syncytium. Syncytium means the whole tissue acts as electrically like a single large cell. The junctional complex between adjacent cardiac myocytes is called intercalated disc. The junctional complex between adjacent cardiac myocytes is called intercalated disc, which includes all types of intracellular junctions except tight junctions or an abundance of gap junctions. Syncytium means the whole tissue acts electrically like a single large cell. The junctional complex between adjacent cardiac myocytes is called intercalated disc. The junction complex between adjacent cardiac myocyte is called intercalated disc, which includes all types of intracellular junctions except tight junctions or abundance of gap junctions. The presence of numerous gap junctions results in rapid spread of ions from one cell to the adjacent cell and subsequent rapid spread of impulse. As a result, whole of the atrial ventricle muscle must contract at a time as a single cell, which is essential for effective pumping of heart. In a functional point of view, it appears that there is the individual cell boundary through its presence. This cardiac muscle can be considered a functional syncytium. They are structurally separate but functionally connected with one another by a gap junction. Atrial syncytium and ventricular syncytium. The two syncytiums are separated from each other by fibrous band. Only AV bundle of his makes connection between the two syncytium. Action potential of cardiac muscle. Action potential of cardiac muscle. Phase 0. Depolarization due to rapid sodium influx through the fast sodium channels. Phase 0. Depolarization. Phase 1. Initial repolarization. Phase 2. Plateau. Phase 3. Last rapid repolarization. Phase 4. Pacemaker potential. So action potential of cardiac muscles. The first is depolarization, the second is initial repolarization, and then plateau, and then last rapid repolarization, and then pacemaker potential. Depolarization due to rapid sodium influx through the sodium channels. Depolarization happens due to rapid sodium influx.
And then initial repolarization happens due to closure of sodium channels and potassium efflux. Sodium influx and potassium efflux from -90 to +20, 0 to +20. The plateau, sodium efflux, calcium influx through the sodium-calcium channels. Calcium influx to sodium channels. Calcium influx. Last, rapid repolarization, increase sodium efflux due to prolonged opening of sodium channels, closure of calcium channels. Inside the cell, negative due to greater potassium conductance. Inside the cell due to negative potassium conductance. Draw and level the rhythmical action of potential that is generated in SA node. So minus 60 resting potential and then threshold voltage, and then back to resting potential and then sinus nodal fiber, and then back to ventricular muscle fiber. Seconds and millivolts. Draw and level the action potential of ventricular muscle. What is plateau? Plateau is a prolonged or sustained period of depolarization which occurs in cardiac muscle. Plateau is a prolonged or sustained period of depolarization which occurs in cardiac muscle. Plateau is a prolonged or sustained period of depolarization. Plateau is a prolonged or sustained period of depolarization. Which occurs in cardiac muscle. The plateau. Causation of plateau in cardiac muscle. Plateau occurs due to two types of ion channel present in cardiac. Plateau occurs due to two types of channel present in cardiac muscle. Voltage gated calcium sodium channels, slow channels which are slow to open but remains open for prolonged period. Calcium sodium channels and voltage gated potassium channels which are slower than usual to open. Voltage gated sodium channels which are slow to open but remains open for a prolonged time. Which are slow to open but remains open for two types of channels: calcium sodium channel, voltage gated calcium sodium channel, and voltage gated potassium channel. At first, depolarization occurs due to sodium influx through the fast sodium channels. The initial rapid repolarization occurs due to closure of fast sodium channels. Thereafter occurs the slower but prolonged opening of voltage gated calcium sodium channels. During this time, a large quantity of both calcium and sodium ions enter the cardiac muscle fiber, and this maintains a prolonged period of depolarization, causing the plateau in the action potential. A second factor partially responsible for plateau is slower opening of voltage gated sodium channels. This delayed potassium efflux, which delays the return of membrane potential towards the resting value, -80 to -90 millivolt. So this period of depolarization becomes more prolonged when plateau occurs. A second factor partially responsible for plateau is slower opening voltage gated sodium channels. This delays sodium efflux, which delays the number of membrane potential towards the resting value. So the period of depolarization becomes more prolonged and plateau occurs. Importance: the plateau greatly prolongs the period of depolarization and causes the contraction of heart muscle to last for a long period. The plateau greatly prolongs the period of depolarization. Plateau depolarization prolongs the depolarization and contraction of the heart muscle to last for a long period. Contraction of the heart for a long period and muscle, and because of the prolonged period of contraction, the heart muscle can pump all its blood.
Compare the action potential of SA node to that of cardiac muscle. Traits action potential of SA node, action potential cardiac ventricular muscle. An upstroke of action potential, largely due to calcium with little contribution by sodium influx. Largely due to sodium with little contribution of sodium influx. So action potential as a node largely due to calcium with little contribution to sodium influx, and largely due to sodium with little contribution of calcium influx. Action potential develops slowly, speed. Action potential develops rapidly. Resting moment potential minus 50 to minus 60. Resting moment potential minus 85 to minus 90 of cardiac muscle, ventricular muscle. Depolarization caused by slow sodium calcium sodium channels, so there is no sharp, rapid or depolarized spike. Caused by the sodium channel, so the calcium sodium channel, so depolarization is sharp and rapid. Prepotential. As a node has prepotential that affect each impulse, declines to the firing level and triggers the next impulse. Atrial and ventricular muscles do not have prepotentials. External stimulus can develop without external stimulus due to self-excitation. Cannot develop without external stimulus. So as a node can develop in self-excitation, cannot develop without external stimulus. What do you mean by junctional tissue of heart? Junctional tissue of heart. Junctional tissue of the heart. Cardiac muscle consists especially of certain specialized structures which are responsible for initiation and transmission of cardiac impulse at a regular and faster rate than rest of the muscle. They are called junctional tissue of the heart. Cardiac muscle consists especially of certain specialized structures which are responsible. Junctional tissue of the cardiac consists of specialized structures which are responsible for initiate and transmission of cardiac impulse at a regular and a faster rate than rest of the muscle. They are called junctional tissue of the heart. These are specialized tissues of heart which are concerned with initiation and propagation of the cardiac impulse. The junctional tissue are as follows. As a node, sinoatrial node, the inner nodal pathways anterior, middle and posterior. AV node, atrioventricular node, and AV bundle of Hayes, right and left bundle of branches and Purkinje fiber. Rate of generation of their impulses. As a node, 0.5 ms impulse, 70 to 80. AV node, 0.5 ms, 0.5 ms, 0.5 ms, 40 to 60. AV bundle, 1 millisecond, and then Purkinje fiber, 4 millisecond. Explain how cardiac impulse is generated automatically. SA node. The SA node or sinoatrial node is one of the junctional tissues of the heart. It is a small flattened ellipsoid strip of specialized muscle. SA node is one of the junctional tissues of the heart. It is a small flattened ellipsoid strip of specialized muscle. Size 15 millimeters long, 3 millimeters wide, 1 millimeter thick. 15 millimeters long, 1 millimeters wide, and 1 millimeter thick. Location in the superior posterolateral wall of the right atrium, immediately below and slightly lateral to the opening of the superior vena cava. Connection. The SA nodal fibers connect directly with the atrial muscle fiber, so that any action potential that begins in the SA node spreads immediately into the atrial muscle wall. Properties. Resting membrane potential minus 55 to 60 millivolts. Rate of impulse generation 70 to 80 impulse per minute. Spread of conduction 0.05 millisecond. Blood supply in 75% of cases right coronary artery, in 30% of cases left coronary artery. Right coronary artery and left coronary artery. connection. These sinus nodal fibers connect directly with the atrial muscle fiber so that any action potential begins in the sinus node spreads immediately into the atrial muscle wall. Generation of action potential cardiac impulse in SA node. Cardiac impulse in generated or originate in the SA node automatically and rhythmically. The SA node can generate the impulses spontaneously because of self-excitation. Because of self-excitation.
Conduction or speed of the cardiac impulse through the heart. As after generation, cardiac impulse spreads through the heart through the junctional tissue. Depolarization, cardiac impulse is generated in the SA node. Spread.
Depolarization, cardiac impulse is generated in the SA node. Depolarization, cardiac impulse is generated in the SA node, spread of radially through the entire atrial volume. তাহলে কি depolarization or cardiac impulse is generated in the SA node, which spreads radially through the entire atrial muscle, reaches AV node through the internodal pathways, then reaches the AV bundle and its branches, then reaches the Purkinje fiber. Finally
তোমাদের দুর্গাপূজা বন্ধ করিয়ে ফেলছে reaches all the ventricular muscle. Depolarization of the ventricular muscle starts at the left side of the interventricular septum and moves first to the right across the mid portion of the septum. Septal activation from the left to right. Activation of the atrioseptal region of the ventricular myocardium. The activation of the major portion of the ventricular myocardium from the endocardial surface.
তাহলে কি late activation of posterobasal portion of the left ventricle, the pulmonary conus and the uppermost portion of the septum. SA node, AV node.
কাকে কিন্তু
It is a diagram that channels responsible for pacemaker potential and action potential. Comparison of action potential in ventricular muscle and a diagram of the membrane of potential in pacemaker. T long and T translucent. Write down the cholinergic and androgenic stimulation of SA nodal membrane.
Genic stimulation on SA nodal membrane. Stimulation of the parasympathetic nerves or cholinergic to the heart, the vagi, causes the hormone of the acetylcholine to be released at the vagal endings. This hormone has two major effects of the heart. It decreases the rate of the rhythm of the sinus node. It decreases the excitability of the AV junctional fibers between the atrial muscular and AV node, thereby slowing transmission of the cardiac impulse into the ventricles. Advantage: stimulation of the SA nodal membrane, stimulation of the sympathetic nerves.
Androgenic stimulation of the SA nodal membrane.
Stimulation of the sympathetic nerves, androgenic release of the hormone norepinephrine at the sympathetic nerve endings and causes essentially the opposite effects of the heart to those caused by the vagal stimulation as follows. It increases the rate of the sinus nodal change. It increases the rate of the contraction as well as the level of the excitability of all portion of the heart. It increases greatly the force of the contraction of all cardiac musculature, both atrial and ventricular.
Write a short about AV node.
Posterior wall of the right atrium, immediately behind the tricuspid valve. Location.
Function. Receives impulse originated in SA node and transmits into the ventricles via bundle of His.
Rate of rhythm.
It delays the transmission of impulse from atria to ventricles to allow the time for atria to empty their blood into the ventricles before ventricular contraction begins. Act as a reserve pacemaker.
Act as a reserve pacemaker. When SA node fails, then AB nodal generates impulse. Rate of rugosity 40 to 60 impulse per minute. Conduction rate 0.5 minute per second. আবার শুনছি
এরপরে AV nodal delay. AV node and its adjacent conductive fibers delay the transmission of impulse from the atria into the ventricles. This delay in impulse transmission is known as AV nodal delay. It is about 0.09 second. Cause of AV nodal delay. Junctional fibers of the AV node are very small in size. Cells are embryonic type. Junctional fibers of the AV node. Very few gap junctions. Prolonged refractory period of the AV nodal fibers. Resting membrane potential of these fibers are much less negative than the normal resting membrane potential of the cardiac muscle. Significance of the AV nodal delay.
delay allows time for the atria to empty their blood in the ventriculars before ventricular contraction begins. Atria and the ventricular systole does not override with each other.
What is ectopic pacemaker?
The ectopic pacemaker elsewhere than the SA node is called the ectopic pacemaker. Causes the occasionally some other part of the heart such as AV node or Purkinje fibers of the atrial ventricular muscle develops a rhythmical discharge rate that is more rapid than that of the SA node. In that case, the pacemaker of the heart shifts from the SA node to that part of the heart. Another cause of the shift of the pacemaker is blockage of transmission of the impulses from the SA node to other parts of the heart. The new pacemaker that then occurs most frequently at the AV node or in the AV bundle. Importance: an ectopic pacemaker causes the abnormal frequency of the contraction of the different part of the heart can causes the significant debility of the heart pumping.
Alright.
Kutupundo.
What is the reserve pacemaker? Where SA node fails to generate impulse, the AV node becomes the pacemaker and produces impulse at the own rate of 40 to 60 beats per minute. Then the heart contracts at a rate of 40 to 60 impulse per minute. So it is called the reverse pacemaker. Right and short about AV bundle. Functions: conducts atrial impulse into the ventricles. When SA node and AV node both fail, bundle can originate impulse. Parts: penetrating parts and dorsal portion. Rate of rhythmicity 60 to 65 impulse per minute. Contraction velocity 1 millisecond per minute. The role of Purkinje fiber. The Purkinje system controls the Purkinje fiber, which arises from the branch of the bundle of His. It spreads from the interventricular septum directly to the pulmonary muscle and then to the lateral walls of the ventricle, ending ultimately with the subendocardial network. Its fibers spread into all parts of the ventricular myocardium. Properties of Purkinje system.
Properties of the Purkinje system. The diameter of the fibers large in the comparison of the to ordinarily cardiac muscle fiber. Purkinje cells contain large amount of the sarcoplasm and large amount of the glycogen. Myofibrils of the fiber are present mostly in the periphery of the cells and central space occupied by glycogen. The conduction velocity 4 minute per second. Rate of generation of the cardiac impulse 15 to 40 per minute.
Functions: to conduct impulse quickly to every part of the ventricular fiber muscle. It can also initiate impulse in case of atrioventricular dissociation at the rate of 15 to 40 impulse per minute. Impulse quickly every part of the ventricular muscle. It can also initiate impulse in case of atrioventricular Dissociation at the rate of 15 to 40 impulses per minute. Nice to know. Speed of conduction of Purkinje fiber is higher, 4 milliseconds due to presence of more gap junction. Length of Purkinje fiber is long. Nerve supply of the heart. Nerve supply. The heart is supplied by automatic nerve systems, sympathetic and parasympathetic. Sympathetic.
সিম্প্যাথেটিক কি? সিম্প্যাথেটিক নার্ভ না, তুমি চিন্তা করতেছো একটা জিনিস।
চিন্তা কর লাফাস
বন্ধ করছো? না না,
sympathetic nerve.
এই তোমার ডাক্তার
Sympathetic nerve,
স্কিনের ডাক্তার সাপ্লাইড, দি হার্ট ইজ সাপ্লাইড বাই দি অটোমেটিক নার্ভাস সিস্টেম। কই এইটো, the heart rate is supplied by the autonomic nervous system, sympathetic and parasympathetic. Sympathetic nerve fibers arises from the lateral horn cell of the upper thoracic part, especially from the thoracic tree and thoracic floor. They are controlled by the nerve vasomotor centers, neurotransmitter, non-epinephrine effect. The increase of the force of contraction increase the heart rate. Supplies all parts of the heart, predominantly to the ventricular muscle. ভগবান রক্ষা করছে।
Parasympathetic nerve. Fibers arise. Parasympathetic nerve. Fibers arise from the nucleus ambigenous of medulla oblongata, give origin to some fibers of vagus, and finally terminate on heart. Neurotransmitter acetylcholine. Neurotransmitter acetylcholine effect.
Decrease the heart rate and decrease the force of contraction.
Decrease the heart rate, decrease the force of
এখন
contraction.
কাউকে আনা দরকার নেই। The acetylcholine effect decrease the heart rate, decrease the force of contraction, but the parasympathetic has the less effect on force of the contraction. Supply the SA node, epinode less than muscle of the atrial and lesser of the ventricle. What is the vagal tone? It is the inhibitory control of the vagus nerve. তাহলে vagal tone কি? Inhibitory control of the vagus nerve over the heart rate and atrioventricular contraction. Vagal tone is the degree of the activity occurring within the parasympathetic nervous system, resulting in the changes to the heart rate and other key function. The vagus nerve, among many other things, inhibits the heart rate to keep the organ begin within a safe range. When the vagal tone increases or decreases, a patient will experience charged in heart rate, and thus can sometimes become dangerous or even fatal.
Effects of sodium and potassium ions in heart function.
Effects of potassium, sodium potassium and calcium. Potassium heart. Potassium plays an important role in generating the resting membrane potential and allowing the propagation of the action potential. The resting membrane potential allowing the propagation of the action potential along the myocardial fibers. So it is crucial for cardiac tissue. Change in the plasma potassium level produce severe cardiac abnormalities. Effect of the hyperkalemia. Hyperkalemia is very dangerous and potentially lethal condition because of its effect on the heart. Ventricular arrhythmia, heart stop the diastole. The resting membrane potential of the muscle fibers decreases as the extracellular potassium concentration increases. The fibers eventually become the unexcitable and the heart stops in diastole. Effects of the hypokalemia. Hypokalemia is a serious condition, but it's not in rapidly fatal as hyperkalemia. Cardiac arrhythmia, a long
Hyperkalemia. Cardiac arrhythmias is a long QT syndrome, ventricular ectopics, etc. Effects of calcium on heart.
calcium hypercalcemia, এটা কি hypokalemia, hyperkalemia, এটা hypercalcemia. Increased extracellular calcium in concentration and hence myocardial contractility, so the heart relax less during diastole and eventually stop the systole. Calcium rigor. Hypokalemia, cardiac weakness and prolonged QT interferes on ECG.
State the effects of temperature on cardiac muscle. Increased body temperature, such as the which occurs during fever, greatly increases the heart rate, sometimes to double the normal rate. Decreased temperature greatly decreases heart rate, which may fall to low at a few beats per minute when a person is near death from hypothermia. The body temperature ranges from 60 to 70 degrees Fahrenheit or 15 degrees to 21 degrees Celsius. These effects presumably result from the fact that heartbeat increases the permeability of cardiac muscle membrane to arms that control heart rate, resulting in acceleration of cell excretory process. Contractile strength of the heart often is enhanced temporarily by moderate increase of temperature, such as which occurs during body exercise. But prolonged temperature elevation exhausts the metabolic system of the heart and eventually causes weakness. Therefore, optimal heart function depends greatly on proper control of body temperature by the control mechanisms. Humerus. The humerus is a long bone of the arm. It is the longest and the strongest bone of the upper limb, which extends from the shoulder to the elbow. Parts. It consists of three parts: upper rounded end, lower flattened end, and long middle shaft. Upper end. The upper end presents the following five features: head, neck, great tubercle, lesser tubercle, intertubercular sulcus. So the head, the neck, the great tubercle, and the lesser tubercle, and the intertubercular sulcus. The head is smooth and rounded and forms less than half of a spear. The head forms less than half of a spear. It is directed medially backwards and forwards. Directed medially backwards and upwards. It articulates with the glenoid cavity of the scapula to form the glenohumeral shoulder joint. Lower end. The lower end presents the following seven features: capitulum, a lateral rounded convex projection; trochlea, a medial pulley-shaped structure; and radial fossa, a small fossa above the capitulum. So capitulum, a lateral rounded convex projection; trochlea, a medially shaped structure; and radial fossa, a small fossa above the capitulum; and coracoid fossa, a small fossa above the trochlea, and a medial epicondyle, a prominent projection on the median side. Lateral epicondyle, a prominent projection on the lateral side. Epicondyle, prominent projection on the left side, but less than the median epicondyle. Olecranon fossa, a large deep hollow on the posterior aspect of the trochlea. Shaft. The shaft is long part of the bone, extends between the upper and the lower ends. It is cylindrical in the upper half and flattened anterior posteriorly in the lower half. It is cylindrical in the upper half and flattened anterior and posteriorly on the lower half. Anatomical position and side determination. The side of the humerus can be determined by holding it in a vertical in such a way that the rounded head at the upper end faces medially. Backwards and upwards. The rounded head at the upper end faces medially backwards and upwards. The rounded head at the upper end faces medially backwards and upwards. The lesser tubercle, greater tubercle, and vertical groove. The lesser tubercle and the greater tubercle and the vertical groove, intertubercular groove at the upper end faces anteriorly. The olecranon fossa at the lower flattened end faces posteriorly. Features and attachments. Upper end head. It is smooth, rounded, and forms one third of the sphere. One third of a sphere. It is covered by an articular hyaline cartilage, which is thicker in the center and thinner in the periphery. Which is thicker in the center and thinner in the periphery. Neck. The humerus has three necks. Anatomical neck. It constriction at the margin of the rounded head. It provides attachment to the capsular ligament of the shoulder joint, except superiorly. It provides attachment to the capsular ligament of the shoulder joint, except superiorly, where the capsule is deficient. For the passage of the tendon of the long head of the biceps brachii. Passage of the tendon biceps brachii. Medially, the capsule extends down from the anatomical neck to the shaft. Medially, the capsule extends from the anatomical neck to the shaft about 1 to 2 centimeters. Surgical neck. It is short constriction in the upper end at the shaft below the greater and the lesser tubercle. It is short. Surgical neck. It is short constriction in the upper end of the shaft below the greater and the lesser tubercle. It is short constriction in the upper end of the shaft below the greater and the lesser tubercle, below the epiphyseal line. Below the epiphyseal line. It is related to the axillary nerve and posteriorly and anterior circumflex humeral vessels. Related to the axillary nerve and posteriorly and anteriorly circumflex humeral vessels. Anterior circumflex humeral vessels. It is the most important feature of the proximal end of the humerus because it is weaker than the more proximal regions of the bone. Hence, it is one of the sites where the humerus commonly fractures, leading to the damage of associated nerves and vessels. Morphological neck. It is the junction between diaphysis and epiphysis. It is the junction between diaphysis and epiphysis. It is represented by an epiphyseal line in the adult bone. It is the junction between the diaphysis and epiphysis. It is represented by an epiphyseal line in the adult bone. It is a true junction of the head with the shaft. Morphological neck. It is the junction between diaphysis and epiphysis. Morphological neck, diaphysis and epiphysis. It is represented at the epiphyseal line in the adult bone. It is a true junction of the head and with the shaft. So it has humerus has three necks: anatomical, surgical, and morphological. Anatomical, surgical, and morphological. Greater tubercle. It is the most lateral part of the greater tubercle. It is the most lateral part of the proximal end of the humerus. Greater tubercle. So anatomical neck, head, lesser tubercle, and then greater tubercle, and then lateral lip, medial lip, bicipital groove, and then surgical neck, and then morphological neck, and then median border, anterior median border, and then anterior border, median border, deltoid tuberosity, nutrition foramen, short shaft of the humerus, nutrition foramen, shaft of the humerus, anterior lateral surface, and then anteromedial surface, anterolateral surface, and then anteromedial surface. Large supracondyle ridge, medial supracondyle ridge. Coracoid fossa, radial fossa, medial epicondyle, lateral epicondyle, capitulum, and then trochlea. Anatomical neck, head. Morphological neck, and then impression for supraspinatus, impression for infraspinatus, supraspinatus, infraspinatus, and impression for teres minor, oblique ridge, and then deltoid tuberosity, a spiral groove. Shaft of the humerus, lateral border, median border, posterior surface, olecranon fossa, median epicondyle, lateral epicondyle, trochlea. The greater tubercle is the most lateral part of the proximal end of the humerus. It is posterior superior aspect, bears the flattened facet-like impression, upper, middle, and lower, which provide attachment to supraspinatus, infraspinatus, and teres minor muscle respectively. Mnemonic SIT, supraspinatus, infraspinatus, and teres minor. Supraspinatus, infraspinatus, and teres minor. Lesser tubercle, it is small elevation on the front of the upper end of the humerus, just above the surgical neck. It provides attachment to the subscapularis muscle. Attachment to the subscapularis muscle. Lesser tubercle is a small elevation on the front of the upper end of the humerus, just above the surgical neck. It provides attachment to the suprascapularis muscle, subscapularis muscle, intertubercular sulcus or bicipital groove. It is a vertical groove between the lesser and the greater tubercle. It contains the long head of the biceps. So the long head of the biceps, enclosed in the synovial sheath and ascending branch of the anterior circumflex humeral artery. So it contains the long head of the biceps enclosed in the synovial sheath, the ascending branch of the anterior circumflex humeral artery, the long head of the biceps enclosed in the synovial sheath, long head of the biceps, and the ascending branch of the anterior circumflex humeral artery. Three muscles are attached to the region of this groove. Pectoralis major on the lateral lip in this groove. Pectoralis major on the lateral lip of the groove, and then teres minor on the medial lip of the groove, and a latissimus dorsi on the floor of the groove. Mnemonic: lady between two majors. L stands for latissimus dorsi. Two majors, pectoralis major and teres major. So supraspinatus, subscapularis. Supraspinatus, subscapularis. Capsular ligament shoulder joint, head. Pectoralis major, latissimus dorsi, and teres minor. Morphological neck, and then deltoid, and then coracobrachialis, and then brachialis, coracobrachialis, brachialis, brachioradialis, and then extensor carpi, brachialis, and then extensor carpi, and pronator teres, and then capsular ligament of elbow joint, common flexor origin. Trochlea, capitulum, common extensor origin, common flexor origin, common extensor origin, extension carpi, and then head, supraspinatus, infraspinatus teres minor, capsular ligament of the shoulder joint, capsular ligament of the shoulder joint, capsular ligament, teres major, surgical neck, lateral head of the triceps brachii, lateral head of the triceps brachii, spital groove, and then deltoid, median head of the triceps brachii, shaft. The upper part of the shaft is cylindrical and its lower part is triangular in cross section. It has 3 borders and 3 surfaces. 3 borders and 3 surfaces. Borders: anterior border, and then exterior border, anterior border, median border, and lateral border. Anterior border, it starts from the lateral lip. Anterior border starts from the lateral lip of the intertubercular sulcus. Lateral border. Shaft borders, lateral tubercular lip of the intertubercular sulcus extends down the anterior margin of the deltoid tuberosity and becomes smooth and rounded in the lower half. Where it extends in the radial fossa. Median border, it extends from the medial lip of the intertubercular sulcus down the medial epicondyle. The lower part is sharp and called the median supracondyle ridge. The ridge provides attachment to the medial intramuscular septum. The ridge provides attachment to the medial intramuscular septum. A rough strip on the middle of this border provides insertion to the coracobrachialis muscle. A narrow area above the medial epicondyle provides origin to the humeral head of the pronator teres. A lateral border. Its upper part is indistinct while its lower part is prominent, where it forms the lateral supracondylar ridge. Above the lateral supracondylar ridge, it is ill-defined but traceable to the posterior part of the greater tubercle. Lateral border. Its upper part is indistinct, while its lower part is prominent, where it forms the lateral supracondylar ridge. Above the lateral supracondylar ridge, it is ill-defined but traceable to the posterior part of the greater tubercle. Posterior part of the greater tubercle. And about in the middle, the border is crossed by the radial groove from the behind. About in the middle, the border is crossed by the radial groove. The lower part of the border, lateral supracondylar ridge, provides attachment to the lateral intermuscular septum, brachioradialis, except carpi, external carpi radialis longus. Surfaces: anterior and lateral surface. Anteromedial surface, posterior surface. Anterolateral surface. It lies between the anterior and lateral borders. A little groove in the middle. This surface presents a characteristic V shape. The deltoid tuberosity, which provides insertion to the deltoid muscle. In anteromedial surface, it lies between the anterior and the medial borders. The upper part of this surface forms the floor of the intramuscular sulcus. The upper part of this surface forms the floor of the intermuscular anterior lateral surface. It lies in between the anterior and the lateral borders. Anterior surface, anterior and lateral borders. Anterior and lateral borders. A little groove in the middle. This surface presents a characteristic V-shaped tuberosity. The deltoid tuberosity, which provides insertion in the deltoid tuberosity. Anterior medial surface. It lies in between the anterior and medial borders. The upper part of the surface forms the floor of the intertubercular sulcus, and inward is middle closes the medial border. Lower end. It is flattened from backwards. It is flattened from before backwards and expanded in side to side. It is flattened. So the lower end, it is flattened from before backwards and expanded to side. The capitulum, rounded convex projection laterally, articulates with the head of the radius. The head of the capitulum, the head of the radius, and the trochlea, pulley-shaped projection medially, articulates with the trochlear notch of the ulna, and the trochlea articulates with the trochlear head of the ulna. The ulnar nerve is related to the posterior surface of the The ulnar nerve is related to the posterior surface of the medial epicondyle. Posterior surface of the medial epicondyle. The ulnar nerve is related to the posterior surface of the medial epicondyle. The ulnar nerve is related to the posterior surface of the median epicondyle. The anterior surface of the medial epicondyle provides an area for the common flexor origin of the superficial flexure of the forearm. The anterior surface of the medial epicondyle provides an area for the common flexor origin of the superficial flexures of the forearm. The anterolateral part of the lateral epicondyle provides an area for the common extensor origin. The posterior surface of the lateral epicondyle gives origin to the anconeus muscle. The coracoid process of the ulna fits into the coronoid fossa above the trochlea during full extension of the elbow. Ulna fits into the coracoid. The coracoid process of the ulna fits into the coracoid fossa. The head of the radius fits into the radial fossa during full extension of the elbow. The head of the radius fits into the radial fossa into the flexor elbow. The olecranon process of the ulna fits into the olecranon fossa, posterior aspect of the trochlea during the full extension of the elbow. The capsule of the elbow joints is attached above the coracoid and radial fossa anteriorly and above the olecranon fossa posteriorly. Note 12. Supratrochlear process. It is a small hook-like bony process that may sometimes supratrochlear process. They may arise from the anteromedial surface about 5 cm above the lower end of the humerus. A fibrous band called Schurter's ligament stretches from into the medial epicondyle. In such cases, the branchial artery along the medial nerve diverges from the normal occurs under pressure of Schurter's ligament and may compressed. Sometimes a bony bar separates the coracoid and olecranon fossa. It perforates and forms the supratrochlear foramen. The angle of the humeral tension. It is an angle formed by the superimposition of the long axis of the upper and the lower articular surface of the humerus. Nerves directly related to the humerus. The three nerves, axillary, radial, and ulnar, closely related to the back of the humerus follows. Axillary nerve around the cervical neck. Radial nerve in the radial or the spital groove, in the radial groove. Radial nerve. Ulnar nerve behind the medial epicondyle. Ulnar nerve behind the median epicondyle. Mnemonic anti reacts unnecessarily. Therefore, these nerves are often involved in the structure of the humeral and above sides. Common sites of the fracture of humerus. These are surgical neck, mid shaft, and supraclavicular region. Fracture surgical neck of the humerus, the most frequently fractured site of the humerus, especially elderly above 65 years due to osteoporosis. Mid shaft fracture of humerus. It occurs in 3% of cases due to fall or high energy injuries. For example, motor vehicle collisions, etc. In the older people, it occurs due to weakening of bones and osteoporosis. Supracondylar fracture of the humerus. It is caused by a fall of the outstretched hand and commonly occurs in young age. Clinically, it presents a backward displacement of the lower fragment with an unduly prominent elbow. However, the three bony points of the elbow still form the usual quadrilateral triangle because of the olecranon process. Axillary nerve and radial nerve and ulnar nerve. Axillary nerve, radial nerve, and then ulnar nerve. Upper fragment of the humerus, kinking of the brachial artery. Lower filament of humerus, line joining the tip of the humerus epicondyle and tip of the olecranon process of the ulna. Ossification of the humerus, upper and lower end. Always moves with the lower fragment. Details. This fracture may cause injury to the medial nerve and occlusion on the back of the brachial artery. The injury of the brachial artery may cause Volkmann's ischemic contracture and myosis ossification. The occlusion of the brachial artery causes ischemia of the anterior of the compartment of foramen, leading to increased pressure and swelling within it. It results in a shortening of muscles due to hypoxia. Medial nerve. It is commonly involved in the supracondyle fracture of the humerus. Note 12. Non-union of the fracture of the humerus is common if fracture occurs at the junction of its upper 1/3 and middle 1/3 due to poor blood supply. Ossification. The humerus is formed by cartilaginous ossification by the primary and 7 secondary centers. 1 primary and 7 secondary centers. These are 1 primary center for the shaft, 3 secondary centers for the upper end, 4 secondary centers for the lower end. The site of appearance, time, and appearance fusion with the center is given table. Clinical correlation. The separate centers of the medial epicondyle and its late union with the shaft may be mistaken for fracture, or median epicondyle of the humerus. Median epicondyle and its late union shaft may be mistaken for fracture.
Humerus. Humerus is the long bone of the arm. It is the longest and the strongest bone of the upper limb, which extends from the shoulder to the elbow parts. It consists of 3 parts: upper rounded end, lower flattened end, and long middle shaft. The upper end presents the following 5 features: head, neck, greater tubercle, lesser tubercle, and intertubercular sulcus. The head is smooth and rounded and forms the less than half of a sphere. It is directed medially, backward, and upward. It articulates with the glenoid cavity of the scapula from the glenohumeral joint. Lower end. The lower end presents the following 7 features: capitulum, a lateral rounded convex projection; trochlea, a medial pulley-shaped structure; rounded convex projection in radial fossa, a small fossa above the capitulum. Radial fossa, a small fossa above the capitulum. Coracoid fossa, a small coracoid fossa, a small fossa above the trochlea. Medial epicondyle, a prominent projection on the medial side. Lateral epicondyle, a prominent projection on the lateral side but less than the medial epicondyle. Olecranon fossa, a large deep hollow on the posterior aspect above the trochlea. A large deep hollow on the posterior aspect of the trochlea. Shaft. The shaft is a long part of the bone extending between its upper and lower ends. It is cylindrical in the upper half and flattened on the anterior posterior on the lower half. Anatomical position and site determination. The site of the humerus can be determined by holding it vertically in such a way that the rounded head of the upper faces medially, backward, and upward. The lesser tubercle, the greater tubercle, and the vertical groove at the upper end faces anteriorly. The olecranon fossa at the lower flattens and faces posteriorly. Features and attachments. Upper and head. It is smooth, rounded and forms one-third of a sphere. It is smooth, rounded and forms one-third of a sphere. It is covered by articular hyaline cartilage, which is thicker in the center but thinner in the periphery. Humeral has three necks. Anatomical neck. It is constriction at the margin of the rounded head. It provides attachment to the scapular ligament of the shoulder joint, except superiorly where the capsule is deficient for the passage of the tendon of the long head of biceps brachii. Biceps brachii. Medially, the capsule extends from the anatomical neck to the shaft for about 1 to 2 centimeters from the anatomical neck, and then from down from the capsule extends down from the anatomical neck to the shaft about 1 to 2 centimeters. Surgical neck. It is short constriction in the upper and at the shaft below the greater and the lesser tubercle. It is surgical. It is short constriction in the upper end of the shaft. It is short constriction, surgical neck, in the upper end of the shaft below the greater and the lesser tubercle. Below the epiphyseal line. It is related to the axillary nerve and posterior and anterior circumflex humeral vessels. It is related to the axillary nerve and posterior and anterior circumflex humeral vessels. It is the most important feature of proximal end of the humerus because it is weaker than most of the proximal regions of the bone. Hence, it is one of the sites where the humerus commonly fractures, leading to damage of associated nerves and vessels. Morphological neck. It is the junction between diaphysis and epiphysis. It presents by an epiphyseal line in the adult bone in a true junction of the head with the shaft. And greater tubercle, the most lateral part of the proximal end of the humerus. It is the most lateral part of the proximal head of the humerus. It is posterior superior aspect, bears three flattened facet-like projections, upper, middle and lower, which provides attachment to the supraspinatus, infraspinatus and teres minor muscle. Lesser tubercle. It is a small elevation in front of the upper head of the humerus, just above the surgical neck. It provides attachment to the suprascapularis muscle. It provides attachment to the subscapularis muscle. Intertubercular sulcus or bicipital groove. It is a vertical groove between lesser and greater tubercle. It is a vertical groove between lesser and greater tubercle. It contains the long head of biceps, encloses the synovial sheath. It contains the long head of the biceps, encloses the synovial sheath, and ascending branch of the anterior circumflex humeral artery. Three muscles and attachments originate this group. Pectoralis major at the lateral leg of the group, teres major and the medial leg of the group, and latissimus dorsi at the floor of the group. Shaft. The upper part of the shaft is cylindrical and its lower part is triangular in cross section. It has three borders and three surfaces. Anterior border. It starts from the lateral leg of the intertubercular sulcus and extends down to the anterior margin of the deltoid tuberosity. And becomes smooth and rounded lower half where it ends in the radial fossa. It starts from the lateral. And then medial border. It extends from the medial lip of the intertubercular sulcus down the medial epicondyle. After the medial, its lower part is sharp and called the medial supracondylar ridge. Medial supracondylar parts are sharp and medial supracondylar ridge. The ridge provides attachment to the medial intramuscular septum. The ridge provides attachment to the medial intramuscular septum. A rough strip on the middle of this border provides insertion to the coracobrachialis muscle. A rough stitch in the medial border provides attachment to the coracobrachialis muscle. A narrow area above the medial epicondyle provides origin to the humeral head of the pronator teres. A narrow area above the epicondyle provides attachment to the humeral head of the pronator teres. Lateral border. The lateral border, its upper part is indistinct while its lower part is prominent. Its upper part is distinct while the lower part is prominent from the lateral supracondylar ridge. Above the lateral supracondylar ridge, it is well defined but traceable to the posterior part of the greater tubercle. In the middle, the border is crossed by the radial groove. The lower part of the groove, lateral supracondylar ridge, provides attachment to the lateral intermuscular septum, brachioradialis, and extensor carpi, brachioradialis, and extensor carpi radius longus. The lower part of the border, anterior surface, it lies between the anterior and the lateral border. A little groove in the middle. This surface presents a classical V shape. Anterior surface. The anterior surface and then anterior lies between the anterior border and the lateral border. Lateral border and anterior border. It presents a characteristic V-shaped tuberosity. The deltoid tuberosity provides inserted to the deltoid muscle. Interomedial surface. It lies between the anterior and the medial borders. Interomedial surface. It lies in between the anterior and the middle border. It lies between the anterior and middle border. The upper part of the shell forms the floor of the intertubercular sulcus. The middle crosses the medial border and presents a nutrient foramen. In the atriomedial surface and provides a nutrient foramen. Directed downwards. Posterior surface. The posterior surface lies in between the medial and the lateral border. In the upper 1/3 of the surface, there is an oblique ridge. 1/3 of the oblique ridge, there is an oblique directed laterally. The ridge provides origin to the lateral head of the triceps brachii. Below the medial ridge of the radial groove, it lodges a radial nerve and profundus brachii vessel. So a radial nerve and then profundus brachii vessel. The entire posterior surface below the spiral groove provides origin in the medial head of the triceps brachii. The entire posterior surface below the spiral groove. The anterior posterior surface below the spiral groove. Middle head of the triceps brachii. So profundus vessel and also radius nerve. Profundus vessel. Lower end. It is flattened from the before backwards and expanded in side to side. The flattened form of the back before the backward. The capitulum rounded convex projection laterally articulates with the head of the radius. And then trochlea pulley shaped projection medially articulates with the trochlear notch of the ulna. The ulnar nerve is related to the posterior surface and the medial epicondyle. The posterior surface of the medial epicondyle. And the anterior surface of the medial epicondyle provides attachment to the common circumflex origin of the circumflex, common flexor origin of the superficial flexor of the forearm, common flexor origin. The anterolateral part of the lateral epicondyle provides area for the common extensor origin. The posterior surface, the lateral epicondyle gives origin to the anconius muscle. So anconius muscle. So again we get the coracobrachialis, brachioradialis, and then common extensor origin, common flexor origin, common extensor origin, and then pronator teres, and then extensor carpi, brachia longus radius, and then anconius. So again, the coracoid process of the ulna provides coracoid fossa during full extension of the elbow, coracoid fossa, extension of the elbow, and the head of the radius fits into radius fossa during the full extension of the elbow. The olecranon process of the ulna fits into the olecranon fossa, posterior respiratory trachea during full extension of the elbow. The carpi capsule of the elbow joint is attached to the above the coracoid of the radial fossa anteriorly and avoid the olecranon fossa posteriorly. Note well. Supratrochlear process. It is a small hook-like bony process that may sometimes arise from the anteromedial surface. It is a hook-like bony process. Supratrochlear process. The supratrochlear process, foramen medial. The supratrochlear process. The supratrochlear process is a small hook-like bony project that may sometimes arise from the anterior surface, 5 cm above the lower of the humerus, in fibrous band called Struther's ligament attaches from the medial epicondyle. In cases, the brachial artery along with the medial nerve derives from the normal course and passes under the Struther's ligament. Struther's ligament and may be compressed. Sometimes a bony bar separates the coracoid and the olecranon fossa and performs the supratrochlear foramen. The angle of the humeral torsion. It is an angle formed by the superior imposition of the longer axis of the upper lower articular surface of the humerus. Nerves directed laterally related to the humerus. There are 3 nerves: axillary nerve, radial nerve, and ulnar nerve. The axillary nerve round around the surgical neck, the radial nerve in the radial and the spiral groove, ulnar nerve behind the medial epicondyle. And these nerves are often involved in the fracture of the humerus of sites. Common sites of the fractures of the humerus. These are surgical neck, mid and supracondylar region. Fractures in surgical neck. Most frequent fracture sites, humeral condyle over 65 years of during osteoporosis. Middle shaft of the humerus occurs 3% of the cases due to fall of high energy injuries, for example motor vehicle collisions, etc. Older people occurs in weakening of the bones and osteoporosis. Supracondylar fractures of the humerus. It is caused by a fall on the outer stretched hand and commonly occurs in the young age. Clinically, in presents a backward displacement of the lower fragment with the unduly prominent elbow. However, the 3 bony points of the elbow, for example medial epicondyle, lateral epicondyle, and olecranon process are still from the usual collateral because of the olecranon process. Always moves in the fragment. This fracture may injure the medial nerve and the brachial artery. The injury of the brachial artery may cause Bachmann's ischemic contracture. Bachmann's ischemic contracture. The brachial artery ischemic contraction leading to swelling of it, the results in shortening of muscle and hypoxia. The most common involved supracondyle fracture of the humerus. Nutrient foramen of the humerus is the most common. If fracture occurs in the junction of the upper one-third and middle one-third due to poor blood supply ossification. The humerus is formed by cartilaginous ossification. Primary 7 centers. There are 1 primary segment shaft, 3 primary segments in the upper end, 4 primary centers in the lower end. Sites of appearance, time of appearance, and of fusion of these centers given below. Separate case center for medial epicondyle and its late union may be mistaken for fractures of the medial epicondyle or the humerus. Third year and fifth year, third year, fifth year, second year, 10th year, 12th year, and 6th year. Brachial plus. The brachial plus is commonly felt in the cuboidal fossa medial to the tendon of the biceps, and its pulsations are auscultated for recording of blood pressure. The biceps tendon is easily palpable on flexing of the elbow. Method of taking blood pressure to taught in physiological practical case classes. Compression of the brachial artery. The brachial artery can be effectively compressed against the shaft of the humerus at the level of insertion of the coracobrachialis to stop the hemorrhage. Coracobrachialis to stop the hemorrhage on the upper limb shaft. Distal compression of the artery. For example, bleeding wounds of the pulmonary artery arches. Workman's ischemic contracture. The sudden complete occlusion of the brachial artery due to tight pulse caused or the laceration due to the supracondylar fracture of the humerus can cause fibers of the muscle of the forearm due to the muscles can tolerate ischemic up to 6 hours only. The muscles can tolerate 6 hours only. They are undergo necrosis, and the fibrous tissue replace necrosis tissue, and the fibrous tissue necrosis. As a result, the fibrous muscle shortens prematurely, producing flexure and deformity of the skin, claw, and characteristic by flexure of the wrist, extensor of the MP joints, and flexure of the IP joints, which leads to loss of hand power. So axillary nerve, teres, major, humerus, and then brachial artery, insertion of the coracobrachialis, site of compression of brachial artery, coracobrachialis, radial nerve, and then ulnar artery, radial artery, ulnar artery, brachial artery, humerus, rupture of the brachial artery, supracondylar fracture of the humerus, ulnar, supracondylar fracture of the humerus, and anterior anastomosis around the elbow. The anterior anastomosis around the elbow takes place between the branches of the brachial artery and forms the upper end of the radial and the ulnar arteries. For easy remembering, the anastomosis divides into parts: inferior medial epicondyle, in front of the medial epicondyle, and behind the medial epicondyle. Inferior ulnar artery and anterior ulnar artery, superior ulnar artery, posterior ulnar artery, and in front of the lateral epicondyle and behind the lateral epicondyle. So they are anterior descending artery, radial artery, recurrent artery, and posterior descending artery. So inferior ulnar, anterior ulnar, superior ulnar, posterior ulnar, anterior and radial recurrent artery, and posterior artery. Nerves of the muscularis nerve passing through the arm. The arm rises from the lateral to the medial cord of brachial plexus in the axillary and descends down in front of the arm. It closes related to the brachial artery through its course of the arm. Initially, it lies lateral to the brachial artery and crosses over the medial artery. As a result, the cuboidal fossa, it lies on the brachial artery. It is superficially located, except at the elbow where it is crossed by the brachial bicipital nerves. So nerve of the coracobrachialis, nerve of the biceps brachii, nerve of the brachialis, nerve of the cutaneous forearm, medial epicondyle, and then ulnar nerve. Note 12. The relationship of the medial nerve, the brachial artery in the arms as follows. In the upper part, lateral of the artery; in the middle part, crosses in front of the artery; in the lateral part of the medial side, and lower part, it is medial to the artery elbow branches. In the arm, the medial nerve gives rise to the following branches: nerve to pronator teres just above the elbow, nerve to pronator teres, vasomotor nerve, and then articular nerve. Ulnar nerve. The ulnar nerve arises from the medial cord of the brachial plexus of the axilla. It then runs downward on the medial side of the arm, medial to the brachial lateral, up to the insertion of the coracobrachialis. Here it pierces the medial intermuscular septum along with the superior ulnar brachial artery to the entire posterior of the arm. The elbow ulnar nerve passes behind the medial epicondyle of the humerus, where it can be easily palpated. Ulnar nerve does not give any branches to the funny bone. On either funny nor it is neither funny nor bone, but the name given part of the ulnar nerve because medial epicondyle humerus. This is because when medial condyle of the humerus, medial condyle of the humerus is knocked against a hard object, there is a feeling of tingling on the numbing around the medial side of the forearm. Funny bone is a nickname for ulnar nerve behind medial epicondyle and humerus because its funny feeling gets after the medial epicondyle hits against the object. Radial nerve. In axilla, in superior groove, posterior aspect of the arm. Clinical correlation. The radial nerve is commonly injured and the radial groove due to various reasons. Fractures of the humerus fauci leads to wrist drop, and then sensory loss of a narrow skin, and then lack of forearm, tingling of burning sensation back in the wrist, index finger and middle finger. Injury of the radial nerve. The radial nerve may be injured in three sites: in the axilla, in the spiral groove, and at the elbow. The nerve may be injured in three sites: the axilla, the spiral groove, the axilla. Injury of the radial nerve in the axilla, the spiral groove, and the elbow. Injury of the radial nerve. The axilla radial nerve may be injured by the pressure of the upper end of the crutch. Characteristic features will be motor loss, loss of extension of elbow due to paralysis of triceps, loss of extension of the wrist drop due to paralysis of wrist extension, caused wrist drop due to an opposed action of muscle of flexor muscle on forearm, loss of extensor ridges due to paralysis of extensor digitorum, extensor index and extensor digitum minimi, and extensor pollicis longus. Loss of supraspinatus in the extended below elbow. Supraspinatus brachialis are paralyzed, but supraspinatus becomes possible to flex elbow by action of biceps brachii. Loss of supination in extended elbow because supinator and brachialis are paralyzed. Supination becomes possible of influx elbow. Sensory loss. Loss on a small area of the skin over the posterior surface of the arm. Sensory loss along the narrow strip back on the forearm. Sensory loss of the dorsal end of the dorsal surface 1 to 2 digits, except the distal phalanges. More often, there is an isolated sensory loss of the dorsum at the end of the base of the thumb. Injury of radial nerve and radial spiral groove. The radial nerve may be injured due to midfist humerus invertly wrongly placed intramuscular junction, direct pressure on the radial nerve, and feeling asleep on the one arm over the back of the chair. One arm on the back of the chair. Saturday night paralysis. Injury of the radial nerve. Injury to the radial nerve occurs most commonly in the distal part of the groove, beyond the origin of the nerve to be triceps and cutaneous nerves. Characteristic clinical features in such cases will be as follows: motor loss of extensor in wrist fingers, wrist drop, loss of sensation of arm extended. Sensory loss. It is restricted only to a variable small area of the dorsal head between the first and the second metacarpals. Extension of the elbow is possible in ever lesion, but may be little weak because nerve of two long hairs of the triceps maxilla before the site of lesion. And then injury of the radial nerve at elbow. The radial tunnel syndrome. It is an entrapment neuropathy to the deep brachii of the radial nerve elbow. The compression of the radial nerve at elbow may be caused by the following factors: fibrous bands which can below the nerve of the radiohumeral joint, sharp tendinous margin of the extensor carpi radialis brevis, less vessels, the radialis recurrent artery, or arc of fossa, and then characteristic features: loss of extensor fingers, wrist drop, pain, and extensor aspect of the forearm. Shoulder joint complex consists of four basic articulation, namely glenohumeral joint, acromoclavicular joint, sternoclavicular joint, and scapuloclavicular articulation. Normal function of the shoulder girdle requires smooth coordination of the movements of all of these joints. The impermanence of one of those joints leads to functional complex. So, shoulder joint, glenohumeral joint is a joint between the head of the humerus and the glenoid cavity of the scapula. The shoulder joint is most movable joint of the body and consequently one of the least stable. It is the most common joint of dislocation undergo recurrent dysostosis. Dislocations, therefore, the students may study very thoroughly type. It is a ball socket type of synovial joint. The shoulder joint is formed by the articulation of a large head of the humerus and the relatively shallow glenoid cavity scapula. The glenoid cavity is deep and just slightly, but effectively is deep and just slightly effectively, but fibrocartilaginous ring called glenoid labrum. Joint capsule. Thin fibrous layer of the joint capsule surrounds the glenohumeral joint. Attached to the medially to the margins of the glenoid cavity beyond the lateral to the acromial neck of the humerus, except inferiorly where it extends. So the glenoid cavity beyond the glenoid labrum and laterally to the anatomical neck of the humerus, except inferiorly where it extends downward to 1.5 centimeters or more to the surgical neck of the humerus. 1.5 centimeters. Medially, the attachment extends beyond the supraannular tubercle and encloses the long head of the biceps brachia within the joint cavity. So you can see ligament, coracoacromial ligament, coracohumeral ligament, and transverse humeral ligament. Bicipital group, loose fold of the joint capsule. Medial to the attachment extends below the tubercle, thus enclosing the long head of the biceps brachii joint cavity. The capsule remains lax to allow the mobility of the shoulder. Hence, the upper limb for stability relies on the ligaments. The muscle tendons surround the head of the rotator cuff. The anterior aspect of the capsule thickens in its inner aspect of three special glenohumeral ligaments. The coracoacromial arch acts as secondary socket. The coracoacromial arch acts as secondary socket of the humerus, which is further strengthened by long head of the biceps brachii, which runs intracapsularly and forms a dome-shaped arch over the humeral head to prevent its upward displacement. Humeral head. So coracoacromial process, acromial process, coracoacromial ligament, transverse humeral ligament, synovial seat around the tendon of biceps, tendon of long head of the biceps brachii, synovial membrane. The synovial membrane lies in the inner surface of the joint capsule and reflects from the glenoid labrum and humerus as far as the articular margin of the head. The synovial cavity of the joint presents the following features. The forms a tubular sheath around the long head of the biceps brachii and lies at the bicipital group of the humerus. It communicates with the subscapularis and infrascapularis bursa around the joint. There are opening of the tubercles of the humerus, passes tendons, long head of the biceps brachii and surround the head of the rotator bursa. The opening situated posteriorly on the communication between the synovial cavity of the inside of the bursa. Ligament of the shoulder, glenoid ligaments, coracoid ligaments, and accessory transverse humeral ligaments, transverse humeral ligaments, coracoacromial, coracohumeral ligament, and then glenohumeral ligaments, accessory ligaments, coracoacromial ligament, coracoacromial ligament, coracoacromial arch. Dorsal way to the joint. Relation of the shoulder joint. Deltoid subscale supraspinatus. And then nerve. The humerus scapula move a ratio of 2 to 3 during abduction. That every 15 degree elevation the humerus moves 10 degree and scapula moves 5 degree. The humerus moves 10 degree and the scapula moves 5 degree during early stages of the So flexion range of motion 90 degree, 45 degree, 55 degree. flexion, pectoralis major, and then anterior dislocation, posterior dislocation. So the actions: deltoid 50 to 90 degrees, abduction deltoid, flexion under deltoid, and then supraspinatus abduction arm carries up to 15 degrees, supraspinatus up to 15 degrees, and deltoid up to 15 to 90 degrees. And then subscapularis, injury of the axillary nerve, the risk of damage, dislocation shoulder joint, fracture surgical joint, because it's closer to the fractures. The damage presents clinical features, for example, impaired abduction of the shoulder due to paralysis of deltoid muscle, axillary nerve due to deltoid of the shoulders, loss of half of the deltoid region due to movement of the arm, loss of shoulder and wrist deltoid muscle.
There are two bones in the forearm, radius and ulna. The radius is the lateral bone of the forearm and homologous to the medial bone of the leg and the tibia. The radius is relatively short than ulna, but it is larger and weight-bearing bone of the forearm. The radius and ulna joined together by a fibrous interoserous membrane parts. The radius is a long bone consisting of three parts: upper end, shaft, and lower end. Upper end. The upper end presents head, neck, and radial tuberosity. The head is disc-shaped and articulates above with the capitulum and humerus. The neck is constricted part below the head. The radial tuberosity is just below the medial part of the neck. It has a smooth anterior part and rough posterior part. The long shaft extends between the upper and the lower end and presents a lateral convexity. The shaft extends from below the upper end and the lower end and presents a lateral convexity. It widens rapidly towards the distal and is concave anteriorly in the distal part. Concave anteriorly on the distal part. Its sharpest anteroserous border is located on the medial side, lower end. The lower end is the widest part and presents 5 surfaces. The lateral surface projects distally as the styloid process. The dorsal surface presents a palpable tubercle known as the Lister's tubercle, which is limited medially anatomical position and site determination. The site of the radius can be determined by keeping the bone vertically in such a way that the narrow disc-shaped head is directed upward. Disc-shaped head is directed upward. The sharpest border, interoserous border of the shaft, is kept medially. The styloid process at the lower end is directed laterally and prominent tubercle, Lister's tubercle, at the lower end faces dorsally. And the prominent tubercle, Lister's tubercle, is directed faces dorsally. The concavity of the shaft faces laterally. The concavity of the shaft faces laterally. The convexity of the shaft faces laterally, and the concavity anterior surface of the shaft faces anteriorly. Features and attachments. Upper end. It is shaped like a disc and covered with articular hyaline cartilage. It articulates superiorly with the capitulum to form the humeroradial articulation. The circumference of the head is smooth and articulates medially with the radial notch of the ulna, rest of it encircled by the ulnar ligament. Neck. It is constricted part below the head and is embraced by the lower part of the annular ligament. The quadrant ligament is attached to the medial side of the neck. The quadrant ligament is attached to the medial side of the neck. Quadrant ligament. The tuberosity. The biceps tendon is inserted on the rough posterior part. Small synovial bursa cover the smooth anterior part that separates it from the biceps tendon. Shaft. The shaft has three borders and three surfaces. Borders. Anterior border. The anterior border below the anterolateral part of radial tuberosity. Anteroradial part of radial tuberosity runs downward and laterally to the styloid process. The upper part of this border is called anterior oblique line. Anterior oblique line. The lower part of this sharp lateral border of the anterior surface. Its anterior oblique line gives origin to the radial head of the flexor digitorum superficialis. Flexor digitorum superficialis. The posterior border. It is well defined only in the middle third of the shaft. It is only defined on the middle third of the shaft. Above it runs upward medially to the radial tuberosity and forms the posterior oblique line. Anterior oblique line and the posterior oblique line. Medial border. The medial border is the sharpest border. It extends above up the radial tuberosity and below lower part forms the posterior margin of the small triangular area. Posterior part of the small posterior part and extends down radial tuberosity and below its lower part forms the posterior margin of the small triangular area of the medial side of the end of the bone. Small triangular and on the posterior side and on the posterior margin of the small triangular area on the medial side of the long end of the bone. Interoserous membrane is attached to the lower 3/4 surface. Anterior surface. It is concave line. Lies the anterior and the interoserous border. Anterior surface. On the anterior surface lies in the anterior and the interoserous borders. The flexor pollicis longus originates from the upper 2/4. The pronator quadratus is inserted on the lower border in the 1/4. Pronator quadratus. So the pronator quadratus on the lower 1/4 and flexor pollicis longus. A nutrient foramen is present. A nutrient foramen is present a little above the middle in the surface upper part. The nutrient canal is directed upward. The nutrient artery for the radius is a branch from the anterior interoserous artery. Posterior surface. It lies between the interoserous and the posterior borders. It lies in between the interoserous and the posterior borders. So anterior surface is between the anterior and the interoserous, and the posterior is the interoserous and the posterior borders. Abductor pollicis longus arises from the middle of the 1/3 of the shaft. Extensor pollicis brevis arises from the lower part of the surface. Lateral surface. The lateral surface lies between the anterior and the posterior borders. Supinator is inserted on the wider upper 1/3 of the surface. Supinator 1/3 of the surface.
pronator teres is inserted on the rough area in the most convex part of the surface. Rough area. Lower end. The lower end is the widest part and the bone has 5 surfaces. Anterior surface. The anterior surface presents a thick ridge on the that provides attachment to the palmar radiocarpal ligament of the wrist joint. Palmar radiocarpal ligament of the wrist joint. Posterior surface. The posterior surface presents the dorsal tubercle of the lister. Dorsal tubercle of the lister, lateral to the groove for the tendon of the extensor pollicis longus. Inferior surface. The inferior distal surface presents a lateral area for articulation with the scaphoid and medial quadrant area for articulation with the lateral part of the lunate. A lateral triangle for the scaphoid and the medial quadrangular area for the articulation with the lateral part of the lunate. Common fractures of the radius. The radius is a weight-bearing bone of the forearm. Hence, fractures of the radius are more common than those of ulna. Fractures of the head of the radius characteristically occurs due to the failing on the outstretched hand. The radial head is forced into the capitulum to fracture. In this fracture shaft of the radius. In the fracture shaft of the radius. Fracture head of the radius. With the fracture line below the insertion of the biceps. With the fracture line below the insertion of the biceps and above the insertion of the pronator teres. Above the insertion of the pronator teres. The upper fragment is supinated by the supinator and the lower fragment is pronated by the pronator teres. Lower fragment is pronated by the pronator teres and the upper fragment is supinated by the supinator and pronated by the pronator teres. Colles fracture. Fracture distal and end of the radius. It is the most common fracture of the radius, 90%. It occurs due to fall on the outstretched hands of elderly people due to osteoporosis. The distal fragment is displaced backward and upward. The wrist shows a typical dinner fork deformity. The reverse of Colles fracture called Smith's fracture due to the fall back of the hand and distal displacement of the anteriorly. So the displacement forward and backward and upward and then fall back to the hand due to the fall back of the hand distal fragment displacement anteriorly. So Colles fracture and Smith's fracture. Note 12. The radius is most commonly fractured bone in people over 50 years of age. It is often fractured as a result of fall on the outstretched hand. Fracture on the styloid process of the radius is termed Coffer's fracture. Ossification. The radius ossifies from the following 3 centers. 1. Primary center appears in the middle shaft during 8th week of uterine life. 2. Secondary centers on each end. Center for lower and age of the first year for the lower end appears at the age of first year. The center for the upper end appears during the 5th year. So first year and 5th year. The upper epiphysis fused at the age of 12 years. The lower epiphysis fused at the age of 20 years. So 5 years and first year. 12 years and 20 years. Clinical correlation. Madelung deformity. It is a congenital anomaly of the radius that presents the following clinical features. The anterior bowing of the distal end and radius due to abnormal growth of distal epiphysis. It occurs between 10 to 14 years of age. There is premature displacement of the distal epiphyseal seal. There may be subaxillary or
dislocation of the distal and end of the ulna due to the defective development of distal radius epiphysis. It is a congenital anomaly, Madelung deformity. Madelung deformity. It is a congenital anomaly of the radius that appears the following clinical features. The anterior bowing of the distal end of the radius due to abnormal growth of distal epiphysis. Defective distal epiphysis. Development of distal epiphysis.
The ulna is the medial bone of the forearm. It is homologous with the lateral bone of the leg fibula. It's thin and longer than radius and lies parallel to it. The ulna acts as a stabilizing bone with the radius, providing pivoting to produce movement. It has upper extended end which process a large notch and a narrow rounded lower end. Its bone looks like a pipe branch. Parts. The ulna is a long bone and consists of three parts: upper end, lower end, shaft. Upper end, lower end, and shaft. The upper end is expanded and hooked like with the concavity of the hook facing forward. The concavity of the upper end trochlear notch lies between the large olecranon process. The concavity of the upper end trochlear notch lies in between the olecranon process above and the small coronoid process. Olecranon process above and the large coronoid process. Olecranon and coronoid process. The shaft is the long distance between the upper and the lower edge. Its thickness diminishes progressively. From the above downwards through its length. The lateral border interosseous border is sharp crest line. The lower end is slightly rounded and called the head. A small bony projection from distal end of the ulna is called the styloid process. The styloid process is the posteromedial to the head. The ulna is the medial bone of the forearm, which is homologous to the lateral bone of the leg in fibula. It is thin and longer than the radius and lies parallel to it. The ulna acts as a stabilizing bone with the radius providing to produce movement. It has upper extended end and possesses a large notch and narrow rounded lower end. So this bone looks like a pipe wrench. The ulna is a long bone consists of three parts: upper, lower, and shaft. Upper end. The upper end is extended and hook-like with the concavity of the hook facing forward. The concavity of the upper end trochlear notch lies between the large olecranon process and the small coronoid process. The long shaft extends between the upper and the lower ends. The thickness diminishes progressively from above downward through its length. The lateral border, interosseous border, is the sharpest crest line. The lower border end is slightly rounded and called head. A small bony projection called distal end of the ulna is called styloid process. The styloid process.